See, it got silent even before I said, let's all take our seats. Let's have the Commissioner of Mental Health join us at the front table. And I will do one quick text while she's moving. All right. Good morning, everyone. And we're good on seating. Um, Just, just a quick update and reminder as we get started. Hi, I'm Liz Kruger, Senate Finance Chair, joined my no longer new colleague, the no longer new Ways and Means Chair, Gary Pretlow, because we've already survived X number of hearings. So just the same old Ways and Means Chair, Gary Pretlow. So today is the hearing on mental health and Office of People Developmental Disabilities and Office of Addiction Services and Supports, and the Justice Center for the Protection of People with Special Needs. Just some basic rules for people who may not come to all of our hearings. When you are testifying or asking questions, you need to speak into the mic, and it only works when you press the push button and it goes from red to green. And there's a little trick with them. You have the sweet spot just above the word push. So some people struggle to get it to work, including me, but just know when it's green, you're on. When it's red, you're not. Also, both for testifiers and for legislators asking questions, there are clocks that all of us can see, and commissioners and other invited government guests get 10 minutes each to testify. Everyone else gets 3 minutes to testify. We tell everyone, you may have 30 pages worth of testimony. You've submitted it. We all have it. It's up online for the whole public to read. But the best testifiers are people who bullet point their most important issues, because you're not going to have enough time to get through everything. For people asking you questions, that clock means it's the time for you to ask the question and get the answers. So some of our colleagues enjoy doing a very broad opening statement and a very extended question, and then are shocked when the bell goes off that they're done, and they assume then somebody is going to answer them. They're not, because your time is up. So just remember, if the clock says X amount of time, that's for both of you. And I know it's not enough time, and we haven't just mastered 24-hour hearings, and I'm not sure any of us want to. Also, if you're a chair, for addressing the commissioners, and there's 4 different ones today, chairs of the relevant committees get 10 minutes, rankers get 5 minutes, everyone else gets 3 minutes. Only chairs get a 3-minute at the very end follow-up if they have additional questions to ask. Okay, that's, I think, mostly the rules of the road. So I'm now going to officially do the opening of this actual hearing. So good morning. You already know I'm Liz Kruger, Chair of Senate Finance, and the Senate is chairing today's hearing. The Assembly and the Senate take turns. Today is the 5th of the 14 hearings to be conducted by the joint fiscal committees of the legislature regarding the governor's proposed budget for state fiscal year 24-25. These hearings are conducted pursuant to the New York State Constitution and legislative law. Today, the Senate Finance Committee and Assembly Ways and Means Committee will hear testimony concerning the governor's proposed budget for the following agencies: Office of Mental Health, Office of People with Developmental Disabilities, Office of Addiction Services and Supports, and the Justice Center for the Protection of People with Special Needs. As I've described, following each testimony, there will be some time for questions from the chairs of the fiscal committees and other legislative members of the committees. I will now introduce members of the Senate. Assembly Member Gary Pretlow, Chair of Ways and Means, will introduce members of the Assembly. And then Senator Tom O'Mara, who is actually ably represented by the lovely not Tom O'Mara, and Senator and Assemblymember Ra from the Assembly Republicans. I just want to make sure I have the list of all the Senate Democrats so far. Oh, and during the course of the day, because people have session, they have committee meetings, you'll see legislators come and go, and we will introduce them as they show up. And for all of my legislative colleagues, if you want to ask questions, then you need to let the four of us, chairs or rankers, let us know so you go on a master list, because sometimes it's many, many people, and they'll be thinking, why didn't you know I wanted to ask a question? And the answer will be, because you never told us you wanted to ask a question. So please remember, colleagues, to do so. So the senators who are here today so far are Senator Bino, our new senator, Senator Webb, Senator Fernandez, and Senator Brook, Assembly member.
Well, thank you, Senator. With us today, we have the Chair of Mental Health, Assemblywoman Simon. We have the Chair of Alcoholism, Assemblyman Steck, and the Disabilities Chair, Assemblyman Santa Barbara. Also with us, we have Assembly people Anderson, Braunstein, Burdick, Eckes, Epstein, Otis, and Tappis.
And from the Republican Senate, Senator Canzoneri Fitzpatrick. I never mean to disrupt you.
That's okay. It's
And
a
she's
mouthful.
also the ranker on the Mental Health Committee.
Thank you, Chair. I'm honored to introduce my colleagues from the Republican Senate, Senator Oberacker, Senator Rollison, and Senator Weber.
Assembly.
Assemblyman Ra.
Morning. We are currently joined by Assemblyman Semplowinski, who is our ranker on mental health, Assemblyman Keith Brown, our ranker on alcoholism, and Assemblymember Marr.
Okay. Well then, good morning, Commissioner Sullivan. Nice to see you here today. And you have 10 minutes to present.
Thank you. Good morning. Okay, good morning, Chairs. Oops. Good morning, Chairs Kruger, Pretlow, Brook, Simon, and members of their respective committees. I want to thank you for the invitation to address Governor Hochul's fiscal year 2026 executive budget as it relates to mental health. I am happy to report that the governor's proposed budget continues to emphasize the importance of building a comprehensive mental health system that provides New Yorkers with robust prevention services, increased access to treatment, and a vital safety net for those with high needs who have been unable to effectively engage in treatment on their own. Since taking office, Governor Hochul, in partnership with the legislature, has made historic new investments in the mental health system, and the Office of Mental Health has been diligently working with counties across the state to implement these programs in a manner that meets the needs of local communities. To date, we have generated more than 780 contracts, funded more than 690 providers. And to ensure the success of these programs, Governor Hochul provides a targeted inflationary increase of 2.1%, building on investments from previous years. The executive budget provides for investments across the lifespan, with an emphasis on recovery and community-based wellness, as well as additional intensive services for high-need individuals. Providing for early access to care is at the core of mental wellness, and the Office of Mental Health continues to grow services. Across the lifespan, this year's executive budget proposes the inclusion of $1.5 million to integrate behavioral health in OBGYN offices in underserved communities to improve maternal mental health, providing for vital screenings and access to treatment. We know that treating maternal depression is critical to the successful growth of our youngest New Yorkers. Governor Hochul is continuing her commitment to youth mental health by including $1.5 million to expand teen mental health first aid, which is specifically designed to teach teens grades 9 to 12 how to help each other respond to mental health challenges. During the governor's youth listening tour in 2023, young people repeatedly emphasized that they often first talk to their friends and that when they are experiencing mental health concerns, and that they don't always know how to respond. Additionally, funding for youth safe spaces, which are clubhouses where young people can access mental and behavioral health wellness resources, foster positive relationships, and engage in positive activities, further strengthens their ability to help each other. For those children and adolescents whose complex needs require special assessment and care, the proposed budget includes $1 million to create comprehensive clinical assessment hubs for evaluation and linkages to the array of services needed. There is also an amendment to the mental hygiene law, which will allow runaway homeless youth who are already authorized to consent to their own physical health services to also consent to inpatient and outpatient behavioral health services without parental consent. This change will help avoid delays in accessing essential behavioral health care and ensure that vulnerable minors receive timely treatment and support. For adult New Yorkers, this year's proposed budget provides for the development of clubhouses, which are programs designed to assist individuals living with mental illness with the establishment of friendships, recreational activities, and educational and vocational opportunities. The National Alliance on Mental Illness describes the term recovery as reaching a place where you are able to pursue a safe, dignified, and meaningful life. Governor Hochul and the Office of Mental Health are committed to assisting individuals with mental health challenges to reach that place. Additionally, by working with local communities to develop culturally appropriate care, we are more successful in engaging diverse populations in mental wellness activities. The executive budget includes $2 million to support community-determined wellness in historically marginalized neighborhoods, which can help us towards reaching all New Yorkers with prevention services. Utilizing peers who have the unique perspective of living with mental health challenges has proven to be highly effective in engaging high-need individuals with whom traditional services have had little success. $4 million is proposed for hospital-based peer bridges services and for the expansion of intensive and sustained engagement teams to work with individuals to secure their success in the community, prevent hospitalizations and emergency room visits. Ensuring that services are across the lifespan, the recovery journey requires us to make adjustments as people enter different stages of life. This year's budget provides $1.6 million to create a pilot aging in place program for OMH licensed residential units, allowing individuals to continue to receive optimum services and support in their own homes as they grow older. Our highest need New Yorkers require specialized, intensive, and innovative approaches to engage them in services. Governor Hochul launched the Safe Options Support Initiative in January of 2022. These teams, initially working with unsheltered individuals in the subways of New York City, have expanded to Long Island and upstate communities. There are currently 27 SOS teams who have conducted more than 67,000 encounters, successfully housed 884 individuals previously unsheltered, often for many years, in permanent housing. Additionally, teams have helped facilitate over 2,600 shelter placements in New York City. They have also initiated 875 voluntary referrals to hospital emergency rooms, both for medical and psychiatric services. In this year's budget, it includes over $12 million to enhance these special services for these high-need individuals. Funding will be available to add street medicine and street psychiatry to the SOS teams, as well as additional funding for OASIS street outreach teams to integrate substance use services. For mobile outreach teams, proposed funding would also establish welcome centers in 5 subway stations, allowing for a private space to speak with outreach workers. Beyond the data, it is an individual's life change that is so important. A woman who was unsheltered and living in the subway for many years, after working with her SOS team, not only accessed permanent housing, but reconnected with her worried sister, who had been searching for her for years. We will always make every effort to work with and engage individuals in need of services in their communities. Since 2023, with the over $2 billion investment in mental health, we are significantly expanding the ability of outpatient services throughout our system, including ways to effectively connect individuals to services upon discharge from the hospital. But sometimes, for people living with mental illness, due to their illness, they are unable to engage in community mental health services, despite being at extremely great risk for their personal safety. This year, we are proposing a clarifying amendment to the involuntary inpatient commitment criteria to include individuals at substantial risk of harm due to an inability or refusal as a result of their mental illness to provide for their essential needs, such as food, clothing, medical care, safety, or shelter. In addition, the executive budget applies for a new $16.5 million to the Assisted Outpatient Treatment Program for counties to increase efforts to work with individuals on a voluntary basis while also providing support for local oversight, and $2 million for additional staff at OMH to better support the counties, enhance state oversight, and enable increased use of voluntary AOT throughout the state. There are also proposed changes to the mental hygiene law to clarify AOT criteria and provide petitioners with better guidance on when an AOT petition can be filed within 6 months of an expired AOT court order. Finally, this budget specifically increases services in 2 additional key areas. It proposes funding for the much-needed update to the crisis unit of the Capital District Psychiatric Center and expansion of its mobile integration team, providing ready access to crisis services in the capital area. And the executive budget also provides $160 million in capital for an increase of 100 psychiatric forensic inpatient beds on Wards Island in New York City to address the increasing need for restoration services to ensure that individuals can participate in their court processes in a timely manner. Lastly, the budget also provides $21 million for OMH to increase clinical and direct care staffing at its 4 forensic facilities to reduce staff to patient ratios, improving safety and quality of care. Again, thank you for the opportunity to testify on the executive budget, and I'm happy to answer any questions you may have.
Thank you very much. We've also been joined by Senator Persaud, and our first senator questioning will be Senator Brooke, the chair of the Mental Health Committee.
Thank you. Good morning, Commissioner. Thank you for your testimony, and thank you for everything you do every day for New Yorkers. It's really an honor to be able to work with you. I want to jump right in because I think that there's a lot. Obviously, we're very grateful to you and the governor for putting such a heavy focus on mental health, the entire continuum of care. We know that we can't solve it by just looking at one part of mental health, so from prevention all the way to crisis. I think there's still a lot of work we need to do. I want to start with your work on the Daniels Law Task Force this year. To your knowledge, in this executive budget, were any of the recommendations that came out of the report, which came out a year early, so that was December 2024, were there any of the recommendations from the Daniels Law Task Force included in this year's budget?
The Daniels Law Task Force, which I think did an excellent job of bringing together stakeholders, coming up with recommendations for policymakers to look at what should the emergency response for mental health crisis look like in New York State. So those recommendations are there. They're a tremendous resource for policymakers, and it's up to policymakers to decide which of those recommendations they may want to move forward.
Okay, so just so that we all know, there were these 2 major recommendations: establishing a defined response protocol for behavioral health crisis, and then creating a statewide behavioral health crisis technical assistance center, which I thought was it could be tremendous value, and I was glad to see it come out of the recommendations. So I guess my question is, if we were to move forward with those recommendations in this year's budget, is OMH in a position, if funding were to come through this budget, to start creating this technical assistance center and actually start the process of these Daniels Law pilots as it recommends in the report?
We have a pretty robust, at the current time, we have mobile crisis teams in all of our counties. We have the 988 answering center, we have crisis residences, and we have an increase in crisis stabilization centers over the next few years. So we have a crisis system, which we have been working with now for many years to establish across the state. So I think the issue of a technical assistance center is something that, again, is a recommendation in the report, and again, for policymakers to decide if that's something that they would want to enhance. It's up to the policymakers.
Okay, so in other words, are you saying you may have the capacity at OMH now to administer some of these recommendations?
It would depend on the other. It would depend on the other recommendations that are accepted. So what would be available currently, and then what we would need in addition if they were accepted.
Okay, thank you. I want to move on to some of the changes that were in the executive's budget that you mentioned around AOT and how those are implemented. So the first thing I was curious about is, we know that there's a study, I think, that's going through OMH. I think it's been contracted out. And that study is due in 2026. Is that correct?
Yes.
So have we learned anything in the interim while this study is going around, what the efficacy has been like, what the impact has been of AOT orders statewide?
We haven't yet received anything from the group that's doing the study. They have all the data, and they are compiling it at this point. They will be on time to deliver it next year, but we haven't received anything from them yet. What we do know from our outcomes that we look at is that AOT decreases incarcerations, it decreases hospitalizations, it decreases episodes of violence. So that's our determinations as we have looked at AOT, but from the researchers, we're still waiting to hear from them, and they have not yet given us any information on what they're looking at. They're doing a qualitative and a quantitative analysis.
So then my next question would be, I know you were, and I know it was the task force that you were in charge of chairing, and this is different, it's a study that's being done externally, but do you think that there's an opportunity to get any of that information earlier than 2026? And I ask because in this executive proposal, there are a number of changes to AOT, and it seems somewhat premature to be moving forward with changes to something that we have put $1 million towards studying, and so maybe there's a way that we can still do the study with integrity, but to get some answers of what these researchers are seeing so that we can make more data-driven, evidence-based decisions on how we might make changes.
I think we can ask. However, our conversations so far with the researchers, I don't think that they are able to give us too much of the results of their data analysis yet. But we can certainly ask if they have anything that they could share.
Okay, thank you. And then you talked about there's a total of $18.5 million going towards AOT orders. It sounds like $2 million of that is for OMH staff. What do you anticipate the $16.5 million going towards exactly?
There's a good part of that is going to go towards expanding the use of voluntary AOT. One of the difficulties with using as much voluntary AOT has been not having the degree of care coordination, care oversight, making sure that all the services are there, that the individual is getting everything they need. So we think may have, since that isn't there, we haven't been using the voluntary as much as we could. So those dollars will be going to the counties to increase the voluntary, but also to help them with some of the ongoing services they are providing for individuals on AOT.
Okay.
Voluntary AOT could really provide excellent services as well with the right supervision.
And so just so to make it very clear, this could actually go to someone who's voluntarily choosing to enter this program and get services that they may not be able to get right now.
Yes, yes. Voluntarily with a high priority for the services so they can get them, but continue the same degree of support that you would get if you actually had an AOT order.
Wonderful. And then I'll use my last few minutes. You know, I don't think it was in this testimony, but obviously in the executive budget, there are changes, pretty big changes to the involuntary commitment and how we would do that here in New York State. You know, civil rights lawyers, peers, community members, a lot of people are talking about how there is fear that, you know, the new standard is essentially saying that anyone who may be unhoused, whether or not they may have on and off employment or it might be temporary unhousing, now could be at risk of involuntary commitment. How do you think we avoid this from being a sweeping change so that we are essentially saying homelessness now equals you could be involuntarily committed?
Let me be very clear. In no way does homelessness equal involuntary commitment. And this is a very small, select group of individuals who are at very substantial risk to physical harm because they are unable to take care of their daily needs. So we're talking about an individual who, for example, really is out in the freezing cold and is not adequately dressed at all and is a danger of frostbite. We are talking about an individual who has severe cellulitis that could lead to serious medical problems, that has no understanding of what it is because of their mental illness. We are talking about individuals with very serious physical problems, their inability to take care of themselves. It's a very small percentage. Clearly, making these decisions is very difficult. You have to be extremely careful about ever committing anyone to a psychiatric facility involuntarily. All this does is clarify what has been present in case law before, that individuals at this degree of substantial risk can also be involuntarily committed. It also exists in case law, but by clarifying it, you help individuals who make these difficult but important decisions know better how to make those decisions.
Thank you. And so I want to switch quickly to the incident review panels that are, has any locality ever requested to have a review panel when we hear about all these instances, right? Horrific incidents. You know, and, you know, we hear certain things in whatever headline, but rarely do we hear the information really behind it and the investigation that goes into it. I know that there is an ability to do incident review panels when there is someone with a mental illness who, has created physical harm to themselves or others, but it has to be a locality that is requesting it. For example, has New York City or any locality ever requested that there be a review panel to really dig into what's happening?
We've never had the formal incident review panel that is described in the legislation. However, every time there's an incident, there's a tremendous amount of review that goes on, both within the Office of Mental Health and any other agencies that are involved.
sorry, not to cut
So that's
you off,
going on. It's not in the formal
Right.
incident review panel.
Why not do the formal? And we have that option to do it. Do you think we could maybe learn more about how to better serve those who are severely mentally ill? And I always have to remind folks, by and large, right, they're actually victims of they are victims and they are not the perpetrators of violence. And so we want to be careful. Again, this is a very small number of folks, but do you think we might be able to learn more and do better to serve them and create better safety in our subways and beyond if we were to do those?
I think you can always do a good review, and we do good reviews, and we learn all the time from what we review. I think incident review panels we have not used yet. It's something to look into.
Thank you, Commissioner.
Thank you.
Thank you, Assembly.
Assemblywoman Simon? 10 minutes?
Thank you. And thank you, Commissioner, for your testimony and for all of your work in this area. I have a few additional questions to follow through on what Senator Brooke asked. A couple of things that strike me is, for example, the incident review teams, right? Incident review panels that have not been engaged in a formal way. What, in your mind, what kind of support from the state or funding from the state would be helpful to really encourage that kind of review in a formal way so that we actually had information from which we could make informed policy decisions?
I think that the ability to do such a review panel is there. I think that the question is when you would call it, what localities would want to do, and I really do have to keep emphasizing that it's not that these reviews have not been seriously looked at. So much of the information behind what has happened is confidential, but then the outcome of looking at those reviews certainly influences the services we put up. The outcome of all the reviews of these incidents have led to developing things like INSET teams for individuals have led to the CTI programs that we're putting forward. So I don't want people to think that the reviews that we've been doing haven't been substantial and haven't been informing the whole array of services that we are putting up to work with individuals with serious mental illness.
Okay, thank you. I have another question about a population I think is of concern. One is, it's a question on managed care. As you know, the outpatient behavioral substance abuse services were carved into Medicaid managed care about a decade ago. And later on now, they're not actually managing the care, that there's no real benefit to that care provided to the patients that comes out of that carve-in to Medicaid managed care. And there are like 16 plans that are for-profit corporations that are profiting off of this, but not actually contributing to the management of that care. And so the organizations, the providers that are providing this care are at a breaking point because they're spending more time doing the administrative work for something that actually is yielding no savings to the state or any benefit to the people that they're serving. One of the providers had to hire 4 people just to do the administrative work. Those are dollars that could be used to take care of people. So I want to know if you can work with us to carve these outpatient services out of managed care, which would actually save us over $400 million to New York State.
We work very closely with the Department of Health, and the Department of Health ultimately manages the benefits of the organization of how payments are made to managed care. We work very closely with them and with the managed care organizations to ensure that the appropriate amount of dollars are spent on mental health services, and that managed care organizations work cooperatively with our providers. The question of a carve-out, I think, is a big question and really has to be discussed additionally with the Department of Health.
Because I'm concerned because they're not processing payments in a timely manner, which is harming the ability for people to keep their organizations going, and these are vulnerable people. It's
We
mostly Medicaid.
we do monitor the timely payments, and there have been citations to managed care organizations for not providing timely payments. The timely payments of many of them have gotten better because of the oversight and the enforcement, and there have also been fines when managed care companies have not provided appropriate response to parity, and parity includes timely payments.
Thank you. I have a couple of other questions. One question has to do with the governor's proposal to expand support for the Empire State Supported Housing Initiative program, which is a good program, but in the meantime, there is also the community residents, SRO providers, who are getting much less money per unit and are still functioning and provide good support, which doesn't seem to make a lot of sense in the dollars and cents, and also provision of care. So, I want to know what plans you or the governor have to support the CRSROs at a level above, or at least consistent with the amount of money that is committed to the SG programs.
Now, over time, there has been a significant investment in housing, and those supportive dollars have gone up. But yes, this year in the budget is for new Ishai housing, the increase. But there has been over $350 million invested in housing over the past 4 years overall, with lots of increases to housing providers for stipends to do the work they need to do.
Yeah, but these other people aren't getting the same amount of money,
No, they
right?
are not at
And
this
so they're still providing housing. They still have the same costs. They have a population that has significant needs. So the question is beefing that up. How can we beef that up is really the question. And then the other question is what additional funding is going to be provided to residential programs so they can serve not just the current residents, but the needs of people who are under this AOT. I think one of the confusions people have is the sort of voluntary AOT, which is actually available through many other programs as well, providing the same kinds of supports, which is different than something that's involuntary, which has other ramifications, obviously.
Yeah, so basically, yes, the funding for individuals, AOT for voluntary involvement will be the same. Yes, I'm not sure of your question.
Well, it seems to me that you have residential programs that some of them are based in a residential facility that might help somebody with outpatient, right? But also, we've made a proposal to expand the use of involuntary commitment, for which there are a number of concerns, including importing a definition from retention of people who are currently hospitalized to people who are not yet and not even evaluated. But if that were to occur, you would increase the number of people who are involuntarily hospitalized, and we have a lack of beds. Where is the money to support the natural consequence of such a proposed expansion?
Expansion or involuntary
If
commitment
you have more
to hospital
people
beds. I'm just
involuntarily
trying to-
hospitalized,
Yes.
where are you going to put them?
Currently, in New York State, the occupancy of our psychiatric services is about 80 to 82% adult,
Yeah.
not 95%. So there's room within the community-based hospital system for the small increase in individuals for the change in the involuntary commitment law. After the pandemic, the occupancy was 95%. And that's why additional beds have been added in the community. But at the current time, across the state, the occupancy is between 80 to 83%, which means there is sufficient space to expand. However, the involuntary commitment law, which we are expanding, is for a very small number of individuals. This will not have a tremendously significant impact on hospital occupancy.
So a sort of follow-up question to that is, we just recently had a report issued in New York City under the mayor's change sort of standards, and it would bring people into the hospitals. Almost 50% of them were not retained, which meant that they were probably not a danger to themselves or others, and they were evaluated by competent people who do this kind of work. But 52% of them, I think, were retained. And one of the big challenges, and we hear this with the cycling of people out, Daniel Prude was somebody who wasn't retained, that there's not enough availability of those beds. And I know the psych beds in the private hospitals have not been restored fully. In some cases, yes, but not fully restored from COVID, but there was also a loss of beds previous to that. And so this is a very real concern about the feasibility of ever even implementing what it is that is currently being proposed. And so that's why I asked that question. I think that's a very real concern that people have, and there doesn't seem to be any dollars given to actually making that happen.
There were capital dollars last year for expansion of beds, and there will be 100 additional community-based beds that will open. But the important thing here is occupancy is something we track very, very closely. So if you were at an 80% occupancy, that means that you have space to be admitting individuals into the services. The other critical point are the services when that 50% that you said came into the emergency room are discharged. And that's where the growth of critical time intervention teams and all the other services we're putting up will affect that revolving door of people coming back.
Transition, yes, they need it. Thank you.
Next for the Senate, the ranker, Kanzaneri Fitzpatrick.
Morning. Thank you so much for being here today. I have sort of a general overview question. As was stated previously by Senator Brooke, we have an issue with so many people being arrested that are committing crimes that are truly have mental health issues or addiction issues. Where in this budget are we providing that those people will get services instead of just being thrown into a system where their issue is not properly addressed? I'd like to know where in this budget are we going to do better in the next session for those people that need those services?
I think it's important to look at the budgets for the past several years, the services that are coming up now. There's a significant increase in teams that will be working with exactly the individuals that you're talking about, critical time intervention teams, assertive community treatment teams. Those were in the $1 billion budget. They are now hitting the streets in the next year. You will begin to see these teams available. In addition, last year's budget had something called court navigators, who are going to be distributed across the state to work actually in the courtroom when individuals come before the judge to help connect them to services.
And
So
is
the
that budget
entire-
being increased, excuse me, is that budget being increased so those court navigators, there's more of them, or there's more time for them? Because we have a system that is obviously not addressing everybody's needs, and unless we put more of those people out there, it's not going to help every person that needs it. So my question is, are we increasing those services?
Well, those services, those court navigators will become available as of January of this year. So I think we need a little time to see exactly how effective they are. But there's a significant increase. It was $8 million to put court navigators across the state.
Okay. Switching to our COLA increase, I learned through discussions with many people that the COLA increase previously applied in previous budgets did not typically provide for supervisors and other people to also get increases. And I'd like to know if you had questions, pushback, administrative issues with applying that COLA increase equitably over all of the people working in the agencies.
The particular increase which we're doing this year will be dollars going to the agencies, and they will decide how to use them. Last year, there was a segregation of some of the dollars that had to go to direct care staff. This year, the targeted inflationary increase that we are proposing is general.
Okay. And as I understand it, the budget includes a 2.1% inflationary increase when inflation was actually 2.9%. So why are we not at least meeting inflation? And are we going to have issues going forward for letting these vulnerable care workers making sure that they can make ends meet to continue the care that they do, because we hear over and over and over again about the fact that they can't afford to stay in these positions, that they can't make their own salary go as far as they want to, and they're taking care of our most vulnerable. Why aren't we doing better for them?
Well, the budget allocates the 2.1%, but it is important to remember that over the past 3 years, there's been out an additional 13% that came through other forms of COLA. So this year's allocation is 2.1%.
I mean, from what I could see, a 7.8% COLA would be more appropriate to get us back on track. But I realize that we live within a budget, but we have to take care of these individuals, in my opinion. I'd like to just switch, because I only have another minute left, and ask you about the $10 million for the expansion of clubhouses and youth safe spaces. I think it's great. I think we have to focus on youth mental health. Very, very critical. Where will these new safe spaces be throughout the state?
We will be putting out an RFP and looking for individuals who are interested in doing it. It will be a break between upstate and downstate for the youth safe spaces. Probably, we're expecting from this budget, I think, about 36 youth safe spaces, which we'll be able to put up, and we'll put out an RFP across the state.
But you don't have a guide as to where they're going to be?
We're probably going to try to do one, which we usually try to do in each of the regions, but it will depend. We're looking at it closely.
Okay, and how will these safe spaces coordinate with existing school-based community health programs? Is there going to be a synergy so that we have efficiencies?
Yes, absolutely. I mean, that's so important, as you say. So there'll be synergies with the school-based programs and with the providers in the communities. So the safe spaces will be a place for youth to get all those resources.
Thank you.
Before we go on, we've been joined by Assembly Members Berger, Chandler Waterman, Gallagher, and Simone. Next for questioning, 5 minutes for Assembly Member Simplewinski.
Commissioner, thank you so much for coming, and thank you for your work helping those with mental illness in the state of New York. I've got 3 things I want to cover, so I'm going to try and move quick in the 5 minutes that I have. My first would be sort of an expansion of the question my counterpart, the ranking member from the Senate, was asking about the COLA, or now targeted inflationary increase, I think is the new nomenclature. If this is designed, as was pointed out, to match inflationary pressures, why every year do we have from the executive either no COLA or no TII, or something that's substantially less than what the inflationary rate is? Why don't we start at the inflation rate where people can at least then stay where they're at from the previous year?
Just to reiterate, that it's 2.1% in the budget, but there have been consistent COLAs with this administration, which were not there before, which is partly why we're in the place we're in. But there have been consistent COLAs over the past 4 years.
Yeah, but oftentimes those COLAs don't, we get a COLA, but it doesn't match what actual inflation is, so then it's not really a COLA, it's really a practical cut. So what I'm saying is, why don't we start with inflation, especially considering the return on investment that we get investing in all of the mental hygiene agencies. If we're getting folks the salaries and the resources they need to provide these services across all of the agencies we're going to hear from today, we have a substantial savings on the back end in other services that we don't have to provide. So I'm just saying, why don't we just start with inflation every year?
Well, the amount that's allocated in the budget for it is $68 million, I think, and $8 million for minimum wage increase. So that's 2.1%.
I appreciate your answer. Second, I want to highlight and actually indicate my support broadly for the changes to involuntary commitment. I understand some of the concerns that we don't want to have this expand into something where somebody who shouldn't be involuntarily committed ends up being involuntarily committed. I think that's a legitimate concern, but I would just highlight from my position that allowing somebody who is at a substantial risk of physical harm to themselves to continue to be out on the street fending for themselves is not compassion. So the idea of expanding this to enable more services to be provided to people, I think is a good thing. Not to mention the benefits and public safety to both themselves and the broader public. What would be the particular changes for an individual going through that process as we shift from likelihood to result in serious harm to substantial risk of physical harm. What would be different for the person going through the involuntary commitment process?
Well, the difference, I think, once the person is committed to the hospital, then all the services become available. And I think that's what's really important. Get a good evaluation, get physical health as well as mental health. And then when you're discharged, you will have a significant wraparound services and assistance in getting housing, because many of these individuals aren't housed, but if they are housed, significant wraparound services. So what you now provide is the real treatment someone needs so they can make decisions more clearly about their own physical health and physical safety. That's the addition of the law, that now they could be able to decide and move forward in their lives.
I appreciate it, and I appreciate the change. I think we're going to actually really help some folks and get them the help that they need and truly be compassionate to them. My last thing I want to point out, later on in the day, we're going to have a constituent from my friend Mr. Palmisano's district from Sioux County. I also live in Sioux County, Mr. Tobia, testify, and he's going to talk about a very tragic situation regarding suicide in his family. And his support, there was legislation that passed unanimously through the legislature, reached the governor's desk to provide for a rural suicide prevention council in the previous legislature, along with a lot of these other councils. The governor vetoed that bill and indicated in her veto message that she would prefer this sort of thing to happen through the budgetary process. So I wanted to indicate certainly my support for that. I represent an extraordinarily rural district. And oftentimes, one of the challenges that we have is just making sure that the services that your department provides and the other departments under mental hygiene provide get out into those rural areas. So I just wanted to voice my support for what he's going to testify on, and I think Mr. Palmisano will expand on that in his questioning. But thank you very much.
Thank you.
Sorry. Then our next is Senator Natalia Fernandez, but before she starts, we've also been joined by Senator Tom O'Mara, ranker for Finance. And just to clarify, the people who are chairs and rankers on the 4 different committees that are relevant to the first 4 government panelists today, they each get 10 minutes for each, or 10 minutes or 5 minutes for each. So Senator Fernandez will get 10 minutes. Her ranker will get 5 minutes. But that also applies then to the same group getting time with the OASIS and people with developmental disabilities and Justice Center, just because so much of this work overlaps in relationship to each other. So just wanted to make sure everyone understood, and the clock is at 10 minutes. Senator Fernandez.
Thank you so much, Commissioner. Thank you for the 10 minutes. The executive budget you mentioned has $8.5 million for clubhouses. I know how crucial and important they are to helping those with mental illness, but will these funds also be equipped to help those with co-occurring disorders and substance use disorder?
Yes, all the clubhouses have integrated treatment. They will all have integrated treatment, so they will be available, absolutely, for individuals who have mental illness and substance use problems, for sure.
Great. The executive budget also includes $1.9 million for historically marginalized communities. What criteria will be used to determine which neighborhoods qualify as marginalized?
Well, we're going to be looking at data across the state, which will tell us which areas are particularly underserved in terms of mental health services. So we do that usually when we send out the RFPs. We will also do some talking with communities as to whether or not they feel that they are getting all the services they need. These dollars are particularly for more what we call kind of grassroots organizations, so that they can try to provide outreach in the community. They're usually made up of community members who provide services, screenings, and also work with communities on wellness activities. So it's very exciting to have these dollars, which will really embed in the community with community workers. And this has been being asked for a long time from some of the grassroots providers across the state, and now this is actually in the budget, so it's very exciting.
Thank you. It's been mentioned here before, co-occurring disorders, like I just said, but have you been working, and if so, how have we been working with the Office of OASIS and Commissioner Cunningham on the issue of co-occurring disorders and dual licensing?
Yeah, we've worked all the time on the issue of co-occurring disorders. It's embedded in what we're doing in prevention. It's embedded in all the new services that we're putting up. We've been working closely with OASIS to ensure that there's integrated treatment there, especially harm reduction. and making sure that it is throughout the system. On the licensing part, we will be having new regs coming out, I believe, in a month or two to the Behavioral Health Services Council to look at how we can make it easier to have integrated care throughout the system. And then finally, there will be in July some regs for the very highest tier to working together of integrated care. So we're trying to make it easier. We know from the providers that it sometimes has been cumbersome, the way we had set up the licensing, but working very closely with OASIS. And I think there's going to be a lot of, and with the community to understand how to make that easier. That will be coming out within the next few months.
Okay, I have a bill to make it a little easier. That would remove copays for integrated care. So we would love the support on that. With the potential increase of patients due to possible changes in involuntary commitment and assisted outpatient treatment, what are plans in place to ensure that these individuals have the resources and supports they need after they're released from confinement?
Yeah, I think that's the most critical point. One of the things you have to ensure is those individuals get the services they need. So we are going to have a program with all the hospitals where what we call critical time intervention teams will wrap services around those individuals for up to a year or more until they are stable in getting services, stable in their housing, stable in their treatment. So this is very exciting. We're also growing peer programs that will work with individuals when they leave hospitals. And we're going to make sure the hospitals work with us, with the community-based providers, to have really comprehensive discharge plans. We have not been as successful at doing that in the past, and the Hospital Connections program will ensure that. So the critical thing is to get those services to those individuals.
Okay, in my district in the Northeast Bronx, I have Bronx State Psychiatric Center. There's been a few buildings there that have been vacant for years. Is there any plans to reutilize these buildings now with, I know that the mayor's office has mentioned $600 million to help with continual mental health care given involuntary removal changes. Is there any plans to utilize Bronx State Psychiatric and put more beds there, fill up the buildings that we have? Could you speak on
The
that?
one building that is particularly vacant is something which will be opening maybe by the fall, a huge wellness center for the individuals with serious mental illness and for the community. And we have contracted out to set this up. We would love to have you come see it when we open it, because it's a way to have individuals with mental illness also integrate in with the community. So that one big building that has been sitting there for a long time, that doesn't look like it's being used, will be open soon as this integrated wellness center for the Bronx community, inviting the Bronx community in as well as individuals with mental illness. Most of the other buildings are either residential or occupied by inpatient beds. So except for the unused older buildings, which are not ours any longer, which are on the land which is now belongs to the Development Corporation of the state in terms of getting those buildings sent off to developers. So the only building that we have in Bronx, which is really open, is now going to be this wellness center. But you're right, that has been.
Are there beds in this wellness center?
No, this is for the community. The Bronx Psychiatric Center has no others, just that one building. Otherwise, there's no buildings there that could be used for beds, additional beds. We've looked very closely at Bronx because it's a beautiful facility, but it's limited now
beautiful
in terms of its inpatient capacity.
Okay, thank you. The executive budget includes $1.1 million for maternal mental health. What type of behavioral health expenses will be covered with this additional funding?
This is an expansion of collaborative care where we would have mental health individuals work with OBGYN in the OBGYN practice, and also train OBGYNs on understanding depression, maternal depression, pre and postnatal, so that they feel comfortable treating individuals with depression. Very similar to what you do in primary care, where you have screening for mental health and substance use, we would have that kind of screening in OBGYN practices. That's never really happened in OBGYN. Also, we have a consultation service available, so OBGYNs can call free of charge for consultation to an expert in treating individuals who are pregnant who have mental health issues. So combine that with a collaborative care approach within the practice, right there in the OBGYN practice.
Thank you. The executive budget also proposes $1.5 million for aging in place pilot. Where would this pilot be located?
We're going to have one in each of the 6 regions across the state. There are capital dollars from last year which will be rolled into helping do some of the physical reconstruction, and then the aging in place will actually provide a nurse and a nurse aide to work with the housing team to provide medical services for individuals who are aging. It's a critical issue that our individuals be able to stay in place in their homes. And by doing some retrofitting with some capital dollars and then having nurses and nurse aides available to enhance the housing team, enabling individuals with growing medical concerns to stay in their housing.
Thank you. No further questions.
Thank you, Assembly.
Oh, this.
Yeah, we've been joined by Assemblywoman Jackson. Our next question would be Assemblyman Stick.
Thank you, Mr. Chairman. I want to begin by thanking the governor for her increased attention to this area. If you know me well, you know that I'm sincerely saying that, because when criticism is apt, I don't hesitate, but I think it is helpful to have increased attention to this area. I am wondering how much money has been added to the budget, not for hospital beds, not for community behavioral health, but for residential beds for, we might say, intermediate or transitional care. Is there any increase in that area?
Well, there's, in the $1 billion budget, which was 2 years ago, there were 900 slots available for transitional beds. 3,500 total beds were added. 900 of those are transitional. Half of those have been awarded and are out. The other half are being re-procured because we've looked again at the areas and what might be the best way to use transitional beds, especially for the forensic population. But there will be 900 transitional beds in the budget. It takes a while for them to come up. The transitional beds are not apartments, they are capital. And that's why it takes a bit more time.
So when you say transitional, how long of a transition are you talking about?
Probably somewhere between 6 to 12 months.
Okay. And you had indicated that in response to Chair Simon's question, you had indicated that 82% of certain beds were full, so there was some excess capacity. What beds were you referring to there?
Those are the community-based beds. So when you come into an emergency room and you are admitted to a hospital, those are community-based beds across the state.
So are they hospital beds?
Yes, inpatient hospital units
That, of
licensed by
course,
the Office of
that
Mental Health.
percentage, of course, does not tell us anything about how those beds are distributed geographically. There could be some areas with plenty of capacity and others with none, correct?
Yes. Well, most have some capacity, but yes, there is a differential. There's absolutely a differential.
So going back to the transitional care for a moment, I'm wondering whether you have any regulations concerning nutrition and exercise for the people that are in transitional care. A lot of the medications of today that are frequently prescribed do cause some very adverse health effects, like tremendous increases in obesity. And so I think, you know, the food at these type of things may contribute to that. And so I'm wondering if you've ever taken a look at providing for nutrition and exercise in such circumstances.
Thank you for that. You know, we certainly look at it, but I think we could do better. And just one initiative which we have started with our state hospital residences is working with farm fresh food to bring it in to healthy and teaching people how to prepare farm fresh food. But I think it's something that we should think about very carefully for these transitional beds as well. Thank you.
So I want to talk for a second about the MCO tax, and I realize that's a Medicaid thing, and it goes, you know, to some extent appropriate to the Health Committee hearing, but Medicaid certainly provides coverage, in fact, better coverage than private insurance for people with mental health issues. So my question is whether any of the MCO tax is being allocated to the services that are provided in the mental health area.
We're still discussing this with the Department of Health.
So the answer is no. Yes?
Well, we're discussing it with the Department of
The
Health.
answer is no for now. Okay.
Not yet.
So there was also some discussion by my colleague on the Senate side of co-occurring disorders. Last year in the budget, the legislature allocated an additional $1.2 million to not-for-profits that already provide services to people with co-occurring disorders. This is the one really significant problem with our, and it occurs in both mental health and substance abuse areas, is that our procurement processes are so cumbersome that the funding doesn't get to the places that it needs to go for a very long time. Whereas when the legislature specifically allocates money, it gets there very rapidly. So I think part of this issue with co-occurring disorders is not just saying, oh, we're going to have a rate increase for that higher level of service sometime in the future. I think we need to do something now. And I'm wondering what your thoughts are on that.
Well, I think that, the procurement process, while it is cumbersome, it's also there, for a variety of reasons to protect the dollars that the state spends and ensure that they're spent well. I think harm reduction is a critical part of the work we do. I want you to know that we are doing a lot of, with the assistance of OASIS and their expertise, of harm reduction throughout our system of care. All these services that we're putting up, we are including trainings on harm reduction, and especially in our residential services where we accept individuals with dual diagnosis in all our residences, and their harm reduction is critical. It's just critical that we work and do the training.
So I think Commissioner Cunningham's commitment to harm reduction cannot be questioned. It's been outstanding. I think the areas where we're not as strong has been in the area of recovery rather than harm reduction. And with respect to the co-occurring disorders, I think the point is we need to do something to streamline the access of programs who have already been approved and operating by the state. I don't think we need to babysit them every second of the day. And I think the bureaucracy for many of these programs is just overwhelming. So I would certainly ask that in your efforts in this area of co-occurring disorders that we not just say, well, we're going to have a program in 5 years or we're going to spend lots of money studying the rate structure for 5 years before we do anything. I would ask that we get things done in a deliberate fashion, because we do have, this is an area of crisis in our state. So to the extent you are talking with OASIS, we'd appreciate your advocacy for immediacy. Thank you.
Thank you.
Thank you. Our next questioner is Senator Webb.
Look at my time.
3 minutes, sorry, she's not a ranker or a chair.
Good morning, Commissioner. Is that better? Yeah. Kind of? Okay, I don't know what's happening. That dwindles my time. Good morning, Commissioner. So I want to go back to Senator Fernandez's question around maternal mental health. As you know, or may know, the Commissioner from the Department of Health, there was a report last year talking about maternal mortality and the disparaging outcomes when it comes to that. And so one of the pieces I wanted to lift up is the fact that 70% of those maternal deaths were preventable, and we know that mental health is a big part of that. So in looking at the governor's proposal this year, is there any conversation around this $1.1 million investment? You said it was going towards training. Is that training also going to include cultural competency for OBGYNs in that regard? And then I'll ask my second question with respect to the targeted inflationary proposal. Last year and the year before, we've asked questions with regards to why those dollars are not going to all workers. And so I was hoping you could speak to that as well.
Yeah, I think, yes, the maternal mental health initiative and providing collaborative care will definitely be looking at the multiple cultural issues in terms of ensuring that people are able to have the right conversations about mental health with individuals. Also, there will be a consultation service available that will also be culturally sensitive, so that our OBGYNs can call and get advice and understand. You know, one of the very tragic you referenced the DOH report. It was very tragic that a number of those deaths seemed to be because of the inability to continue, the fact that antidepressants may not have been continued during a pregnancy. And I think that that is a very serious issue. And one of the things which we will be doing is working culturally with communities to understand why that can happen, why you should continue to take antidepressants sometimes and continue to treat depression, and look very closely for postpartum depression and how you do that. So yes, that's a big piece. On the targeted inflationary increase, this is really for providers to use as, they would get those dollars to use as they see fit. So it could be spread across different workers.
Yeah, but it just seems that certain agencies continue to be excluded when we're talking about expanding workforce because of the staffing shortage. It just seems counterproductive and also counterintuitive to continue to have a COLA or a targeted inflationary increase that does not be spread to workers across the board in all the agencies. So thank you.
Member Brown Ranker.
Good morning, Commissioner. How are you today?
Good, thanks.
So I appreciate my colleagues bringing up the important issue of integrated care and co-occurring disorders, and I appreciate, you know, that we improved the ability for co-licensure, but we still have a lot of work to do when it comes to co-occurring disorder training, the payment mechanisms, and workforce expansion, as well as retention. But my first question, I'm going to go back to last year. The AG published a report on ghost providers, private insurance companies that state that they provide for mental health treatment, but in fact don't have any providers. So what has been the office's role in ensuring network adequacy requirements for these plans? And do you believe the current enforcement actions by OMH, DOH, and DFS are adequate?
Basically, the regulations have been out by DFS for comment, and I think they will be finalized within the next month or so, both for a network adequacy and for the 10-day appointment. So the regulations are there. Now the question becomes enforcing and making sure that they actually happen, because actually parity has been around for a long time, and these should have been enforced before. There's $1 million in this year's budget for us to work together with DFS to ensure that the insurance companies are not providing ghost networks, that their directories are up to date, and that they also have access for that 10-day appointment for mental health appointment. So those are critical things which we will be enforcing. We're keeping a very, very close eye on.
I appreciate that. When it comes to you talking about and the governor's commitment with the $1 billion and then first aid kits and clubhouses that you referred to in your testimony, one of the things that we've been working on a lot is mentorship programs in the high schools. And you know, the Office of Children and Family Services has something called Mentor New York that was started by Matilda Cuomo many years ago. It has a very small budget. I just wanted to know if you and Dr. Cunningham ever thought of perhaps utilizing that in conjunction with these efforts that you're trying to make to help young people stay away from drugs and alcohol.
I think mentorship programs can be very important. And in fact, there's a grant on Staten Island, which we got from the federal government to do mentorship from college students to high school students to deal with mental health issues. So I think, yes, mentorship is important, and it's something we're glad to look at further to see how we might even do better with it, yes.
Great. So one thing we recently sent out a budget request letter on was a very successful program we have in Suffolk County, and we did a tour of the facility. It's called DASH. It's run by Family Service League in Hauppauge. And as you know, DASH, extremely important crisis intervention center that's run by Family Service League. However, they run a hotline that has handled a tremendous amount of crisis intervention calls, and they work very well in conjunction with the Suffolk County Police Department. The problem is, they don't have money left in this year's budget. They need $650,000 in order to continue the hotline. So it's just one thing I wanted to bring to your attention, if there's some way that you could address that, we'd appreciate that very much.
Yeah, I agree, Dash does some great work, and we'll talk to Dash.
Great, thank you. In terms of, I'm looking at the comprehensive plan changes that were in last year's budget, and I'm just wondering if there's any way, I think many people on this dais would like to see an update in terms of the plan that was put in place back in '23 and how far we've come. Because, and I'm not going to go through it, and I only have a minute left, but if we could get an update in terms of the housing and some of the other initiatives that were made, and to see exactly where we're at, because I know it's not enough for you to get it all in your testimony today, but I think we'd appreciate that very much.
Yes,
So.
we'll definitely get that to you. I think it's progressing really well, so we can get you all the numbers where we're at now. I can assure you all the dollars are there to be awarded, and probably about 60% is really moving forward, and then the other 40% is taking a little longer for various reasons. But all the money's been allocated, so we'll get you that report.
Great, thank you. And last question, do you think the state's allocating enough financial resources towards the current opioid fentanyl crisis to provide comprehensive integrated co-occurring disorder care to our counties across all demographics and life stages?
Well, we're working very, very closely with OASIS on doing everything that we can for the opioid crisis, and I think there are a lot of dollars that have been allocated, but we want to make sure they're allocated well, and we want to make sure that we put in place all the programs which have been put forward.
Great, thank you for your advocacy.
Thank you.
Thank you. Next is Senator Oberacher, 5-minute ranker.
Thank you, Madam Chair and Commissioner. Thank you for coming into Albany. It's always nice to get into Albany when it's not a snowstorm, right? You know, a couple quick statements and then one question. The mental wellness side of the equation, being the ranker on the Alcoholism and Substance Use Disorder Committee, the mental wellness side of things is an upstream issue that would have downstream, if you will, positive effects. And one thing I'd like to be duly noted, I use the term mental wellness. I think it's a term we ought to start using more than mental health. I think it actually better defines not only where we are currently, but where we would like to go. And I'd just like to throw that out. I like to use that term more often. In the 51st Senate District, 7 counties, extremely large, and we are a desert when it comes to the services side of the equation. There are a couple of decommissioned state entities, is the term I'll use, that are in that district that I think could basically be used to the good of all. Beds, services, the heat's on, the electric's on already. And so I would encourage, and I'm cordially inviting you to come travel with me in the 51st to actually take a look at this. And I think it's something that would fill a very, very high need as far as just having a place, you know, to go. Transportation being the other issue that we see a lot of. I think if you could kind of focus in some of the dollars that are being allocated for transportation to these facilities would help immensely with as we start to work towards that mental wellness. And lastly, as I've said before, I would cordially invite you to come in. I would love an opportunity to show you what we could do. And I also would like it duly noted, Madam Chair, that I'm going to yield back my 3 minutes. I would just like to say we can be efficient here in Albany. So thank you, Commissioner.
Well, thank you, but please, I would love to come. So I will definitely, and also I think your comments on mental wellness are so important. I think that we have to begin early to start thinking mental wellness in pediatricians' offices, in schools, with our youth, with young people, that we begin to help them be mentally well so that the next generations that come have a very different approach to mental health. So I absolutely agree with you, and I would love to come visit.
You're preaching to the
definitely.
choir. Thank you.
Thank you.
Barbara, for 10 minutes.
Okay, great. Thank you. Good morning. Thank you, Dr. Sullivan, for being here. Thank you for your testimony.
Is your
wanted to
microphone
talk-
on?
Yeah, I think, is it on? Can everybody hear me?
Okay.
I wanted to just talk in a couple of different areas. I want to start with the expanding crisis response services. I continue to hear from families in my communities and advocates about the long wait times for care, especially in inpatient and long-term community supports where wait times are extremely long. What specific budget allocations are needed, in your opinion, to ensure that mental health beds and community-based supports can meet the demand in our communities?
And first of all, you want to have the right number of beds, which I think we have been successful in opening beds across the state. But the other supports, many of the individuals who are in emergency rooms are not necessarily waiting for beds, they're waiting for community-based services. And that's where our Hospital Connections program, our critical time intervention teams, our ACT teams, our assertive community treatment teams that have been gone up in the first budget in significant numbers are going to have a significant impact once they're up and running to help hospitals manage individuals who are in the emergency room but need intensive community services. We have opened up almost 20 Youth ACT teams across, just as one example, across the state, and we are hearing from a number of hospitals that there is an improvement in helping youth who come to the emergency room to leave the emergency room and get the services that they need. So those are the kinds of services, as they come up, that will impact hospitals' ability to make good decisions about who needs to be an inpatient and who can go back into the community in providing those wraparound services.
And just as a follow-up to a previous question and what we just discussed, some of the underserved areas, especially some of the rural areas of our communities, how can we strengthen the mental health workforce in those areas? We've heard concerns about that as well across New York State, and I know in my community as well in some of the rural areas. What are some of the initiatives and some of the things that we're doing to strengthen that system?
Yeah, we're working in those rural areas, working a lot with the counties to try to understand what some of the issues are. We've been working with our loan repayment programs to get the word out that individuals can work in those areas and have loan repayment. We're working with schools that are located somewhat close to those areas to help individuals become interested in loan repayment, and then working within those more rural areas. And we're going to be talking with the high schools in those areas, working with them to help them understand the opportunities that are in the mental health and social services field to kind of join and begin to become interested and then help support them in their education as they move forward. We're having a paraprofessional title that will become available probably within a year or two for high school graduates, and we feel that that could be particularly helpful in some of the rural communities and getting people's foot into working in the mental health field.
Yeah, and just in terms of these rural communities, just healthcare in general, that's something that's lacking. I would like to see more investment in these areas.
Yes, and we are adapting a lot of our RFPs that we're putting out because we learned over time that they were not, they wouldn't fit into rural areas. So a lot of the RFPs which are coming out now have different requirements for rural areas. So yes, absolutely. We're working very hard to ensure that the services get into the rural areas.
And in connection to healthcare, how can we integrate mental health services more effectively in the primary care system? Because those are some of the services that are lacking as well. But if there is going to be doctors' offices and places to go and resources, can we integrate these services right into those primary care?
Yes, and I think we're working on, there's a collaborative care initiative, which we have been doing across the state, and we're going to be expanding significantly something called Healthy Steps, which provides mental health services in pediatricians' offices, right there in those offices. And we will be contracting, that's expanding, eventually will cover probably about 350,000 kids across New York State. So we would definitely be targeting some of that for rural areas to assist pediatricians especially, but then also primary care providers to be able to put those services right in their office. And telehealth can be very helpful with that too, in terms of consultations for the primary care doctor and the pediatrician, and also to provide services in their office, but via video, which can be very helpful.
Great, thank you for that answer. I just want to shift to crisis response services in connection to my committee with people with disabilities. This may be something you can comment on. The budget includes increased funding for crisis intervention teams, but many of the teams lack specialists trained in developmental disabilities. So additionally, Kender's Law was expanded to address individuals with serious mental illness. It still does not include people with disabilities who are often placed in emergency rooms or jails instead of receiving the proper treatment that they need. What specific investments in this budget can we make to ensure that the crisis response teams are adequately trained to serve individuals with disabilities as well?
Yeah, we have a contract for ongoing training, both for the mobile crisis teams across the state and disabilities. We are also training the certified community behavioral health centers, which were expanded in last year's budget from 13 to 39. Those certified community behavioral health centers are getting intensive training. The RFP has just been gone out and been approved in developmental disabilities. In addition, the crisis intervention team, certified critical time intervention teams that we are working with hospitals, especially the ones for youth, will be focused on working with young people who have dual diagnosis and who are coming to hospital emergency rooms, working with them to keep them out of the hospital emergency rooms, and something called home-based crisis intervention for youth, which we have about 1,500 slots for now. 3 of those teams are specifically designated just to work with individuals who have dual diagnosis developmental disabilities. They work in the home, and that's going to be expanded as well. So we are definitely integrating those services into our crisis services and the work that we're doing in the emergency rooms, because we realize that's been a tremendous problem for dual diagnosis individuals who get stuck, sadly, very sadly, in emergency rooms.
And does that include the mobile crisis teams and community-based
Yes, yes.
interventions as well?
Yes.
Okay. Just want to switch over to talking about the 988. I know we talked this last time you were here about the 988 hotline. Just if you give us an update on that, how that's working, and maybe some statistics on that as well.
Yeah, we're expecting over 400,000 calls to the 988 line this year. It's been steadily going up. Basically, all the calls are being answered now, 92%, 93% in New York State. That was an important ability to make sure that the calls used to, when we didn't have our call centers up and there was geo-routing, these things were, before that, they were going to Oklahoma or someplace and then being sent back. These calls are now being answered in New York State. We are expecting that 400,000 will probably continue to grow. It's still about 10% of those calls get referred to a mobile crisis team. So 10% of those calls would go to someone to outreach. Another 10 or 15% get referrals, but many of those calls are handled on the phone with the individual. The call length is about 20 minutes for many of the calls, so the service is there. We feel it's working very well. We're very careful. Any complaints that come, we take care of, and we work with the hotlines, but we feel that it's been very effective in offering the immediate counseling. The other thing we're doing is beginning to help 988 talk with 911, so that more and more calls maybe over time can be triaged to 988, so that 988 can do the counseling for individuals. So far, across New York State, I believe it's been very successful.
Okay, great. That's good to hear. And the last question, just in terms of school-based programs you mentioned, and also the clubhouse-based services. I know there's a few in my district that have been very effective. In your testimony, you talked about those 2 items. Do you find that these are effective? I think they seem to be effective in my community, and is there plans for more investments in programs like this?
Yes, I think the school-based clinics have been very effective. I think that when we've talked to the schools that have these clinics, it's amazing how the kids are really very connected to seeing someone individually, seeing them, speaking with them in the schools, and how grateful they are to have those services. So they've been very successful. They've also been working with parents, and they work with teachers. So the expansion of the school-based clinics is something we're going to continue to do, and I think that it's had a significant impact in our educational system, yes.
Great. Okay, thank you. That's all I have. Thank you, Mr. Chair.
Actually, I know that Senator Bino, you also had a question? Okay, thank you. I'm so sorry. No, it's not your fault.
Thank you, Madam Chair. Good morning, Commissioner. Wanted to chat a little bit about the CCBHCs. And Nassau and Suffolk has a couple of entities that are providing the need, including Family Children Associations, CNN Guidance, and also Family Service League. There's an opportunity there. because folks are coming in and they're getting the wraparound services, they're able to be treated and provided care 24 hours a day. There's a need there to increase funding, and so that they can continue to provide that care, because what they're finding is that people who are not insured are using those facilities to be able to get the medical care. Is there an appetite for the state to increase funding in that area?
Yeah, there is a pool of dollars that for uninsured care, specifically to help in the CCBHCs. And as far as I know, we have been spending those dollars, giving them out to the CCBHCs, and each year we look at it and take a look and see if we need more, then we would look for more. But basically, those dollars are also going to be increasing because we've increased the number of CCBHCs. So we will be working with the ones on Long Island to see what their numbers are in terms of uninsured people can't get insurance. For those who are insured, it's a cost-based system. So the CCBHCs get reimbursed very well for the services they provide for the individuals who are insured, which is great, which gives them the kinds of the ability to really expand. But for the uninsured, those who can't be insured, there is a pool of dollars, which we have, and we will be working with them to make sure that they're accessing that as much as possible.
What exactly how much is in that pool?
I think there was 10 million, and I think it will be increasing as we expand the CCBHCs, because we went from 13 to 39. So as we increase, that number goes up. I'm not sure exactly what it goes up to, but it will be increasing.
Okay, thank you.
Mr. Ross not here. Okay, is Assemblymember Anderson, 3 minutes. He left, okay. Assemblymember Braunstein? Epstein?
Good morning, Commissioner. Thank you for being here, and thank you for all your work. Just a question on the 884 housed individuals. Are all those housed permanently?
I'm sorry, could you?
You mentioned 884 housed individuals.
Yes.
Are those all housed permanently housed? And those are all in supportive housing or?
Yes, supported housing. Yes.
Supportive housing.
Supported housing, yes.
And of the 67,000 outreach encounters, how many human beings were those outreach encounters to?
That's, those are,
I have to skip you.
I can get back to you on that, exactly how it breaks down to individuals.
Yeah.
I can get back to you on that.
I appreciate that. And then you mentioned some 875 voluntary referrals to hospitals. Did those referrals result in people being hospitalized, or were they just released, do you know?
It was a mixture. I think some of them were able to be, the teams went with them, and they were pretty satisfied as to whether someone was hospitalized or was discharged.
Can we get from you how many of those actually you were hospitalized and how many weren't hospitalized, and how many of those got into supportive housing or versus didn't supportive housing after hospitalization?
And we can get you that. We can get you that.
That would be
Thank you.
really helpful. Just want to make sure that the Safe Options Net support, if this is working, then we want to see it be successful. Because obviously we've seen a lot of this work and still seeing a lot of serious mental health issues on the streets in our city and our state. So we just want to see that's working. So how many new units of supportive housing do you know that we've put online in the last year?
We put on, from the 1,200 out of the 3,600 that were in the $1 billion, 1,200 are online. There's another 2,000 that will be coming online this year and from the pipeline. And then the other 1,500 or 1,600 for the $1 billion actually are capital, so they will take a little bit longer. So last year, in total, we probably had about 2,000 units, but 1,200 of those units came specifically from the $1 billion budget.
And thank you for that. And the folks who are leaving hospitalization, do you know what percentage of those end up being housed after leaving hospitalization? Whether they're there 3 weeks, 3 months, or up to a year, do you know what percentage of those people are reintegrated into a supportive housing or go back with family, or versus, sent back to the streets?
Well, the individuals who were in the special transition to home units, which we had, the state system, all of those when they left were in housing.
So,
They made
but
sure they had housing.
anyone
They
who's-
haven't all stayed.
Involuntary hospitalization, how many of those folks who are, once are better, are those transitioned back to supportive housing units or to the streets? You have that data?
Out of all the discharges?
Yeah.
No, I don't have
Could-
that.
could you
I can
get that for us,
yeah,
please?
I can get you an approximation of that. I think that might be hard to get specifically across the state because there's like 80,000 discharges, but we'll get you what we can.
Thank you.
Thank you.
Sorry. Next is Senator Rollison.
Good morning, Commissioner. Since we last spoke last year during the budget hearing, in the 39th District, which has 3 cities, Beacon, Poughkeepsie, and Newburgh, having challenges throughout the system, there's an SOS team in Newburgh, based out of Newburgh. And I just want to say that I've had interaction with them on 3 occasions, and it is a great model. And the more SOS teams that can be out there working in conjunction with the partners, many of which are in the room today, I think would be helpful. And also, since we last spoke, there's a clubhouse in the city of Poughkeepsie, which is doing fantastic work. And as the chair said, Chair Kruger said, there's an overlap today with everyone. And as we see, and I applaud the state for ramping up funding, ramping up services in the area of mental health, addiction, and the underhoused, and many other issues that are interconnected. I'm hearing more often now and over the time before the session started from providers in my district, and we've heard this before, of course, that it is complicated, it is cumbersome, and there isn't one point of contact when many of these organizations are using multiple state agencies for resources and for funding. And that slows the system down on a variety of levels, and I know that you know this because we've heard this before. But what I'm hearing is, and I just want to get your brief thoughts on, do we need in this state a cabinet-type level position that can help coordinate the different agencies that are doing such great work? Because I'm hearing that more often than not. And that is not a rub on anybody in state government. That is just, as we're getting bigger, more coordinated, and giving more services, is that something we need to consider?
I don't know if I can actually speak to that, but I would say that one of the critical things I think when working with communities is at the real community level. And one of the things that we are starting are these regional meetings where we pull together we pull together the sheriff's office, we pull together the healthcare providers, we pull together the schools, and we talk about the needs of that community based on how do we serve the most needy, and that's part of our hospital, we call it Hospital Connections, but it's not just hospitals, it's hospitals and all the community providers. And I think the most effective way to get to what you want is to really have those kinds of connections happening at the community level, because it's who talks to who and who knows what, and the information that flows within a community. So as we begin to grow those, I think I'd like to see how effective that is in really combining mental health with all the other people. The other thing is the social network work, which is going on under the Department of Health, under the 1115 waiver, is another area of bringing together multiple stakeholders, which I think can be very effective.
Thank you.
Assemblywoman Giglio, 5 minutes.
Good morning, and thank you for being here. So mental health is a big thing within our school districts, within the workplace, actually even people that are trying to get jobs. And I did speak to somebody in your office over the summer, especially when it comes to COVID and kids maybe have lost a parent, a grandparent. They took an anti-anxiety drug. They're putting that information on a police test. They're putting it on a corrections test that they took an anti-anxiety drug, and it's making it complicated for them in order to get a position with law enforcement or with corrections. I'm just wondering what recommendations you have, or if there's any funding that we should have for these types of programs with a referral from testing agency that may say, you know, you didn't pass the psychological because you took these anti-anxiety drugs during COVID. So do we have any solutions for that?
You know, I think it's probably, I don't think there should be discrimination against people with, who have a mental health issue if they're taking medications that are prescribed by their physician any more than there should be if you're a diabetic and you're taking insulin. And so I think when those things come up, it's, I think it might be best to combination of either letting us know or understand who we can refer individuals to, because that shouldn't, my book, that shouldn't be happening, that would exclude you from a position, especially if you're being honest and if it's prescribed by a doctor for a condition that happens. So I think that's probably discriminatory, but we'd have to check.
Yeah, I couldn't agree more, and your office was very willing to help and get back to me with solutions to that problem as to whether or not they could go and get a psychological examination from somewhere outside of the agency to clear them and say that they are currently not, and they are stable, and they are, you know, willing and able to take this position.
Yeah, I think unfortunately the stigma against mental health issues is still out there. And I think, you know, unfortunately when it comes up like that, and especially in job applications, it has to be looked at very carefully.
Okay, and then in school districts where social workers are in the schools and they're prevalent, they're available if children should need to talk to them. But a lot of those social workers are being sent out to individual houses to find out why a student is truant and not showing to school, whether or not there's a mental health issue or something else that's going on in their life, why they're not coming to school. And I'm wondering what your thoughts are on that, whether or not social workers should actually be working for the school districts, going into homes to find out why students are not there, rather than being in the school for the students that may be needing them at the moment.
Yeah, I think that, you know, the Department of Ed probably has to use, that's, to some extent, the school social workers are under the Department of Ed, but one ways we can help, and we've been trying to do this across the state, is make sure we get these school-based mental health clinics in the schools. Because once we have those clinics in the schools, that's their job, to talk to the students, to be there to talk to the students. And whatever other needs the Department of Ed may have, they now have that available. So we're working very closely with all the school districts, saying we have this. Please let us know. We can give you startup funds to start a school-based clinic. After that, they really are financially stable because we've increased the rates. So I think part of the solution is to make sure that every school has a robust school-based clinic so that youth have someone that they can approach and speak with.
And do you think that that funding for the social welfare clinic within the schools should be funded by Foundation Aid and the school itself, or should that be funded by DOH or OMH?
The school-based clinics, we give, OMH gives the startup funds, and then it is reimbursable by Medicaid and third-party insurers, and we insured the commercial has to pay for it. So the school-based clinics, when we assist them to make sure this works, can be financially viable on a payer basis by the commercial and Medicaid payments.
Okay, thank you.
Thank you. Just double checking, good. Next is Senator Weber, 3 minutes.
Good morning, Commissioner. So I have some questions regarding the Joseph P. Dwyer Veteran Peer-to-Peer. You know, I think we've all seen the great work that they do, and I know it's been expanded through to include all counties now, I think.
Mm-hmm, yes.
And you know, some of the questions that I've had locally is, you know, some of the veterans and the calls that we get from constituents about the unmet need for the program. Has there ever been consideration to really expand the program and you know, ask for additional appropriation for the program? And how was the allocation of the $8 million with a minimum of each, I think, $100,000 for each county? You know, how did you come to that, you know, those conclusions?
Well, it's to give each county the ability to at least set up a Dwyer program, because it's such a great program, and to have really throughout every county. And I think as we're getting more experience now that we're getting back the data from the Dwyer programs, I think we'll be looking at looking at the dollars and where we need to kind of consider other services. The Dwyer program, I think, provides just tremendous, it's not just mental health services, it provides all kinds of assistance. And I know we are also working with several of the Dwyer programs on mental health assistance for individuals who are transitioning from the service to the communities. So yes, I think we will continue to look at the funding, but we did that to get it started everywhere.
Great, thank you. And just switching gears, going back to mental health services in schools. So, from some of the feedback I got is there are very few providers, outside providers, and I know a lot of families and students sometimes have to wait months upon months to get those services. Is there something that can be done to increase the number of providers or make it more available to the students?
Yeah, we're working with all the providers to see, they can really establish these satellite clinics, and so depending upon the areas, sometimes they need some technical assistance on how to do that, but it is a viable program. So I think when we hear that there are difficulties setting them up, we're very glad to work with those communities, because usually with some help, we can get those school-based clinics into the schools.
Thank you. And I think I've also heard, too, that there's a big need for bilingual type providers as well. So that's something maybe you can at least keep in top of mind as well. But thank you.
Thank you.
Assembly.
Thank you, Mr. Chair, Commissioner. Good morning. I know we're obviously talking about the major proposals, I would say, in this budget regarding involuntary commitments and AOT, but are there any other proposals or suggestions that you believe would benefit public safety from a mental health perspective?
I think, again, just always to mention that individuals with mental illness are far more the victims of crimes than the perpetrators of crimes. So just keep that in mind. But I think the biggest issue is to make sure that we have the community-based services that we need, and that's this tremendous investment that the governor has made over the past 3 years. So that $1 billion that's coming out to help with all the services I've been talking about specialized teams, to work with our highest need individuals, to have housing for our highest need individuals, all those things are critical in terms of helping individuals really thrive in the communities and to avoid things like incarceration or getting in trouble with law enforcement. So the big issue here is to have the services available, and I think we're on a road here to providing that in a way we never have before.
And what are the investments being made right now in terms of, to that end, training, supporting mental health professionals, counselors, other service providers, to make sure they have the necessary skills to deal with, you have mental health, obviously coinciding with addiction, all these type of things, and training those professionals?
Yeah, we have a tremendous training that we run through the Department of the Office of Mental Health. But we have something called the Center for Practice Innovations, which is connected to Columbia University, which does tremendous training across the state. We have specialized training for youth services, where we pay for evidence-based practices to be implemented in our clinic services and in our specialized services. We do training on integrated care, we do training on crisis services, we do training on integration of dual diagnosis. So we have training grants throughout the system. It's critical. One of the reasons that people stay, I think, in public sector work is because we offer them learning opportunities. And I think we have to continue to offer more and more learning opportunities to all those who work in the public sector.
And then what about any efforts to recruit people into these fields?
Some of the major efforts, one of the big successes I think we've had is the loan repayment program. The loan repayment program for psychiatrists and nurse practitioners has gotten us about 70 psychiatrists and about 140 nurse practitioners who will be working with us for 3 years. And for other clinicians, psychologists, social workers, 600 individuals. Loan repayment, and they will be working with us for 3 years. So loan repayment has been successful. We're also working with the scholarship program with SUNY and CUNY, and we are working with trying to recruit from colleges across, and also we're going to be starting a paraprofessional title that will enable individuals with just a BA or maybe individuals graduating from high school to begin to work in the field and then move up. So there's lots of exciting recruitments going on.
Thank you, Commissioner.
Thank you very much. think it is my turn. Thank you so much, Commissioner, and I know I always try to back cleanup, because many of my colleagues on both sides have already asked many of the questions. And clearly, there's serious discussion about the involuntary issues. And I happen to represent a section of New York City which probably has more of these incidents than anywhere else, not because I'm lucky, but because of being in the central Manhattan areas where you have Penn Station, Grand Central, Port Authority, just lots of places where homeless, mentally ill, substance abusing people may, for very rational decisions, be spending their days. We see much of this. So I know for a fact that the police are picking up large numbers of people involuntarily and taking them to my hospitals on a daily basis. But I also know the statistic shows that they go in and then they get let out a few hours later and nothing has been done. And in fact, the data, I believe, shows, even though there was a question earlier about tracking, that when police take someone into a hospital against their will, the likelihood of their being admitted for care is radically smaller than if a community-based organization or the outreach teams that you fund actually convinces someone to go in, that they need to go in, that there's a much higher rate of actually getting them admitted to the hospital. So I think whatever works out within the budget and the governor's proposal, I think it's really important to keep focused on what is the goal. And the goal is actually get the people help before something tragic happens to themselves or others. And that we should look from the experience we're having. So this is more an opening to the real question for you, Commissioner. What I see as the problem is once they get into a hospital, whether voluntary or involuntary, they're not getting the care they need, and then they're being released. So I wanted to ask you about discharge planning. I believe that the language that we should have in the budget is, if you accept someone for mental health care, you don't get to discharge them unless you have a plan for where they're going to go and what kind of care they're going to get. And so that is what I'm asking you. Do you agree that the requirements of mandatory should actually be focused on the institutional providers to actually have somewhere for people to go? Because if you just have a rotating, pick them up here, drive them there, let them out there the same day, or let them out there a week later with no plan for any care, all we did is make people rightly more distrustful of working with anyone in the system. So what do you think about that?
Well, first of all, I absolutely agree with you. And we have promulgated regulations which have gone through all the necessary committees and everything, state regulations about discharges for mental health, individuals with mental health from inpatient services. And those regulations are doing exactly, they passed, I believe, about a couple of weeks ago for the inpatient, and then soon it will be also for the emergency services. Basically, these regulations, which are now regulations, which means hospitals have to follow them, require the kinds of discharge planning that you're talking about. That you can't, that we have to look for complex individuals, for individuals who have complex needs, that we have to have careful discharge planning, which includes having them a safe place to go, includes working with them, to have teams that will work with them when they are discharged, ensuring that they get the kind of care they need after discharge. Now, in fairness to what was happening in the hospitals before, did we have those things set up? So all these new services that we're putting up, the increased ACT teams, the increased CTI teams, these are linked to the hospitals so that now the hospitals have to have careful discharge planning, and they have to make sure that individuals who need those complex services get them. In addition, we actually put in the legislation in the mental hygiene law that it's one of the things which was added, that hospitals have to notify about admission and discharge the provider who's been taking care of that patient, and they have to work with them on discharge planning. That's a critical point because often some of these individuals do have connections to an outreach team, or they have connections but the hospitals aren't aware of it or haven't looked. It can be found in the Psyches database, which we have. So now hospitals will have to pay attention to that and make sure, if that's passed, that basically it would be in national mental hygiene law, that would be that hospitals have to do that. So yes, we are working on the discharge planning, but we're also giving the hospitals the tools that they need to offer the services, because it's in a way, what the governor has done is said, here are the services, now hospitals, you have to work with us to make sure that these very, very needy clients get what they need upon discharge. Similarly, we're doing some of it, it's a little more complicated to do it from an emergency room, but some of these services will also be available out of emergency rooms for the individuals who, as you say, maybe come in and are discharged from the emergency room. They will also have access to these kinds of services. And while it'll take a little while to put up some of the transitional beds, that's what those transitional beds are for. Those transitional beds are so individuals also have a safe place to be when they leave the emergency room or the inpatient service if they don't have a safe place already.
Thank you. So we also know, at least from New York City data, that the number of people who are picked up through either an involuntary admission or some coordination with outreach teams who are determined to need supportive housing with additional services, that the city has only been able to place, I think, in the last year, maybe a fourth to a fifth of the number of people who were approved for this kind of housing. And my experience is that we, of course, don't have adequate supportive housing or adequate intensive services on a residential basis for the number of people who need it, but we also have huge numbers of contractors for supportive housing who are under the old contracts where the amount of money they get for services is so little per year, they can't possibly accept people who have severe needs because they're getting like something like $2,500 for services on an annual basis compared to some of the OMH newer contracts that I think have $25,000 per year. So I know the governor's put some money into human services budget to increase those contracts, but it's not nearly enough. Would you agree that our whole system is not going to work unless we get both adequate numbers of locations for people to go to, but also reasonable levels of funding for the services we know they need?
You know, housing is obviously critical. I mean, it's just a critical issue. I think that there's been a tremendous investment by this administration, whether it's the $3,500 and the $1 billion. We have over now in New York State over 50,000 units of housing. Some of the housing, and we invested over 4 years over $350 million in upgrading housing stipends, some of which were really incredibly low just a few years ago. So the investments are coming. I think there is a significant investment, but yes, housing is one of the most critical issues, and we're continuing to work on making sure that as much as possible we can get people, especially those with very, very high needs, into housing as quickly as possible and get them the services that they need.
So I had written you a very detailed letter looking for information.
Yes.
And thank you. You did get response back. When you get a 12-page letter back from an agency, they are taking your questions seriously. So thank you. And that was all about who, what, where, why, the different kinds of things we funded in the budget. Beds have come online or almost online or where they are. So thank you, even though we're still way behind where we need to be. But yesterday in the local governments hearing, we heard from the City of New York that they believe they have a need for 500 forensic beds. That's different than what we've been talking about so far. Forensic beds, my understanding is people who are in our local jails who have been determined by a court not to be able to stand trial because they are not competent to stand trial. Hence, they're required to be under state control in a forensic facility before ever being possibly brought to trial if they get better. And so the City of New York reports they need 500 of those beds. So, and I know there is some funding in this executive budget for additional, I think, FTEs for forensic locations. But one, do you agree with the City of New York? Two, how big is the problem statewide? And three, do we actually have money to meet these targets?
Basically, these are individuals who are waiting to be felony arrests, who are waiting to be restored to competency. By our numbers, we feel that probably eventually we will need probably another 100 to 150 beds. So the plan, not 500, I'm not sure where they came up with that number.
That's what the
but,
city of New York
yes.
testified yesterday.
But what we have, two things. One is this year, in this year's budget, we will be opening from last year, 50 beds, 50 forensic
I have
beds.
to cut myself off. I have to be the
And
bad
there-
guy.
But just one quick thing, also in the budget, there's 100 beds
Assemblyman
that will
Burdick?
occur.
You'll
5
follow
years.
up with us afterwards. Thank you.
I just wanted to explain.
Thank you.
Assemblyman Burdick.
Thank you. And thank you, Commissioner, for your good work and your testimony today. I'd appreciate your addressing how your agency and OPWDD handle areas of overlap requiring services from both agencies, such as dual diagnosis, crisis intervention, and coordinated services, including the intake process and development of the person-centered plan of care and the life plan. If you could elaborate on that, it would be appreciated.
Yeah, well, we work very closely with OPW, DD on the kinds of services that are important for us to work together on. And one of the key things is the individuals with dual diagnosis who have, there's two groups who have high needs. And for those, we're working on home-based crisis intervention programs, critical time intervention programs, where we together do an assessment, make a diagnosis, and then work together on the mental health needs that an individual has, and then the needs that they may need from OPWDD. We also have a specialized unit which is opening up in upstate, which we're very happy about. It's just opened to work with individuals, particularly with autism, who have severe autistic, and that's a dual unit where we are working with upstate and with OPWDD, and we have a whole bunch of step-down units. In addition, OPWDD is working with us to educate our certified community behavioral health centers to do these kinds of assessments. The assessment hubs, which are in this year's budget, are also going to be, for youth, are going to be specializing in dual diagnosis with individuals with developmental disabilities and mental health. So together, we're trying to come up with this, not just a good assessment, but also a system that can really work to provide both intensive services and more regular kind of clinic services
Right.
on either side, either in OPWDD clinics or in mental health clinics.
And can I ask what kind of feedback you've been getting on that, and whether you are considering any changes or tweaking in how you handle it?
The feedback we've been getting on the home-based crisis intervention teams, which you've had a few up, is very good. People seem to feel that the families are happy. They actually have workers go in and spend 4 to 6 weeks with a family, working intensely with the family on how to work with the young person to avoid their going into the hospital. We've been getting very good feedback on those teams which we have out. We've been also getting good feedback from our certified community behavioral health centers that are doing some of this work from families. So we've been getting good feedback so far. I think it's a question of just continuing to push the services out so that they're more available.
Thank you so much.
Thank you. And next up is we have no more senators until a second round, so we're just going to keep going with the assembly members here. There are always more of them than us. Assemblymember Otis. Are you here? Oh, maybe he stepped out. Okay, we'll come back to him. Assemblymember Tapia?
Thank you, Commissioner, for being here. The budget includes $9.5 million to expand youth clubhouses and safe spaces for at-risk populations. How will these clubhouses be distributed across the state? And what the criteria will be used to ensure they reach the communities with the greatest need?
Yeah, the clubhouses are going to, there's a lot of money in the city budget for clubhouses. These are for adults in the city. So most of these clubhouses will be an expansion to Long Island and upstate because the city has been funding an expansion of clubhouses in the city. So the state dollars For the safe spaces for youth, that's statewide. So that will include safe spaces in the city as well. And we will be looking at the demographics of areas where youth, where there are issues, whether it's, you know, violence with youth, whether it's youth having more incarceration. We're going to look at all that data and looking at communities and then talking with communities about whether or not they think this would be helpful in their area. We are going to be targeting as much as possible the marginalized communities across the state, both in the city and the rest of the state.
Okay. Almost exactly 2 years ago, the governor allocated $1 billion to support mental health, which included creating more patient psychiatric beds and thousands of units of housing for supportive services. Can you provide an update on how this funding was allocated, as well as how the governor's investment in the budget proposal aligned with this funding?
The state hospital beds that were in that budget, there were 150 beds in that budget. They've all been opened in the state hospital system, so those 150 beds are active and open. The various other things that were in that $1 billion budget, which included like our crowd critical time intervention teams, our expansion of ACT, expansion of CCBHCs, et cetera, all those contracts were sent out. Some are being rebid because we didn't get the responses we needed, but we have done 800 contracts, and almost 700 providers are receiving funds. So all those dollars are moving out, and I think that within a year or two, most of those services will be really successfully up and running. It takes a little while to get them out, but we've been really working diligently to make sure that all the services are out there.
Thank you. If you can provide that information to us, that
Yes,
would be
yes, we'll get
fantastic.
that to you.
Oops. You have another assembly.
Assemblymember Eckes?
Thank you. As you know, Doctor, we have a very special relationship, myself with OMH and yourself. And the first thing I'd like to do is say thank you. And please thank your administration and all your staff workers. You do a great job. Thank you for taking care of my daughter. I appreciate that greatly. I have more statements than questions because during your entire tenure, I had no reason to call your office and say, hey, we need or we have to. So that's a credit to your office. But the things that I'd like to discuss is first the SOS or the mobile crisis teams. Certainly there are not enough across New York State. And I would just like to mention that I have a volunteer ambulance corps, which covers 4 of my municipalities, which now is carrying a certified social worker on every one of their calls. Great. So instead of the thought of building entirely new teams, maybe there is some money which can help, because they have to use money out of their budget to support those social workers and get those social workers. That might be something that we might consider, which can happen quicker at lesser cost. In the report, the Certified Teen Mental Health First Aid course, I took that. I think I have to update it, though. It's over a year. And I'm a little worried about that. Having been a teacher for 40 years, I'm a little worried about 9th through 12th graders thinking or needing that they have to run into a situation when what they should be doing is calling about a situation. So I hope that that is stressed. It wasn't when I was part of it, maybe because we were adults that they were teaching, but when you're talking about younger kids, I hope the essence of calling for help is one of the first things.
Yes, that's very important, and basically it's a different curriculum for kids, and they've been taking that very seriously into account. That it's really helping kids kind of be supportive of each other, but just as you said, hold it, get them help, move forward. The youth have asked to just understand how to do that with someone, and that's what the focus of the Teen Mental Health First Aid is.
Now, I did call your office, or it was relayed to your office about recycling and deposit bottles and all. Listen, I visit one of your largest facilities on a weekly basis. I'm there. So I know, and I appreciate you mentioned that your central office does it completely, recycling and doing the deposit. We're considering 2 big, better bottle bills, and yet we're not showing good behavior in some of your facilities. In other words, they need more bins, they need places. Because if I bring recycled materials in, I have to carry them out. And then finally, as my fellow Chris Burdick mentioned, you know that I mentioned 2 years ago about OMH and OPWDD working together, crossing their silos. I know you didn't have time to report it, but if we could get those reports on those programs, that'd be great.
Yeah, I'll be glad to send it to you.
Thank you.
Thank you.
Assemblywoman Gallagher.
Thank you so much, Commissioner. It's so nice to be here in this hearing with you. And I have two questions for you. Part of keeping vulnerable people safe and stable is ensuring that they can stay in the community where they are loved and where they have people they trust. In my community, extreme rents have made this impossible, and displacement exacerbates the instability. 2024 saw a 53% increase in homelessness compared with 2023 because of housing costs, and New York has the highest rate of homelessness in the country. What role would you say the housing market is playing in this instability? And wouldn't a housing first model, funding deeply affordable housing solutions, securing individuals in a way so that they could be stabilized before they're getting outpatient treatment, how would that help their mental health conditions?
Yeah, I think, yes, absolutely. Housing is just one of the most important. Everyone needs a safe place to put their head at night. And I think housing is a critical point. And that's why we're so invested in increasing housing. The $1 billion had 3,500 units of housing. Across the state, now we have 50,000 total supported housing units. But we need more. So we are growing them with the 3,500. We will be growing them through ESHI. So yes, we have to continue to grow. And I think the other thing you mentioned was Housing First, which I think is a model which we are definitely using, especially with those transitional beds that we are setting up, which means that housing comes first, and then at the same time, you can do therapy, you can do all the things someone needs, but the first place they need is to be a safe place to be housed. And that cuts through some of the red tape of getting into housing. So yes, housing is critical, and I think the expansion of housing is something which is an ongoing issue. Next year, I think in the pipeline, there are another 2,000 to 3,000 units of housing that will come up across for supported housing for individuals with serious mental illness, but it is critical and something we continue to work on to make sure we have more and more housing available.
Yeah, and I think doing messaging around how important it is to have these units in our communities is really important, because I know that when we do have supportive housing put in our community, sometimes those units face a great deal of discrimination and pushback, even though they are the greatest buoy for our kind of our support.
And I truly appreciate your saying that, because one of our difficulties with the capital we have is actually convincing communities that these are good things for communities.
Right.
These make communities safer. These make communities more prosperous. So thank you so much for saying that.
Thank you.
Yes, Commissioner, thank you for being here. Last year at the hearing, I mentioned about a constituent who tragically lost his son to suicide, and you sent us a bunch of information at my request of what you're doing. This individual, Joe Tobia, is testifying later today. Mr. Tobia also sits on the Governor's Suicide Prevention Council. He and his wife have been fierce advocates for change and reform to the mental health system, because quite frankly, it failed his son and their family. So they've been very advocate. One of the issues they've been advocating on is the Rural Suicide Prevention Council that the governor vetoed last year for financial reasons, saying it could be duplicative services, that she's directing it. It was lumped in with a bunch of other bills. It could be asking other agencies to do this and implement, well, what can be done to implement this? And given this fact that the rural suicide rate is double the rate of urban areas, this must be a priority. So I would ask you, would you be willing to meet with you and your team be willing to meet with Mr. Tobia, because he's got a lot of ideas and suggestions, but more importantly, as the governor is directing you, what actions have you taken or are you going to beginning to take, and would you be able to provide them in writing after the fact to identify some of those issues in that bill, which would identify barriers to mental health, which would identify vulnerable populations, which would determine if there's sufficient capacity, we'll look for strategies to increase utilization and provide recommendations to improve the coordination of care and services. would you be willing to meet with Mr. Tobia? Would you be willing to provide back in writing what you're doing to address those that bill, the bills, things in that bill to address this issue, and what can you talk about here too as well?
Yes, we'd be very glad to meet with him. And I think, the Suicide Prevention Task Force, which has been reestablished, has a whole subgroup that's going to be working intensely on rural suicide. So we would love to speak with him and to speak with him about his recommendations and make sure that those all get incorporated. So yes, absolutely, and we will send you in writing all the work that we're doing. Yes.
Because I know he has other ideas on how to improve the bill. I mean, I would like to see us advance this bill because I think it lays it out specifically, but I just want to make sure the department is committed to doing this. I mean, the governor mentioned this in her veto message, that if we have to do it in-house, that's one thing, but I would, want make sure that that type of communication is going on. So would like to see what you're doing in writing to address those issues in the bill that was mentioned, and also some suggested improvements that Mr. Tobia had for the bill. He has a lot of wealth of experience and knowledge, tragically, that he wants to bring to help make sure other families don't have to go through this. So hopefully that consultation can happen. And again, because the rural suicide rate is double that of urban area, it definitely needs to be a priority, especially with the mental health crisis we have in the state.
Absolutely, and we definitely thank you so much that he's interested. Thank you so much for all the work he's doing, and we would be very pleased to meet with him, get his ideas, and be able to help implement some of what he needs, what he thinks is needed. So yes, thank you very much for offering that, and thank him. Thank you.
Thank you, Commissioner.
Thank you. Good morning, Commissioner. Appreciate you being here. One of the favorite things I love to do as an assembly member is meet with our local students. Could be elementary school aged, middle school, high school aged. And one thing I try to do is I let them know it is vital to get their feedback. That it's not just a nice trip to come up here, but it's their responsibility to advise us and educate us as legislators on what their needs are. And for the most part, that one issue that always comes up, and they're conscious enough to know that it exists and it's a problem, is increased services for mental health support within our school districts. My first question is, how are our schools being supported to address mental health issues among children?
The first thing is that we are able to open up for any school that's interested is to establish a school-based mental health clinic. And what that really is a satellite clinic of a provider in the community. And that means that services are then provided on-site in the school. And so that's available to schools. We have talked about this with all the school districts, et cetera. The other things are a whole host of other. That's probably the main thing, because if you can have a school-based mental health clinic, that makes a huge difference. In addition, we have available something called teen mental health first aid training, also first aid training for teachers, first aid training for school staff personnel that helps individuals understand mental health issues and also be able to talk to each other about the critical mental health issues. So those are available for schools. Schools can call us. We can set that up. We also have a whole host of safer suicide prevention services that we can talk to schools about, trainings that can go forward to schools. So we'd be glad to work with the schools. There's a lot of suicide prevention services that are available for suicide safer schools, training teachers, working with students, et cetera. So the school-based mental health clinics, and then a whole host of trainings which are available for schools as well.
If I could then add on, and I appreciate you really laying out all of those services that are available, I know it can be very difficult to quantify the success and the impact of some of these programs. Can you speak to how you do that right now? And when we talk about some of these programs, is there a questionnaire that goes out? What exists right now for us to quantify whether or not these programs are successful?
Yeah, we're gathering data from the school-based mental health clinics as to who they're seeing and the satisfaction of the individuals that they've seen and whether or not the students feel it's been helpful, et cetera. On the mental health first aid, it's a little bit harder to get outcome data, but we do get satisfaction data about whether people felt the training was helpful. Whether the impact, the long-term impact, I don't know that we have data on that specifically for schools. There's national data that this has an impact, but I don't think we have it for schools right now.
Thank you, Commissioner.
Woman, Chandler Waterman.
Thank you, Chair. Thank you, Commissioner, and my colleagues for great
questions. I appreciate you and your team for coming out to my district. As you know, I'm in Brooklyn representing East Flatbush parts of Canarsie, Brownsville, and Crown Heights. I also appreciate you and your team partnering with our AD 58, my in-district mental health task force, where it comes to the Black, Brown, Caribbean immigrants. We want to ensure peers are at the forefront of the conversations, of course, mental health professionals as well, local, cultural, sensitive clubhouses and respite centers with up to 30 days. Stay person-centered, non-police response, wraparound services, more investment in school-based mental health clinics, as we mentioned, ensuring families are prioritized as an intentional part of the plan for recovery. I also discussed with you and anyone who listened that we have a great example of an institution supporting person experiencing emotional crisis. One, Brooklyn Health, Brookdale University Medical Center, Behavioral Health Clinic under the CEO, Dr. Scott, and Psychiatry Hirschberg, Dr. Hirschberger. We need more investments like these into these institutions like this in my district. As you know, we have a broken system that have a lot of disparities, oftentimes underserved, under-resourced districts like mine experience worse than other communities. They get a cold, we get a flu. It hits us harder. So on paper, involuntary commitment may sound like a good idea, but it feels more like a Band-Aid. Our fear is that it could look like mass incarceration, it could look like the new stop and frisk, or it could look like, unfortunately, Daniel Prude, who was killed and died, unfortunately, at the hands of police and during a mental health crisis. However, we need a more sustainable plan. Great news, we have one. It's called the New York State Daniels Law Task Force Behavioral Health Crisis Response Report, which I know you know about. $1 million we invested into that. And you, including the community input we had, peers, doctors, professionals. This report, thanks to you and your team, finished last year, a year earlier. All of what I have mentioned just now is in Daniels Law. We need Daniels Law fully passed, fully funded. And how is this issue that we need with mental health being addressed with using this report, using Daniels Law, instead of the Band-Aid approach that involuntary commitment may pose? And as you know, we got over like 3.2 million individuals experience mental health crisis. 2021 and 2022 report by the New York State Comptroller DiNapoli is in your report. So how do you envision that this wonderful report that we invested $1 million is used to help?
Well, I thank you. I think it is an excellent report. I think that it provides a resource for, as I said earlier, a resource for the policymakers to look at that report and to use it in making their decisions about what are those recommendations that are in the report would be implemented. So I think its goal was to be a resource, and I think it is a solid resource for people to look at in terms of what a behavioral health response to a behavioral health emergency can be.
Thank you. Assemblyman Anderson.
Thank you so much, Chair, and thank you, Commissioner, for being here with us this morning into the afternoon. I have two brief questions. Hopefully, I can get an answer from you on them. I did see in the executive proposal an investment in mental health first aid for teenagers, and I think that that's so important. When I was first elected, I was able to train over 150 constituents and community leaders in mental health first aid, and I know how effective that program was. So I'm just wondering the mechanism in which that program, as proposed, would get down to groups and organizations. Is it a grant program? Is it a direct allocation to cities? Just want to get a sense of that.
Yeah, it's direct money that will go to schools, and the goal here is to have work with schools who are interested in us doing this. We can probably do mental health first aid training for almost 5,000 students, and we will be taking requests from schools, going out, doing the mental health first aid training teen to teen. It's been developed very carefully to work just with kids and how kids can talk to each other.
So when you say schools, Commissioner, do you mean school districts, or do you mean?
No, I mean individual schools.
Individual schools.
We're hoping it's for individuals 9th to 12th grade. So it's mental health first aid for high schools.
Thank you so much. Then my next question for you, Commissioner, is I just wanted to learn a little bit more about and this is the larger executive pot that deals with mental health from the disparaged groups, individuals, groups, and organizations. The name of the pot of resources is escaping me now, but I know that there was an investment in the barbershop mental health program that I helped get started 2 budget cycles ago, and it was supposed to go towards the Arthur Ashe Institute. Can you report out on how that funding has been spent and how successful that program has been in the eyes of your agency? Or, if it's a collaboration with you and DOH?
It's been a collaboration, and I think I can get back to you on that. I'm not as up to date because I think it's been through DOH, but we can get back to you on that.
Okay, thank you so much, Commissioner. I hope to also invite you out to my district to see some of the work that we're doing, because you can't stay all the way in the 58th. You got to come to the 31st,
I'd
too.
love to. I'll love to. We'll definitely do it.
Thank you so much, Commissioner.
Thank you. Thank you.
Brooke for her 3-minute follow-up.
There we go. I did it earlier. All right, thank you, Commissioner. I just wanted to follow up because I think a lot of the discussion that we had throughout this, and thank you for all of your thoughtful answers. I think they were really helpful and will be for all of our budgetary decisions. But it seems like there is a theme, right, that we are, while we have invested, including the $1 billion that the governor announced a couple years ago around supportive housing, around SOS teams, ACT teams, all of this community outreach and building up beds and all of these different things, it seems like we still haven't fully built up and even spent some of the funding that has been allocated. And so, my final question to you is, when we look at the efficacy, right, when I hear you talk about 884 individuals that SOS teams have helped find permanent housing, that means they are not jumping back out. It's not a bad discharge and they're going right back out and not having their, basic needs met and potentially, suffering themselves. They are permanently housed. They have dignity. They are on a road to find employment, perhaps on a road for rehab, right? So it tells me that we need to do more with housing first. We need to do more with getting people the care they need. We need more community outreach, whether in our New York City suburbs or in our upstate communities. And so what troubles me is that there's this big change around involuntary commitment, thinking that this is going to somehow solve this when we haven't even fully implemented some of the things that we have funded. So, big question for you. What do you need to act more swiftly to get those, I think it was 2,000 supportive housing beds online quicker? What do we need to do, and what do you need from us to hurry that up and get that done as quickly as possible so we can serve people in the way that we have seen works really well?
Yeah, I think, first of all, just speaking to housing, those 2,000 beds that are not up are capital. And what we do need help with is what was mentioned by Assemblymember Gallagher, is communities accepting these services. One of the biggest delays are siting for mental health housing. And our providers are really good at this, but especially in urban areas, it's been very difficult to site some of this housing. So we really could use the support of legislators and communities to work with us, because housing, it benefits communities. It can be beautiful housing. So we do need help with that, because that has delayed. In fact, sometimes we have housing out there for years waiting to find a site where we can actually provide the housing. And again, once you build the housing, you're not stuck with these rent costs going up. You're not costs with other things. We subsidize, we make sure the housing is successful in an ongoing way. So that's one way that could be incredibly, incredibly helpful. The other is, I think, again, to work with us, with communities to
Get back to me. Thank you. Thank you.
Thank you. +1 to Senator Brooks' question there. And I appreciate your answer, and I think it's obviously one we're going to continue to have those conversations. I have a question sort of a little bit different, which is also the issue of children in need of outpatient behavioral health services through Medicaid. And, a recent study showed that only 1 out of every 4 kids who need this service are actually receiving them. So the question is, what kinds of new investments in Medicaid rates and workforce are being advanced in this budget to meet that unmet need? And also, of course, the big issue is also the Medicaid rates not keeping pace with the cost of providing care. So our children, particularly post-COVID, are, suffering greatly. And the amount of mental health needs for younger children is increased. I mean, we've never dealt with it enough, but now we have even more need for it. Can you tell me what it is that the state is doing and how it could help get the providers to be able to actually provide these services to children who are in need of them?
Yeah, I think that there's been let me begin with one place where we're making a big investment is something called Healthy Steps in pediatricians' offices, which has a mental health worker in a pediatric practice of 1,500 or more families. And we've been able to spread this across the state right now so that 191,000 kids are covered and ultimately over 300,000. This kind of prevention is really critical with kids. You want to begin early. So first of all, there's prevention. There's prevention that happens in the pediatrician's office, and then the prevention that happens in schools. And that's where the school-based services come in terms of having those available, and also working, as we've talked about, with mental health first aid with teens. And then the next level are individuals who need, so you want to do your prevention, and then you want to have access to care when it's needed. So by expanding our certified community behavioral health centers, we're greatly expanding the access to kids services. And the good things about certified behavioral health centers, which cover the whole lifespan, do a lot of child work, is they're cost-based. So at the end of the year, if it costs more to serve 2,000 kids than it did the year before, you can be reimbursed for that. So that helps with the reimbursement. In addition, we have increased rates consistently for child services, increased rates inpatient side, increased clinic rates for kids, partial hospitalization rates for kids. And in fact, in the last year's budget, we also increased the number of partial hospitals startups. Partial hospitals are kind of community-based intensive services. We've increased rates across the board over the past several years for children's services. So that has helped to make the services more available. And then finally, for the most intensive needs,
Thank you.
Let me know later.
You clearly will have follow-up with all the chairs. One last 3 minutes for Senator Fernandez.
Thank you so much. I mentioned before co-occurring disorders and streamlining the three-tiered system. Could you just expand a little more in these next 3 minutes about how someone can navigate getting all services dealing with a mental health disorder and a substance use disorder?
Yeah, so the three-tier system, the second tier is critical because it says that basically our mental health clinics and our substance use clinics are really able to provide a lot more integrated care and get paid for it than they have been currently, even without doing anything to change their licenses. And so that's an educational phenomenon. You can basically bill for opioid treatments, you can bill for alcohol treatment, everything in a mental health clinic. It's making it clear how you do that, how you can get reimbursed, so the clinics are more open to do it. So that's where the regulations are shifting. The third tier will be individuals who, for example, clinics, for example, that would provide the most intensive mental health services as well as the most intensive substance use services. Under one license, not having to deal with two agencies, just consistent billing, consistent documentation, making it so much easier for integrated care. What we have now often requires some different documentation, requires different ways to bill. We're getting rid of all that, and basically, if you're doing integrated care, it won't be as complicated within the individual clinics. So basically, the three-tier system, which we're putting forward, I think will be really a breath of fresh air for the community.
Thank you.
Thank you very much, Commissioner. I think we have used up the time we have with you today. You have more questions to follow up with some of us, so we appreciate it, and we sincerely appreciate the work of your agency. You're hearing frustration from us because it's all not fixed, and mental illness is actually becoming a growing problem in our communities, so we need to keep working together and get the best answers we can. So thank you very much for your time, and thank you to all of your agency staff and your contract agencies throughout the state who do amazing work every day. So thank you.
Thank you.
And any legislators who want to grab the commissioner out in the hall, not in this room, so that we can move on to our next panel of patiently waiting commissioners. Dr. Chinazo Cunningham, Commissioner of the New York State Office of Addiction Services and Support, and Acting Commissioner Willow Baer, New York State Office for People with Developmental Disabilities.
How do I get on Gary's list when he's not here?
I'll write your name down.
Thank you so
Hello.
much.
Good afternoon, everyone. Hi, and is it all right if we go in the order here? Oasis first? Is that okay, Commissioner? Yes, okay. Just for the tech people behind, so they have your name right when they put your screen up, each of you introduce yourselves now.
Great. I'm Dr. Chinazo Cunningham, the Commissioner of OASS, and good afternoon, Senator Krueger, Assemblymember Pretlow, Senator Fernandez, Assemblymember Steck, and distinguished members of the legislature. My name is Dr. Chinazo Cunningham, the Commissioner of the New York State Office of Addiction Services and Supports, and I thank you for the opportunity to present Governor Hochul's fiscal year 2026 executive budget and how it supports our work at OASS on behalf of those who are impacted by addiction. This is my 4th year of presenting the OASS budget. Over the past 3 years, New York State experienced both the COVID-19 pandemic and a devastating overdose epidemic. We met these challenges by following our guiding principles of data-driven decision-making, harm reduction, and equity. Through these efforts, we are now seeing positive results. Most importantly, overdose deaths have declined by 17% statewide. That's roughly 900 lives saved through our combined efforts between 2023 and 2024. We are optimistic about this trend. However, we must remain focused on saving more lives by bringing innovative prevention, treatment, harm reduction, and recovery services to those who need it. Today, I'm proud to share some of our 2024 accomplishments and detail how this year's executive budget helps us build on our foundation of progress. From the start, New York has distributed more opioid settlement funds to localities and community-based organizations faster than any other state in the nation. OASS is responsible for distributing 36% of the state's settlement funds and does so with efficiency and transparency. A recent report noted that our state received and allocated the largest amount of settlement dollars received nationwide. To date, OASS has made nearly $400 million available to address substance use disorder and overdoses. This year's executive budget includes roughly $63 million to help support our continuum of care across the state and in alignment with the Opioid Settlement Fund Advisory Board's recommendations. That includes establishing initiatives to increase medication treatment availability, including expanding access to methadone treatment, along with low-threshold buprenorphine treatment, scholarships to support the workforce, youth prevention programs, recovery center and transportation supports, enhanced outreach and engagement, and more. I'm extremely proud to report that our online portal continues to make free, life-saving harm reduction supplies available to the public. Thus far, over 250,000 naloxone kits and nearly 22 million fentanyl and xylazine test strips have been distributed from OASS alone to individuals and organizations across the state. Just recently, a Poughkeepsie high schooler successfully administered naloxone while at his local barbershop. The teen had ordered the naloxone online through the OASS portal after receiving a lesson on how to administer it during his health class. Our outreach and engagement work has served over 90,000 New Yorkers. In addition, the state now has 3 mobile medication units up and running. These units bring addiction services, including methadone treatment and other medical care, directly to underserved communities. As Governor Hochul has highlighted, additional funds will help us roll out more units in 2025. The fiscal year 2026 executive budget will allow OASAS to continue these critical initiatives and enhance support of our provider system and the individuals they serve. In all, the proposed OASAS budget contains nearly $1.3 billion, including roughly $190 million for state operations, $964 million for aid to localities, and $94 million for capital projects. It continues opioid stewardship funds that allows OASAS to support harm reduction services and medication and treatment affordability. Workforce recruitment and retention remains a priority across the OASAS continuum of services, especially as we strive to increase capacity in our system. To address this challenge, OASAS has made historic investments into the addiction workforce to support and expand a skilled, compassionate network of professionals. This includes a partnership with SUNY and other colleges, universities, and community-based organizations, which has resulted in over 1,000 individuals receiving scholarships for addiction training and more than 80 medical and behavioral health fellows at 4 medical schools across the state. The executive budget includes $12 million in additional support for a 2.1% targeted inflationary increase to provide fiscal relief for service providers, as well as an additional $6.4 million minimum wage increase. This action builds on OASAS workforce initiatives, including a new leadership institute, enhanced peer supports, scholarships, and paid internships, and an online addiction credentialing portal. Treating individuals with co-occurring substance use and mental health disorders calls for close collaboration between OASAS and the Office of Mental Health. The budget supports ongoing efforts to triple the number of certified community behavioral health centers to better address individuals' complex needs, regardless of their ability to pay. It also includes an additional $3 million to expand support for joint street outreach activities to connect vulnerable people with needed services. Further, OASAS and OMH continue to roll out crisis stabilization centers, which provide support, assistance, and urgent access to care. We're also jointly seeking to improve access to services for homeless youth. A 2022 state law required medication treatment for all substance use disorders in carceral settings. It is no small achievement that all 42 prisons and all 58 jails have implemented all forms of FDA-approved medication for substance use disorders. We are a national leader in this work, representing the largest such implementation in a state carceral system nationwide. In the first year of implementation, the number of people who received medication treatment for substance use disorder increased more than 5 times in prisons and more than 3 times in jails. State revenues from casinos and mobile sports betting help empower OASAS prevention efforts to promote and encourage responsible gambling. Our Take a Pause public awareness campaign is airing throughout the NFL playoffs and Super Bowl, asking people to examine their betting habits. Our Problem Gambling Bureau has also worked to eliminate barriers to training, collect and study data on gambling behaviors, and enhance problem gambling prevention, treatment, and recovery services. With the legalization of adult use cannabis, OASAS is raising awareness for its responsible use through a new cannabis prevention toolkit that is available in English and Spanish, giving parents and mentors practical tips and guidance on how to talk to teens about the risk of underage cannabis use. In addition, we're gathering important data from youth about their cannabis behaviors and attitudes while training providers and schools on the prevention and treatment of cannabis use disorders. The OASAS continuum of services includes programs and supports to help individuals achieve and maintain their personal health and recovery goals, including new OASAS certified recovery residence regulations. This represents the first recovery support service to be certified in the state and allows recovery residences to voluntarily apply for OASAS certification. I urge those who are interested to visit our recovery residences webpage to learn more. Lastly, the proposed budget includes ongoing support for a 5-year capital plan to ensure the health and safety of individuals and proper maintenance of facilities. As outlined today, the proposed executive budget allows OASAS to build on a proven foundation of progress based on an equitable, person-centered, data-driven approach. OASIS will continue providing a full continuum of prevention, treatment, harm reduction, and recovery programming and services, all towards our goal of further reducing overdose deaths, improving lives, and preventing addiction. We appreciate your ongoing support and look forward to working with you to better serve those in need. With that, I welcome any questions. Thank you.
Thank you very much, and I'm now going to, no, sorry, we don't ask questions until we do both commissioners. So please, Acting Commissioner, introduce yourselves.
Thank you. Good afternoon, Chairs Kruger and Pretlow, Disability Committee Chairs Fahey and Santa Barbara, and other distinguished members of the legislature. I am Willow Bear, Acting Commissioner of the New York State Office for People with Developmental Disabilities. Thank you for inviting me to be here today to speak about the historic investments included in Governor Hochul's fiscal year 2026 executive budget that benefit people with developmental disabilities, their families, not-for-profit providers, and our vital direct care workforce. In my time as Acting Commissioner, I have had the privilege of traveling around the state to speak with many of our stakeholders, many of you and your constituents. This has allowed me to better understand the needs of people with developmental disabilities and the challenges that the system faces. I have learned about innovative approaches that many of our providers are working on and have heard from people with disabilities about what they want, such as improved access to quality health care, housing, and employment. I've also seen the importance of prioritizing efforts that enhance our provider network, advance our workforce, and respond to the changing demographics of the state. I'm excited to highlight several of those proposals included in this year's executive budget that respond directly to the requests of people and families, challenges providers have shared, and to what I believe our service system truly needs. For the fourth year in a row, Governor Hochul has included funding that recognizes the imperative role that our providers and direct support staff play in the lives of people with developmental disabilities across New York State. The fiscal year 2026 executive budget includes an ongoing investment of $850 million in recent rate increases, allowing our not-for-profit service providers to afford the increased cost of doing business, and most importantly, to increase wages for frontline staff. Additionally, the executive budget proposes a 2.1 targeted inflationary increase to further address the rising operating costs in our service system. These investments, especially when combined with Governor Hochul's historic $5 billion proposal to make New York State more affordable, provide incredible support towards the stabilization of our provider network and the advancement of our workforce. When added to funding that has been provided since 2022 for cost of living increases, rate updates, bonuses, and American Rescue Plan projects, these proposals equal almost $4 billion invested in the developmental disability service system to improve recruitment and retention of staff for OPWDD not-for-profit service providers. Coupled with initiatives like OPWDD's More Than Work recruitment campaign and collaborations with the National Alliance for Direct Support Professionals, as well as with the State University of New York to provide certifications, credentialings, and college credits that professionalize our workforce, we have been able to improve retention and recruitment in our field, as well as significantly reduce the state's reliance on mandatory overtime for these workers. While we all understand that increased funding for providers has enhanced wages for our workforce, and these are imperative to the service system's ability to provide quality supports and services, we also recognize that the demographics of our state and the needs of those we serve are continuously changing, which is why as an agency we have prioritized additional efforts to support people by improving access to both certified and non-certified housing, investing in technology advancements for people to live more independently, and reducing the administrative burden on our providers as part of our strategic plan and short-term housing strategy. It's also why we are prioritizing the changing needs of an aging population, as well as the complexities of serving people with disabilities and co-occurring mental health diagnoses. And as an agency, we remain committed to efforts that ensure we are meeting the needs of all communities in New York State through our diversity, equity, and inclusion efforts, which include staff training, extensive stakeholder engagement, and strengthening the linguistic and cultural competence of our system at all levels. The executive budget continues investments in new service opportunities to meet the needs of people coming into our system or whose needs have changed, with $30 million in new state resources, which when matched by the federal government can total up to $120 million on a full annual basis. To further our goal to increase independent housing opportunities for people with developmental disabilities, the proposed budget also continues the annual $15 million investment for integrated community-based housing projects for people with IDD. Around the state, I have repeatedly heard about the challenges that people with disabilities are facing as they try to meet their basic healthcare needs. Some people wait years for dental care, others can't find a doctor to serve them because the offices are not accessible for physical or sensory needs, and some have simply not received care because doctors' offices do not have the right equipment to meet someone's specialized or mobility need. This year's budget includes funding to reduce these gaps in healthcare for people with developmental disabilities. To increase access to health services, a $25 million capital funding investment is proposed in this year's executive budget to support the creation of regional disability health clinics at existing Article 28 and Article 16 clinic locations across the state. These grants will be awarded through OPWDD, and funding will be used to update or expand buildings, equipment, and technology to increase accessibility and improve the quality of healthcare provided to people with developmental disabilities statewide. The governor's proposed budget also calls for a $75 million capital investment in OPWDD's Institute for Basic Research and Developmental Disabilities, or IBR. IBR opened in 1968 as the first large-scale institute in the world designed to conduct basic and clinical research into the causes of developmental disabilities. This important funding for IBR will be used to modernize the institute's infrastructure and expand its capacity to conduct cutting-edge research that will help identify a person's medical and behavioral health needs earlier in life. Significantly, it would also include the establishment of a genomics core facility to better understand how genetics influence people's developmental disabilities and underlying medical conditions. This will situate IBR to become a national organization for rare diseases that delivers top-tier diagnostic testing for people with developmental disabilities and serve as a nationwide resource. In addition to increasing access to healthcare, people with developmental disabilities have repeatedly shared with me their interest in meaningful, gainful employment. We are proud that Governor Hochul signed Executive Order 40, making New York an employment-first state, and has continued her commitment in this year's budget with 2 proposals that increase tax credits for businesses that hire people with disabilities, as well as proposing to make changes to New York's Preferred Source Program permanent. We must continue to prioritize making sure that people with developmental disabilities have access to competitive employment throughout our communities. At OPWDD, I have prioritized hiring people with developmental disabilities, ensuring that our agency decision-making is informed by those that our decisions impact most, and I cannot overstate the benefits that hiring someone with a developmental disability can add to your workplace. Finally, I would be remiss if I did not highlight the important investment being proposed to commemorate New York State's disability rights history by establishing a Willowbrook Center for Learning on the former state school property. What happened at Willowbrook forever changed the way we provide services and supports for people with disabilities. In fact, the advocacy of people who lived at Willowbrook and their family members sparked a nationwide civil rights movement that continues to this day. The Center for Learning will forever preserve Willowbrook's historic significance by highlighting how far we have come and will serve as a reminder of what we must continue to fight for. I am proud of the progress that OPWDD and New York State have made to better meet the needs of those we serve since the closure of Willowbrook. And I also know that there's more work to be done, which would not be possible without the incredible support that Governor Hochul and this legislature have given our service system. Together in collaboration as we enact a new state budget, I have no doubt that we can reach our goals of a more person-centered, inclusive, and accessible New York for people with developmental disabilities and their families. So thank you for allowing me to be here today, and I look forward to the conversation.
Thank you very much, both of you. And our first questioner will be Chair Fernandez.
Okay, thank you so much. Thank you so much, Commissioner. It is great to work with you, and I thank you for your dedication. Oh, yeah, put on the 10 minutes. I'm kidding. That's a rude to snap. Okay. All right, 20. All right, well, thank you so much for everything that you do. Wanted to touch about the opioid settlement funds and transparency. There's been some concerns about the transparency into where the money is going. Would it be feasible to require the localities and state share of the opioid funds not housed in the opioid settlement fund and overseen by OASIS to report to OASIS? And what would you need to make that happen?
Yes, we're very proud of our really effort to be transparent with the opioid settlement funds. As you said, of the 36% of the state dollars that come through OASIS, we have a website that shows exactly how every dollar is used, where those dollars are going, which organizations are getting funded, what categories of funding they include, how much the counties get, et cetera, et cetera. I think, of the dollars that don't come through OASIS and really come from the Attorney General's office, we are working with them to figure out in terms of reporting how we can get reports from those dollars outside of us. So we are working with them, and we anticipate, as programs have had time to actually implement those opioid settlement funds, of getting those reports of how those dollars have been used, and then we'd be happy to add that to our website.
Okay. Do you have any concerns about what information is made publicly available about the opioid settlement funds given the hostile federal administration, such as funds being used for syringe exchange programs and other harm reduction initiatives?
So a lot of, harm reduction was certainly the top priority of the Opioid Settlement Fund Advisory Board, and that has been a top priority at OASIS as well. And I think a lot of the harm reduction efforts have significantly contributed to the reduction in overdose deaths that we've seen, so that 17% reduction. So certainly, continuing to expand naloxone kits, fentanyl test strips, xylazine test strips, doing outreach and engagement, meeting people where they are, I think is really part of the important, sort of secret to the sauce. We also work with our collaborators at the Department of Health. A lot of their work is with the syringe exchange programs, and they do get some of the dollars from the opioid settlement funds to support that work. So I can't speak specifically about the work that they're doing, but certainly, continuing to expand our work and with harm reduction, and the governor certainly embraces harm reduction, is a priority both of the board and of us, and can be seen how those dollars are used on our tracker for the opioid settlement funds.
Okay, yeah, we have a xylazine test strip bill too that we should consider. But this budget was pleasant to see. There was an increase overall in a lot of items, particularly for IT and system updates, which very happy to hear because in some of the locations that I've seen, it looks like they were still using Windows 95. So to get this upgrade is very much needed. And very happy to see that the vocational and job placement services, the funding, the 11.4 was kept in. But with the question that comes, when will the procurement be available for organizations concerned about a funding gap?
Yeah, so we've worked very closely with the organizations that provide vocational services to think about how we can better and more equitably ensure that these vocational services are available to all New Yorkers across, the geographic regions and across a whole continuum of services. So, not with treatment, with recovery services. And so, so we have worked with them, and through that, we're developing a new model so that we can ensure that there's more equity across the state. There will be no gap in services, so we will continue to fund. We have been continuing to fund those programs that are currently providing services, and we will up until the point where we have new contracts executed. So we plan to, release a new RFP with this new model in the coming months. But the services will not be interrupted. They will continue to have funding up until the new contracts are executed.
Very nice. Regarding recovery services, is it true that the only funding source for recovery services is through the opioid settlement funds?
So some of the recovering services are also through the state aid as well. So we enhanced recovery services through the opioid settlement funds. So all of our recovery centers, the 31 of them funded throughout the state, had increases in their budgets to really equalize across the state to make it, again, more equitable, and to really enhance their services. And so that includes, enhancing the peers, people with lived experiences, enhancing their services and who they're providing, collaborating with across the communities, and some of them enhancing their sites where they have their community centers. So it is a combination of funds from from state as well as the opioid settlement funds.
Okay, and when the opioid settlement funds dry up, will the state compensate those funds?
So, what I would say is that sustainability definitely is an issue that we are aware of, and we need to ensure that there are sustainable funds. And so for that reason, with our opioid settlement funds, we have multi-year initiatives. So that's built into the existing funding. So they are funded for several years at this higher level.
Okay. In the executive budget, language allows EMTs and paramedics to administer buprenorphine for emergency treatment. Will OASIS oversee the training of EMTs?
So the EMTs really don't fall under our purview. They fall under the Department of Health, but we're certainly happy to collaborate with them as we do in many ways. We think that this is certainly an important part of just expanding access to medication treatment because we know medication treatment saves lives.
Thank you. OASIS has street outreach teams that operate, and there is more funding to do more street outreach teams. Is there any concern that these teams will be used to increase the number of people brought in under the possible proposed involuntary commitment changes?
So our funding for these outreach teams is really focused on the addiction piece of it and making sure that people have the resources, the education, and the linkage to services that they need. So we work closely right now with the Office of Mental Health already with some of the outreach and engagement teams, and we will continue to enhance that. But it's really bringing our addiction expertise for example, to some of the OMH outreach teams so that we can better address people who have the comorbid conditions, or the dual diagnosis of mental health and substance use conditions. But our mental health professionals, are not trained on the specific mental health diagnoses.
Okay. This budget also, again, lists a lot of new scheduling that would match what the permanent federal scheduling is. Has scheduling helped curb overdoses in New York State overall?
So that's a very difficult question to answer. I mean, we know that the overdose rates are going down, and I'm sure it's multifactorial as to why. We certainly are confident that a lot of our harm reduction efforts and our improved access to treatment has been a big part of that. But in terms of, law enforcement efforts, that's just not something that I can speak to because obviously we're not a law enforcement agency. So I think, again, it's not 100% clear about why the rates are going down, but certainly I know our efforts are, significantly contributing to that.
Okay, because I just would wonder if there is stats, proof that show that scheduling and matching at the state level, if we already have it at the federal level, why would we need it at the state level? Is that something you can answer?
Yeah, so I mean, I'm not aware of any specific research looking at different scheduling and how that impacts outcomes. The scheduling, really, that issue is under the Department of Health. And so that's actually not under our purview, so I'm just not aware.
Okay. Last question. So harm reduction, thank you again for championing this effort and for what we've seen it do in the state. Do you think other forms of care, such as prevention, treatment, and recovery services, receive the funding needed to meet the CARES needs?
Yeah, so certainly we are fully committed to the whole continuum of services, and that's really a patient-centered, person-centered approach because people need different kind of services at different points in their lives, right? And different people need different kind of services. And so a lot of our work is really to make sure that the whole continuum is working better together so that prevention services, for example, are incorporated in treatment, right? Prevention for the children, for the, of the parents that are in treatment, or, that the linkage from treatment to recovery is also there. So we certainly are investing in our whole continuum of services, and we're continuing to do that, knowing that it's not a linear trajectory, right? That people kind of can bounce around in the whole continuum of services, and making sure that we continue to do that and enhance that collaboration better.
Okay, thank you. I'll probably have to come back, but gambling addiction, I know that there is a stream going to services based on what we currently have in the state with our casinos and gaming. It's been told to me that we have some of the best gambling services that have been nationally recognized. And never mind.
Hold that answer. Assembly.
Will they answer? Assemblywoman Simon? I'll be back.
Yep.
Who's after Simon? Hi, thank you so much for your testimony and your hard work. I have a couple of questions about, if you can, Acting Commissioner. In your testimony, you talked about this $75 million investment in the Institute for Basic Research.
Yes.
And, which sounds terrific. I guess one of the questions I have is, what kind of reporting out has the Institute done with regard to issues such as, the causes of developmental disabilities? Over our history, we had the rubella epidemic at one point, and then we've had other things. What are the current information that you're finding with regard to, causes of developmental disabilities?
So we are very excited about the $75 million investment in IBR. We
That's
know
great.
that people with developmental disabilities have a very high propensity for co-occurring underlying medical conditions and mental health conditions, and that's really why the Institute on Basic Research was opened in the 1960s, right, to do that in-depth research to provide clinic services and assessments on site, which they continue to do today, and to really educate the public about developmental disabilities, and all that work has continued. We've not had a significant investment in IBR since that time, so this really would be the first significant investment to update our ability to do that research in laboratory. But to your question about what data, right, we have a number of research scientists employed at IBR that are continually researching and publishing articles in scientific journals and partnering with other states and national organizations. We certainly can make some of those materials available to you. There's a lot of really fascinating work going on, particularly with Alzheimer's and how it relates to Down syndrome is a big focus of their work right now.
Okay, great, thank you. That would be very helpful because I think there are, I'm not sure where that information is getting, and of course, there's also always conversation about what causes what out there in the ozone, and having some more information about that, but also allows providers to provide better information, even when you look at our schools, where a child may have X disability and have an IEP, and the school may not be aware or recognize or want to believe that there's also a medical condition that tends to go along with that presentation so that they're able to better provide those services. So I think that could be very helpful to us at various levels.
I think that's so important. We've had genetic testing available through IBR on a limited capacity, and the families that are able to participate in that genetic testing have had just life-changing impacts from really understanding the comorbidities and impacts of medication and treatment. And so really excited to make that more available.
Great, thank you very much.
Thank you. Senator Pat Fahey, Chair.
Thank you, Chair. Thank you, Commissioners. Just a couple of questions for OASIS, and then I'll save mine for OPWDD, and welcome to both of you. Thank you for being here. I think there's been some indication between both agencies that you are looking to address the children who have dual diagnoses, and wondering what the plan is on that and what the timetable is for providing services for children who may have a dual diagnosis, as well as adults. If you could take that, Commissioner, with OASIS. Commissioner Cunningham, please.
Sure. So when we talk about dual diagnoses, a lot of our focus is on those who have.
If you could speak up, it's really hard to hear in here. Thank you.
When you talk about the dual diagnosis, a lot of our focus has been on those with co-occurring mental health and substance use disorders.
Yes.
We work very closely with OMH in many ways. In terms of children specifically, so as OMH is increasing their footprint in schools, we're working with them to ensure, for example, that substance use prevention services are also incorporated in that. The youth clubhouses, which Dr. Sullivan also talked about, we have many youth clubhouses across the state. We're collaborating with OMH there too to think about how we can do a better job of addressing, providing services to those with comorbid disorders in the youth clubhouses. So those are some examples in which we're working closely with them to address their comorbid illnesses.
Thank you, and I'll save to switch for another couple. I just want to share the comments of our Drug and Alcohol Abuse Chair, Fernandez. With regard to transparency, I welcome more transparency on some of our funding. And as somebody who spent 5 years trying to advocate for change here on one of our OASIS sites, treatment sites, I know that wasn't authorized under your leadership, but it was a very opaque process, and hope we don't repeat that. I think we have addressed it, but when we have sites right in a commercial corridor, right on a street level with everyone else, it's been a very difficult process, and look forward to continuing to work with you such that we don't have a repeat of that here, which has really harmed the area, let alone, I don't think, served those in treatment as well as it could have. But thank you for working with us for a better outcome there. I'm going to switch gears now to Commissioner Baer. Just a few questions. Can you start with what is the wait list of those who have been certified and on a wait list for either one of your run facilities or one of the nonprofit facilities? We hear a lot about the demand.
Sure, we actually don't have a wait list in New York State for certified residential opportunities, but what we...
If you could speak up, it would really help if you could pull that mic. I'm sorry, it's very difficult here.
No, don't apologize. How's that?
I'm sorry, not a wait list?
We don't operate a wait list in New York State for those services. Where there are vacancies in the certified residential opportunity continuum, that usually is because of one of three reasons. Either there's a need for physical plant renovations, there's a lack of staffing, which is most significant, right? Or we are actively working to match someone who's seeking residential services with that placement opportunity. That is a very person-centered process. That provider has to be able to meet the physical needs of that person, the behavioral needs of that person, the health needs, and then that person or their family have the right to say they don't want to be served by that provider or in that part of the state. So that is a very person-centered process of matching those two. We took a really hard look this year at our certified residential opportunities list and thought about what are those three main obstacles and how could we address them, and we included that update in our most recent strategic plan. So on the staffing side, I talked earlier about the $850 million investment in those providers, which will really go a long way towards helping them staff those vacancies so they can move people in. We've looked at our administrative processes around physical plant reimbursement and trying to make that a much more efficient process of getting those dollars to providers to make those capital investments faster. And then on the third side, the investments that this governor's made in allowing us to update our IT infrastructure. We've started a really robust process of automating our systems, really catching them up to modern day so that we can track who's looking for those opportunities and what all of those opportunities are, so we can do a much more efficient job of matching people to them.
Okay, thank you. And as you know, we hear from a lot of parents, especially aging parents, very worried about where their children will end up, or how they will be cared for when they may not be able to. The pay, can we talk a moment about the pay differential? When we spoke, Commissioner, I know there was a rebasing that I think was put into the budget last year, and I think that has helped with a number of the facilities. Can you talk about that pay differential that I know was finalized at the end of 2024, and how is that helping? The governor has proposed a 2.1% COLA increase. Is the rebasing, is that helping with pay? And of course, the advocates are asking for a 7.8% increase. How, that's quite a difference. Can you address that, please, and let us know if the rebasing has helped with that, getting down to the workers and paying, especially the DSPs?
Sure, I think it's a really important question. This governor, this legislature have invested $1.3 billion in COLAs and targeted inflationary increases to the OPWDD service system over the last 4 years. The rebase that you mentioned was our federally required 5-year rebase of those services and really getting them caught up to the modern day cost of doing business. We know that in the last 5 years, inflation ran pretty rampant. We had a global pandemic, right? So there were a lot of increased costs that those providers were desperate to have matched in their rates. So that rebase process that we went through invested $850 million across the state. That's an average of a 13% increase for those providers. It has gone so far to get them caught up to the modern day doing business, which then of course is compounded by things like the 2.1% inflationary increase to keep them whole and to keep them on the right path. I've heard from providers that that increase was immediately enabled them to increase direct line wages by $4, $5, $6, $7 an hour in some regions of the state, and has made an immediate impact on their ability to recruit staff, which was exactly what it was intended to do. So we're very excited about that.
Yes, thank you, Commissioner. And if there's a way to get a list of those agencies that did receive that, because while we've heard that from a couple, it would be good to have a sense of how many of the providers did feel that impact and how many are passing it on to the workers. That would help tremendously. I also need to commend you on the Willowbrook, the Center for Learning. I missed the ribbon cutting, but I think that's a wonderful way to preserve it, remind us of the history there, and make sure we're doing the research to prevent that in the future. Dental care, it is a crisis. You mentioned it. Is there anything that we should be paying attention to here? It is something here in the Capital Region we have heard where it's an extraordinary crisis where we've lost 4 Medicaid dental care providers. Sorry, we had 4, we're down to 1, which is the Center for Disabled. Can you talk about other ways to address this, particularly for those who are a little harder to serve?
Yeah, dental care is so important. Dental and health care were some of the first things I heard about when I stepped into this role and started meeting with families and self-advocates about what they really needed. We, in state operations, where we have the ability to have a little more control over providing those safety net services, have really tried to focus the last few years on building out our ability to provide dental services in our Article 16 dental clinics in various parts of the state. We're also working now, we hear all the time that people with pretty significant disabilities are unable to receive dental care because of their sensory concerns and response to being in a dental chair. So what we're working on finalizing in state operations is a pilot where we could provide mobile anesthesia to dental clinics. So the mobile anesthesia could arrive at the dental clinic and make that patient's appointment that much easier so that they can get that care that they need. So there are certainly ways that we're looking at providing expanded access to dental care, and we see that people with disabilities who lack dental care have a lot more behavioral and long-term health outcomes. Yeah.
Thank you, and I would love to hear more about that because it is something that comes up repeatedly. In the last few seconds, you mentioned a funding request for disability clinics. Again, I know our Center for Disabled has one of those clinics. Can you tell us how many more and where those are being proposed for in the budget?
I'm glad you're familiar with the Center for Disability Services. That's exactly the type of clinic that this idea is modeled after, right, is to make that type of really integrated health services available to more people with disabilities throughout the state. We hear that people drive hours to get to places like the Center for Disability Services to receive that health care, or they have to receive their pap smears in the hospital, for example.
You have 5 seconds, so how many are you proposing?
Up to 5.
Thank you, thank you, thank you to both commissioners. Thank you, Chair.
Thank you. Assembly.
Assemblymember Simplewinski.
My questions are for Commissioner Baer. And just before I start, I wanted to say thank you for everything your department does. We're having this dialogue because I'm an assembly member, but before that, I'm a father of a special needs child. I have a daughter with Down syndrome. Her name is JoJo. And so thank you for everything you do, taking care of folks like her. I know a lot of the folks that are on this committee have connections to folks that have developmental disabilities, so thank you. I want to inquire about the $850 million investment that was just announced. What's the timeline for that getting out, and what is the sort of assurances it's going to get to all different parts of the state? Because I represent an extraordinarily rural portion of the state of New York.
Great. The $850 million rebase that I mentioned goes to all of our certified residential programs and site-based day programs. So it is a massive swath of our providers in every part of the state. and that's part of our federally required 5-year rebase. We did send a letter to those providers as well, and letting them know that our absolute expectation was that that money be used at least in part to increase wages for frontline staff, to increase them to a living wage, which is what we have seen happening. Those funds are available now. It was paid retroactive to 7/1, which was the effective date of those rates. So we're very excited that providers now have that cash in hand.
Awesome. I'm going to ask the same commissioner same question I asked the commissioner, the Office of Mental Health. We were talking about the 2.1% proposed COLA. We call it a COLA or a TII or what have you, but it doesn't match the rate of inflation. And we've had smaller COLAs over the past few years, none of which have quite hit the rate of inflation, so they're not quite truly a COLA. It's still effectively a cut. Why don't we just, as a matter of standard operating procedure or budgeting, just start with whatever the rate of inflation is and go from there? Why is it always lower and then we have to sort of try and work to catch up?
Well, I certainly defer to the legislature and the governor's office in negotiating the language of what that statute requires. But what I can say is that the 2.1%, which is $116 million for my service system, really will help build upon the $850 million investment to make sure that our providers are keeping current and keeping track with inflation at this point.
Well, I respect that, and certainly 2.1 is better than 0. But when inflation is significantly higher than that, it's just less of a hit as opposed to keeping people even. And I would imagine, since we have to do this sort of negotiation every year, that for providers, it provides a situation where there's certainly a lack of certainty as to what they're going to be able to pay folks, and gets herky-jerky for what they have to do to plan. My last question is, as I mentioned, I represent an extraordinarily rural area of the state. For whatever particular agency we're dealing with, it's always difficult to access systems. For folks in rural areas, how good of a job are we doing of making sure that they're getting their services near where they live as opposed to having to go to other parts of the state?
Yeah, and that's why OPWDD is split into regional offices, right? So we can really make sure that we're keeping track on a regional basis of what the needs are for people that live in those communities, and to develop networks of providers to support them where they live in those regions. I know that the more rural regions, we certainly have robust provider networks in places where they're needed. I know that we continue to work on things like enhancing transportation and access to telehealth and more innovative ways to deliver those services to those communities.
Well, I'd ask you to obviously continue to do that. And again, thank you to yourself and your department for the work you do.
Thank you.
Egypt. Oh, okay. Are you done? I don't want to cut anyone off. You still have a little time. Okay, thank you. Thank you. Next is Senator Weber. Oh, okay, Senator Overrocker.
There we go. One of my maladies is I am colorblind, and I've been told that with my choice of tie today, so bear with me on that, Commissioner. Good to see you in Albany, Commissioner Barrett. Good to see you as well. Thank you. Start off where I kind of left off with Commissioner Sullivan. We in New York, I think, have a supply of decommissioned DOC, excuse me, Department of Corrections facilities in a lot of the areas up here. And two of which I'd like to kind of point out here in my district. One is in South Courtright in Delaware. It was the old Allen facility. And in Fallsburg, we just had a closing for one of our correctional facilities. I think we are missing the opportunity to utilize those facilities for the needs and wants for longer term, 90-day plus, looking at treatments for that. So I would encourage us, as we start to formulate a plan again on how to move forward, that we would really look at considering those areas. The facility in Delhi, I think, is strategically located. It's within the transportation hub of Delhi, which is the county seat. So it takes that transportation equation out of it. I think we could, definitely look at that. Commissioner, I had some folks in my office yesterday, and one of the issues they brought up, which I thought was not only interesting, but I wasn't aware of, is as someone is starting to transition out of treatment, IDs are a big concern and almost a roadblock. They can't get any of the other services that they need because they don't have their Social Security card, they don't have their birth certificate. So we maybe should look at some way of having a verification, or more appropriately, something that we could offer that would allow them to get an ID and then, proceed on it. It was something I wasn't aware of, and you're nodding, so I'm sure you are, but just wanted to bring it up that in the ruralness of my district, it's a huge issue. School-based health, huge supporter of school-based health. I think we ought to partner with school-based health and look at seeing where we, from the Office of Addiction Services, how we can partner with them and help them facilitate more of them in the schools. I think if we focus in there, we are focusing in on a way of looking at harm reduction in a new way. To dovetail with that, are you familiar with the one box concept? It's an AED-style box that is for overdose. And what it has, basically, it looks like an AED, and it has, you open it up, it has a flip-down screen. It will actually walk you through the process of administering Narcan. One of my goals in my district, where I have over 65 school districts, is to put one in every one of those schools. So we're talking, again, I think a plan for harm reduction that we can get behind. We have some really great programs. Sullivan County has Hope, Not Handcuffs. It works. And it is taking a way of changing the paradigm as to those that are suffering from substance use disorder. In there was probably a couple of questions, but I'm just trying to make you aware that we really got some interesting things going in the 51st Senate District. I would love an opportunity to invite you to tour with me, as Commissioner Sullivan has agreed to as well, and show you what I have a plan, I think, to address the issues, and a true partnership, I think, can be had. So with that, I'll yield back my 55 seconds, but thank you both for the work that you do. It does not go unnoticed or unappreciated. Thank you.
Assemblyman Stick.
Thank you, Mr. Chairman. My questions are all for the Commissioner of OASAS. The governor has repeatedly said that all of the opioid settlement funds have been, quote, made available. This budget is reappropriating more than $290 million, or more than 60% of the $500 million received. Do you have any kind of timetable as to when these, over what length of time, these funds will be made available to providers?
Yeah, thank you for that question. I mean, as I mentioned earlier, we are actually leading the country in terms of the amount of dollars.
I'd like to ask for the timetable. I heard that statement before. I have a limited time. We need to stick to the questions. Thank you.
Thank you. So we just announced just recently in this past week another initiative, and we continue to announce initiatives as we're moving forward with the opioid settlement funds. So we are continuing it, and that information is everything is on our website. So the minute that we have a new RFP, that is made available there.
Yeah, so in answer to my question, as you sit here now, you don't know what the timetable is over how many years you intend to release those funds to providers. Is that correct?
I mean, we are continuing to constantly release money as we move
You've
forward.
answered my question. Thank you. So you mentioned in your original statement problem gambling. One of the things that we've been approached about is the issue of problems with addiction to sports betting, particularly among young men. Our office contacted Oasis about that. My legislative director represents to me that the response was, we're not doing anything in that area. We'd certainly appreciate to know what, if anything, is being done in that area.
Yes, we have a robust response to problem gambling. In fact, we developed a problem gambling bureau with staff dedicated to really
Sports
addressing
betting
this
in
issue,
particular.
including sports betting. So we have public awareness announcements that are airing during the NFL playoffs, during the Super Bowl, so people can do self-assessments, so they can look at their own behaviors, so they can be linked then to services. So that's one kind of example. We're working, with schools as well. We are doing, all of our prevention providers are working in communities and schools and do education around problem gambling. We've increased our treatment capacity in problem gambling and our workforce who gets trained in problem gambling. We're also collecting a lot of data and doing surveys, working with a gaming commission and the New York Council on Problem Gambling. So there are many, many efforts to really understand exactly what's happening behaviors-wise and to have a targeted approach and increase the capacity in our system.
Have you undertaken any initiatives specifically with respect to Kratom?
So there is very little evidence about the role of Kratom in addiction. As you know, I'm a researcher, and so this is an area that I'm very familiar with. What we do know is that medications like methadone and buprenorphine have decades of research showing their effectiveness, and we know that we need to really improve access to that treatment that reduces the risk of overdose death by 50%. So our focus is on the tried and true treatment that we know from decades of research works.
So there's been representations made that Kratom does some of the same similar things. I know that's unsubstantiated. I was more inquiring about the proliferation of legal sales of various Kratom products throughout the state. I'm wondering just if you have any insight into that.
I mean, we hear on occasion anecdotes, but we don't have data that's systematic about the sale of Kratom.
Okay, thank you. And then it has also been represented to me that alcohol actually causes more death than opioids. Has the Oasis undertaken any new initiatives with respect to alcoholism?
So we also are absolutely, concerned about alcohol, and obviously there are policies that increase the possibility of, getting alcohol, and so this is something that we are working on internally about getting a better understanding, working with the state liquor authority in terms of understanding what's happening across the state and ensuring that we are, doing more prevention with youth and ensuring that our treatment programs are, have the capacity and are providing the best treatment, particularly medication treatment is an area that we're also focused on with alcohol use disorder.
So in many states, particularly Appalachian states, crystal meth is a giant problem. We were of course, parts of New York State could be considered Appalachia, and one of those counties reached out to us that they have a very bad problem with crystal meth. I'm wondering if the department has, or the agency has undertaken any new initiatives with respect to that substance.
We recently published actually an addiction data bulletin that takes a deep dive into the role of stimulants in New York State, and as you may know, that the role of stimulants is associated with 50% of overdose deaths. So this is an area that we are closely watching. Unfortunately, the treatment options for stimulant use disorder are not great. This is something we're discussing, the possibility of piloting across the state some new initiatives, but unfortunately the treatment options are not great. But we want to make sure that people still know they're at risk for overdose, so making sure that they have naloxone and they know, they're informed about the role of fentanyl getting in either the methamphetamine or the cocaine.
So I think you had a comment in your remarks about marijuana. How do you regard the tremendous increase in the THC content of marijuana that has been occurring in terms of the growers are now able to crossbreed and so forth. Do you feel that that increase in the THC content is especially harmful to our residents?
So, we work with the Office of Cannabis Management and certainly talk to them about prevention efforts and our concerns, especially for underage youth. We also, in our prevention work, do a lot on cannabis toolkits. Part of that is the discussion about THC and the role for parents and caregivers to talk to teens, and then also working with schools around this. So we are trying to provide education so people can make, educated decisions and taking a harm reduction approach to reduce the risk of developing problems associated with cannabis.
So medically, is it fair to say that there is such a thing as cannabis use disorder and cannabis-induced psychosis?
Yes.
Okay, thank you. I have trouble convincing some of my colleagues of that. But in any event, the 24-hour stabilization centers, where do the folks go after they've been stabilized for 24 hours? As you know, I've been skeptical of this because we passed legislation allowing hospitals to hold for 72 hours, and okay, they're there for 24 hours, then what happens?
We have a full continuum of services, as you know. So, people can go from the crisis stabilization centers to inpatient centers to stabilization, residential programs and the whole way through. So we do, have availability across the continuum in those settings to be able to make those warm handoffs. A lot of the crisis stabilization programs are still not yet up and running, but will be in the coming months.
So unfortunately, of course, there's no requirement. They get stabilized and they can go out and do whatever they wish. Isn't that correct?
Yes, we have a voluntary treatment system.
Right. Okay. So then there's 42 million allocated for prisons for treatment, only 177,000 for county jails. What's the explanation of the disparity?
The 42 million for prisons, I'm not sure if you're saying if that's through docs or...
That is in the budget. It's an addition for prisons, for treatment in prisons, but only 177,000 for counties. I can understand if you're not familiar with that, but...
if it's in somebody else's budget, I can't really speak to that, but I can tell you I'm proud of the work we're doing in jails and prisons. We are, they are offering every form of FDA-approved medication in all of the 42 prisons and 58 jails. We work very closely with them, and we do provide support, particularly for the medication costs for all of the jails. So that is work that we are doing, and that's actually coming out of those opioid settlement funds.
So the mobile medication units is a good idea. The reports we receive is some counties refuse to let them be cited there. You have any comment on that?
Yes, stigma is a huge issue in the field of addiction, and we'd love to work with you in communities to get life-saving treatment in those communities.
We'd be happy to legislate on the issue so they can be received.
Thank you. Senator Shelley Mayer.
Good morning. Thank you both. And Commissioner Bear, questions for you. One is you cited the $850 million. I think that is as a result of last year's legislative initiative to apply a COLA or some kind of inflationary index to the not-for-profit community. Am I right?
Now, there was a COLA in last year's budget. The $850 million rebase is separate from that. There was, I think, $400 million in last year's financial plan to support the rebase, with an additional investment made this year when we really looked at the cost of doing business over that 5-year period.
And is that $850 directed exclusively at the not-for-profit community that provides these services?
Yes, the $850 million is only for our nonprofit.
In your testimony, you refer to the development of regional disability clinics. I take it that's different from, I assume it is, from your regional field offices. Can you, what are these regional disability clinics and where are they going to be located?
So the idea behind the Regional Disability Health Clinic proposal is a capital funding program that would be run through OPWDD. So we would take existing Article 28 and Article 16 clinic providers that specialize in providing health care to people with intellectual and developmental disabilities, and we would provide those grant funds on top of their current operating rates, so that they can expand waiting rooms, buy accessible equipment, right, increase their ability to provide those services, those healthcare services to people with disabilities.
With respect to the regional field offices, I think you know, in my district, I've had complaints that there's no one there, no one answers the phone. They're really not of much help to people who are seeking the assistance of the department. Are they fully staffed? Are people in the office every day? And what is the status of these regional field offices?
We've been very lucky this last year to really be as staffed up, I think, as we need to be. We have in-person staff at all of our regional field offices. Certainly, if there's an issue that you're experiencing in your region, I'm happy to talk offline with you about that. People really need to be working with their care managers at this point. So those are through the care coordination organizations, their care managers are really the ones doing that day-to-day work on developing someone's life plan and connecting them to services. So always should start through their care manager, but we absolutely have people working in all of our regional offices, as well as a 24-hour call center.
Okay, lastly, those that first are in the OPWDD system and then have a mental health episode, we found have less coordination than when they start in the OMH world and then get into yours. That's been a problem in my community with inpatient psych hospitals that have experienced this. Do you have a plan to sort of improve that?
Yeah, we've been working very closely with the Office of Mental Health, particularly over the last year, to really close those gaps and to share expertise between OMH licensed facilities. We can.
Okay, thank you.
Thank you, Chair. Good afternoon, Commissioner. How are you today? I'm going to start out by saying, appreciate the statistic of the drop in overdose deaths. We're seeing the same thing in Suffolk County. We met with our medical examiner a couple of weeks ago, and she attributed to the fact of the effectiveness of Narcan administration. We know we still have a lot of work to do, though. I appreciate in your remarks, you mentioned recognition of cannabis use disorder, and I see, trying to get the word out in connection with the Cannabis Prevention Toolkit, but I'd also ask if you could include CHS, cannabinoid hemorrhagic syndrome, which is very prevalent. I mean, the fact that kids are using high-potency marijuana and causing psychosis, as one of my colleagues alluded to, but also parents, should understand what some of the symptoms are. If the child is vomiting uncontrollably or taking very long, hot showers, there's a reason for it, and it's probably because they're dabbing marijuana or smoking high potency, and the issues that relate to that. So I would ask that as something you could include. Just delving right into some of the big issues. We heard Commissioner Sullivan testify earlier about the co-licensure and the three-tier levels. From what we're hearing from the providers, it's causing a lot of problems. And the reason being is because as people will need to move, hopefully, through those tiers, and have less and less treatment, it doesn't allow for that to happen. So we're hearing back that it's very cumbersome and difficult to deal with the three-tiered system. So maybe there's some way to streamline that, if you want to comment.
So the three-tiered system is something we're actually working on. It doesn't exist right now. And part of the reason why we're working on it is to address exactly the problem that you're saying, that the difficulties that providers have now between the two systems. So I think that, the goal is once we have that three-tier system in place, that will reduce those barriers and challenges.
Great, thank you. And then regarding the opioid settlement fund, just wondering what specific plans there are to address and maybe do an RFA to develop competency and access to integrated treatment and support.
Yeah, so certainly in terms of integrated treatment, that is an overarching theme that we've heard from the Opioid Settlement Fund Advisory Board is important, and we've changed our procurement process there. We've also worked very closely with OMH to make sure that they have also access to these dollars, their clinics. So that work is ongoing, and in addition to the licensing, there's many other ways in which we're working together. We're doing training, so the scholarships that we have, for example, for addiction providers also can go to the OMH providers and is going to the OMH providers. So from top to bottom, really around the workforce, around the programming, the licensing, prevention in schools. There is a lot of work with OMH to better integrate our services.
Okay. So along those lines, we're increasing the funding for CCBHC uncompensated care pool. Is there a way to increase it commensurate with the increase in CCBHCs and enable providers to help underinsured and uninsured folks?
That is the whole goal, is really to address those those dollars for the uncompensated pool are really focused on those who are uninsured or underinsured. And so, that is still fairly new, but we're working with providers to ensure that those dollars go to cover that population.
Okay. Switching gears. So one of the problems with bail reform was that individuals who have substance use disorder, it takes a longer period of time for them to get treatment because now there's no arraignment necessarily, right? So for individuals who specifically arrested on DWI, there's currently self-reporting screening, but would you support mental health assessment to provide treatment for co-occurring disorders to help people get treatment faster?
Absolutely, and we work, with the criminal justice system in many ways and the courts to be able to do a better job of identifying and then getting the services that people need.
Okay, real quick, because I only have a few seconds left. Individuals charged with possession of controlled substances, would you support a method of getting desk appearance tickets, get them into treatment, and then if they fail out of treatment, then the desk appearance ticket would be turned over to the court system?
We're not a criminal justice organization, but we're happy to partner with them to make sure that people who do touch that system get the best services that they need.
Excellent, thank you.
Thank you, Senator Krueger. I walked in from session, so I did not hear your testimony. But what I walked into hearing was somebody was questioning about the availability of services in our rural communities. As someone who represents a rural area, I'm concerned because the part of the response I heard was that we have robust provider systems in place. I'm going to tell you, based on the calls I get from my constituents, that is absolutely not the case. Parents will call all the time about the lengthy waits to get their children's services, delays because of insurance issues, and so much more. That's my comment. Now I'll go to my question. I also, just continuing my comment, I believe you will hear testimony later, if you stick around, from a parent who will tell you about the tragedy that occurred in his family because of a lack of availability of services, because of delays. But on to my question. The state's prevention agenda for 2019-2024 prioritizes preventing substance use disorder, yet it seems like our opioid-related deaths continue to increase. Since 2015, it's my understanding that New York State has ranked in the top 5 in the nation year after year. As you know, and I think we could all agree on, our county's on the front line of addressing this public health crisis, and yet I'm hearing from the local departments that they don't have access to the real-time data that's reported to the state, and how helpful it would be for them when they're addressing how to prevent this, how to do better if they had access to this data. So my question is, do local health departments have direct access to real-time state data on opioid-related deaths?
Yes, so I just want to clarify that the overdose death rate has gone down by 17% in New York State. And so that's the first time we've seen this decrease in many years. And we may have the largest number of people who have died, but in terms of, just because of our size, but the rate is about in the middle of the rest of the states.
I appreciate that clarification. Do our local county health departments and others have access to the state's real-time data?
So that's a question for the Department of Health. We don't have authority with those counties' departments of health.
Okay, so you wouldn't know if in this budget there is anything to amend County Law 677 to formally designate local health officials as representatives of the State Commissioner of Health so that they had access to this data?
So that's not in mental hygiene law, and I can't really speak to the public health law.
Would it help if our local health departments had access to real-time data
Absolutely.
to address? Okay.
Absolutely.
I appreciate that. How about then maybe this is for health as well. Does the budget include an increase in the reimbursement rates for county coroners or medical examiners? DOH?
So that's a question for DOH.
Okay. Thank you.
Thank you, Assembly.
Assemblyman Santa Barbara? For 10 minutes.
Thank you, Mr. Chair. Thank you both for being here. Thank you for your testimony. Most of my questions will be for Acting Commissioner Bear in relation to my committee. I do want to talk about, circle back to the investment being made for nonprofit providers. It's a major investment, but the question for OPWDD, I guess, is how do we ensure this funding actually translates into DSP salary increases? Because in the past, we have seen it go to other things and administrative costs and other items. And a follow-up question to that, should we include budget language mandating that a percentage go directly to DSP wages? And is that something you would support? And would you also support requiring mid-year reporting for nonprofits to track how these funds are actually being used, including salary increases and new hires?
Thank you. So the $850 million goes, as we've said, to our certified residential and site-based providers. The majority of the costs of running those nonprofit organizations is their frontline staff. So absolutely, the expectation is that the majority of that investment will make its way to those frontline workers. And we made that clear in a letter, as I said, to those providers. And I have already seen that happening. I had no doubt that our providers would do that. And it's been happening as immediately as they receive that cash. And I've seen improvements immediately in terms of recruitment for those providers. So we're very excited about that. There was language in the COLA statute last year that directed that a certain percentage of the COLA go to frontline staff. That is not in the 2.1% targeted inflationary increase this year, but again, our providers use the bulk of all of their funding to pay for staff. It's their single biggest expense. While it's not required, we at OPWDD also do collect information from each of our providers about how they utilize that funding, and we track year over year how that funding in the COLAs and the targeted inflationary increases are used to increase wages and by what percent. So we are able to collect and report out on that information.
All right, and that information is available to all of us?
Yes, we can make that available for you, absolutely.
I want to move on to self-direction budgets. That's been a topic of discussion. I know my community and some advocates have been talking about this. I guess the question is, will the budgets be adjusted to cover rising provider costs? And I think we discussed a little bit of this earlier. OPWDD actively encourages self-directed individuals to purchase certified services from providers, but these services are costing more. And self-direction budgets are not increasing to cover these costs. And the concern is that if it doesn't change, individuals could lose services while traditional service users see their funding increase. So the question I have today is do you have that same concern without seeing increasing provider rates without increasing self-direction budgets to match? And is there a plan to prevent individuals from losing services because of these rising costs? And would you support a policy to ensure that these budgets are adjusted whenever we see these rate increases?
So every time that we get a targeted inflationary increase or a cost of living adjustment in the budget, those percentage increases are also applied to the budgets within the self-directed model. So they absolutely increase each year by the same percent that the other providers get in terms of that inflationary increase, and that definitely is helpful to keep them current with the cost of providing that care. We currently are working with a consultant to look at our self-direction model in totality. That provider, or that consultant rather, is looking at how self-direction is working in New York State, how it's working in other states, to make some recommendations about how we might look to redesign self-direction in a future waiver amendment. So we look forward to those recommendations. It is a pretty young service model in New York State, and it's had massive explosion in terms of enrollment. So we're very excited that so many people have availed themselves to the flexibilities of self-direction, and always looking at ways to improve it and to make sure that it's really a sustainable model of care going forward.
Okay, thank you for that answer. I do want to move on with the time I have left to circle back to the housing shortage that we seem to be experiencing. The first question is there still a survey going on as to what what the housing crisis is and where we need more services and where we need more inventory. I hear from families, many families in my district that are waiting for housing options for sometimes years. There seems to be a gap between the two main housing options, the group homes with limited availability, long wait lists, and closures seem to be happening faster than openings. And then housing supplements only for those that are capable of independent living with minimal financial support. And this is kind of leaving people out of options on what to do when they need housing. What is the timeline on addressing the housing shortage? Is that survey still going on, and what is the timeline?
Yeah, so we are always surveying network adequacy, looking at people that are looking for certified residential opportunities within the system and making sure that we're meeting that increasing need. I think the survey that you reference is about our capacity management system. So this is our investment we've been able to make in our IT infrastructure to really capture an IT platform, sort of a modern day platform, where those vacancies are and what types of services are available in those vacancies, as well as whether there's actual staff, right? You have to have staff to be able to make use of the vacancy. So the process that we're rolling out now, which will take a year, right, to roll out, to upload all of those profiles into our system of what those vacancies look like so that we can more easily match them with people in the community. Right now we have a very cumbersome sort of paper matching process, which is very person-centered but can take a lot of time to make sure that somebody's needs are matched in those opportunities. So this really will go a long way towards enhancing and creating a lot of efficiency with that customer experience part of the matching process. So hopefully in a year I'll have some really good news about how much faster that process is happening.
And just as a follow-up to that, are there plans for other housing models, particularly there's been discussion of non-certified, it's supportive housing. We talked about this a little bit briefly beforehand as well. Is there any plans to look into that, or is that an option?
So this year's budget continues a $15 million investment in those integrated supportive housing projects that we work on. We match those funds with HCR to open supportive integrated apartments in the community for people with IDD. We've opened 900 of those so far through funding that this legislature has supported over the last several years. So that is one example of non-certified housing. We also spend about $70 million a year, as you reference, on housing subsidies to support people with disabilities to live either in one of those supportive housing or in any other affordable housing that they find in New York State to support them to live as integrated as possible. Our newest service this year, which I want to make sure I don't forget to mention, is home enabling supports. This is a new waiver service only available for people who live in non-certified housing, and that's adaptive equipment, remote monitoring, other technology, telehealth capacity to help people live more independently instead of needing to move into that certified system. So a lot of work happening on both sides, absolutely.
Okay, thank you for that answer. With the time I have left, I just want to talk about crisis response. Just as a follow-up to a previous question, for nonverbal individuals in particular, there's current models rely on hotlines, verbal de-escalation, and traditional interventions, but it doesn't work for nonverbal individuals with developmental disabilities. Is there been discussion on how to address this gap, I guess, in services?
Yeah, it's such a good question. Most of our interventions and therapeutic habilitative services work for people who articulate verbally and those who do not, but there certainly is an increasing number of people who don't articulate verbally, and that's certainly a form of communication that we're looking a lot out now about how to better meet the needs of those people, both the ways that you mentioned and creating community and peer supports for that part of the community.
And just with the time I have left, so you would support the creation of specifically trained people for crisis intervention that are trained specifically for nonverbal?
Absolutely support the need to make sure that those folks are trained in meeting the needs of everyone, including our nonverbal.
Okay, and hopefully we can see something in the budget to reflect that. I certainly would like to see more investment in this area just to address this issue that's still out there. Okay, thank you.
Can I use 30 seconds of your time to thank you as a family member and all of the rich advocacy that you do for our service system? The family members of people with disabilities are so important to the system to make sure that we understand what the needs are, and I thank you for your advocacy. policy.
Thank you. Thank you for being here. All set, Mr. Chair.
Sorry, I'm focused on lunch at the moment. How rude of me. Next is Senator Mayer. No, Senator Mayer went. Senator Persaud, excuse me.
Good afternoon, both commissioners. My question is about OPWDD. You know, I'm sitting here and I just got this letter from C4SD talking, you know, and there are challenges that they were talking about, and so we have to look at that. But I wanted to talk particularly about the mandatory overtime that you were talking about. We are hearing that there's an abuse of mandatory overtime in this across the system. There are workers who are required to work 2.5 shifts, which is not what we want. It's a hazard when that happens because they are not able to give the residents the service the way they should. What are we doing to decrease mandatory overtime? What are we doing to get the workforce to the level that it should be? What are we doing?
Yeah. So in our state-operated facilities, which I think is what you're asking about, we've had a lot of luck this year in particular in terms of recruitment. We hired 3,000 new state-operated employees into our facilities, which is more than what we saw pre-pandemic. So we've come a long way in terms of offering competitive wages and recruiting staff to our state-operated facilities. We brought overtime down this year by 24%, which is monumental. And that is as a result of that recruitment and retention that we've been able to build into state operations, as well as excuse me, as well as the work that we've really done to partner with our union representatives in terms of creating that open communication and relationship in the state-operated workforce.
But it's happening in the residences that are under your guidance also. You know, the voluntaries. Why is that? Who is overseeing it? That the workforce there is working, you know, level at, you know, overtime that they should not be. We cannot have people working to take care of our most vulnerable population, working 18 hours. That's not, there's something wrong with that. Who is looking into that so that we curb that? And why are these operators being allowed to get away with it?
No, I agree. It's very important to keep an eye on. We want work-life balance. We want people taking care of people with disabilities and working with people with disabilities who are not working 3 shifts in a row or not tired, right, or at their best. You know, in any human service organization, when you rely on staff to provide health and safety minimums, unfortunately, sometimes there is the need to keep staff for a second shift. I think it was definitely more pervasive in our state-operated programs, and now that is way down. Anecdotally, I'm not sure that on the nonprofit side they have quite the issue that we did in state operations, but certainly something that management's required to keep an eye on and to make sure that staff is fit to serve.
We'll contact your office and give you some complaints.
Okay.
Thank you.
Thank you.
Thank you. Assembly.
Assemblywoman Giglio? She left? Oh, no.
Yes, good afternoon, and thank you for both of you for what you do. And Acting Commissioner, I really appreciate you coming to Long Island and visiting some of our medically fragile homes and seeing what the needs are there, and hopefully going to be working together with DOH in the future to make sure that the needs of those individuals have been met. When people with behavioral needs are transitioning into new homes, it's essential that the staff working with them are properly trained and prepared to handle any behaviors that may arise. This can significantly reduce the need for law enforcement intervention. Properly trained workers can de-escalate situations, understand triggers, and provide the right support to individuals during challenging moments. Effective communication, proactive strategies, and trauma-informed approach can help maintain safety and prevent situations from escalating to the point where law enforcement may need to be called. Collaboration with mental health professionals, social workers, and the individual's family, including the previous home that the person was in, and that collaboration before they transition into a new home, to make sure that everyone's on the same page, is crucial for a smooth transition and minimizing behavior-related issues. Preparing the environment to be calm, structured, and predictable also contributes to preventing behaviors from escalating. What other steps do you think are crucial to ensure these individuals are supported during transitions? And does OPWDD need funding for staffing to ensure a smooth transition with suitable trained employees in the homes that can address these behavioral needs?
Thank you. I think you hit so many of the important pieces of maintaining continuity for people, and that collaboration as people look to transition from one service setting to another. We see this particularly with our young adults who are aging out of our residential schools, which is why it takes 2 to 3 years of planning on our part ahead of time to really match those young people aging out of residential schools to ensure that the provider that is offering them an opportunity in their residence understands who that young person is prepared to meet the behavioral needs, right? It's an age range that is probably the hardest to serve in any system, and is someone you're getting at their sort of strongest and most behaviorally challenging, right? So that continuity is so important in that communication.
It is, and especially when a new group home is being formed and there doesn't have any residents in the home, that home needs to be prepared, and OPWD needs that oversight to make sure that they are prepared to take in those people with behavioral needs and to communicate with the home that they're coming from to make sure that if there are protocols, they're met. And also, if law enforcement is called, if you're not able to de-escalate. And law enforcement is called a lot into group homes to come and help or restrain. And that is really very challenging, not only for the resident, the person that has the behavioral need, but also for law enforcement. And I think that, we really need to make sure the people in the homes are trained and that papers are going with them and law enforcement knows what they're walking into and if they're expected to go into a situation like that. So I'd love to work with you on that. And then my next question is, the COLA, and we're not calling it a COLA anymore, I guess, in the governor's budget. We're calling it a 2.1% inflationary increase. They're still behind. The rebates were great. The not-for-profits are still behind, 8 years behind in the funding levels that they need to be up to in order to maintain and to provide proper care. So I think we really need to push for at least a 5% increase in the COLA or the inflationary costs, because as the costs go up and the wages go up, so does the capital that they need in order to run the home. So when it comes to the capital funding and the $15 million, will these funds be used for both state-operated and community-based facilities, not-for-profits?
So the $15 million I think you're referring to is for our integrated supportive housing projects. So those are independent apartments for people who can live independently with a little bit of additional support in the community.
Is there any funding for housing for DSPs or affordability of housing for DSPs in rural areas?
There's not a particular investment in this year's budget for housing for DSPs, but the governor has made a $25 billion proposal to create affordable housing statewide as part of the Pro-Housing Communities initiative, which I think will greatly benefit DSPs as well as people with disabilities looking for affordable housing.
Can we prioritize DSPs in rural areas for these affordable housing projects? Can we push for that?
It's not my program.
Thank you.
Thank you very much. We have is Senator Weber back? No, okay. Senator Rollison, did you go yet? No, Senator Rollison.
Thank you, Madam Chair. This question is for Commissioner Cunningham. I see that in one of the briefing papers that I got, there's additional money for street outreach in this year's proposed executive budget. Can you just give me a brief understanding of that and how that money goes out and the process in which it is distributed, and also what the makeup of the teams are, to your knowledge?
Yes, so that $3 million is to continue to enhance and expand our street outreach teams, and particularly focus on those with co-occurring disorders, so mental health and substance use disorders. So we're working with OMH to really think about how to best target that to make sure that, for example, some of their existing teams, we add the addiction expertise to that in addition to expanding. So a lot of this is going to be targeted, based on kind of where the need is in various communities, and really builds on an extensive programming that we have on street outreach and engagement, of which we're investing over $30 million in.
So as a former mayor, I am a huge proponent of street outreach teams and the work that they do, meeting people where they are, of course, right? And I had mentioned to Dr. Sullivan, the SOS team, which is operating now in my district, the 39th, which has been very, very beneficial to many people. I just actually got a text message from the local outreach team coordinator, said they're getting ready to place 6 individuals in housing, because that's part of that program, is a housing component. And so when you're looking at that and the group is looking at that, do you have the ability to structure these RFPs, or however they're going to be done, to have that co-coordinated team with housing, with OASIS help, with OPWDD? Because I'm seeing it, in the communities that I represent, more individuals with certain types of disabilities that are on the street, may not be homeless, but they're on the street in wheelchairs and walkers, and they've got, different types of challenges. Because to me, when you have that wraparound approach, you're getting the best for your money, and so is the individual that could be receiving the outreach.
Yes, I mean, this is exactly the goal. And so, we're working with OMH now to figure out the details there.
Good, thank you.
Yes.
Do you have any questions? Assemblyman Robb?
Afternoon. Commissioner Cunningham, I wanted to just follow up on my colleagues' questions about Kratom. Just in terms of, do you know of data within the department or instances where that is an individual's primary substance of use?
We do collect that information. I'd have to go back and look specifically at the details about the numbers. I can tell you if the number's quite low. The vast majority of people come into our system for either alcohol use disorder or opioid use disorder.
Okay, and I know I found some of the statistics on the website, so I would assume it would be under the all others category if there were instances?
That's correct, yeah.
Okay. I wanted to move over to Acting Commissioner Bear. Good to see you again. Thank you for a conversation a few weeks ago. An issue that keeps coming up when I talk to both colleagues who deal with this personally and advocacy groups, people trying to get services for their children, is the issue of private duty care, private duty nursing, just their inability to find people that can work with their loved ones. They're approved for it. There's, if the staffing or the individuals were there, they would be able to get, all these hours, and they just can't find anybody. And I know there's a couple of pieces of legislation with regard to this, and we're trying to work through how we deal with the federal side, Medicaid, all of these different things. But if you can tell me a little bit about, what the agency is doing to try to address that issue.
So I can't really speak to private duty nursing, which would fall under the Department of Health. What I can say is we've been able to increase rates of pay for nursing staff to support our certified residential facilities, both in through the nonprofit rate rebase and at the state level, and have had marginal success with recruiting that nursing staff. Certainly is an issue shared across systems, and something that I know Commissioner McDonald is looking at the Department of Health as well.
Right. And I know one of the things we spoke about a few weeks ago was housing for individuals with disabilities, and trying to maybe get a little more creative. And down on Long Island, our former colleague, Missy Miller, who's now on the town board there, is trying to come up with some innovative ways to address what is one of the largest concerns that parents have as they have an adult with disabilities is what's going to happen when I'm gone, and they're trying to be proactive in planning for that. So I want to again thank your staff for engaging with us on this issue to try to address that that particular issue. I don't really have a question with regard to that. The last thing I do have a question with regard to, I've had a number of people ask me about trying to take new measures to make sure residents are safe when they're in group homes. And I mean, there are people who want, some type of cameras, and I understand that, there's privacy issues, there's issues with the workforce, all of that. But is that something that the agency is looking at?
At cameras specifically?
Yeah, yes, or other measures in terms of safety for the residents.
Sure. I mean, we prioritize safety of residents, the folks that live through our residential system first and foremost, right? We've got a 24-hour incident management unit that responds immediately to incidents, alleged allegations of abuse, neglect, to make sure that corrective actions are taken. We make trainings available to providers all year. Just earlier, late last month, we offered a training with 2 national experts for all of our providers on the top 5 preventable illnesses and causes of death in the population, right? So we absolutely, safety is a top priority. The issue of cameras, I have heard family members talk about the idea of cameras being installed for surveillance purposes. I mean, as a family member, I certainly empathize with wanting to make sure that your loved one is safe at all times when they're not in your care. Federal guidelines are pretty clear about the right to privacy. These are not transitional settings like a psychiatric hospital. These are people's homes.
Thank
Talk
you.
more offline.
Yeah, sure.
Sorry. Thank you very much. Senator Canzoneri, Fitzpatrick, Ranker, 5 minutes.
Thank you, Chair. Thank you both for being here. My question first is for Commissioner Cunningham. I understand that the budget supports, a large increase to triple the number of certified community behavioral health clinics, and I support that. And that in addition, crisis stabilization centers are going to be increased, and I'm looking forward to the one opening in Nassau County, my hometown. One of my questions, though, which I believe was asked, but I'm not sure it was asked with great detail, is that if we are increasing the fund for uncompensated care pool, if that's going to be increased commensurate with the number of facilities we're opening, or else you're going to have multiple centers competing for the same pool of funds. So is there enough funding there to support the increase in these centers?
So I think, that's a question that we're discussing with OMH, and it's certainly an issue that continues to come up, and we want to make sure that we are supporting that care for those with uninsured or underinsured.
Okay, great. And for Commissioner Bear, my question, nonprofit provider agencies serving the intellectual and developmental disabilities communities have a vacancy rate of almost 17%, from what I've been told, with an annual turnover rate of over 35% of our DSPs. I am concerned about that in the face of the proposed COLA increase of only 2.1% compared to inflation of 2.9%, and our advocates are asking for 7.8%, and there's a big gap there to fill. So my question is, how should we be better addressing these vacancy rates, and is this 2.1% COLA increase, do you think that's going to help these rates that I'm mentioning? Because I really, as I said earlier, a 7.8% increase is probably more appropriate. So I'd like to know what your thoughts are on that.
Yeah, so if we're talking about staff vacancy, I think all of the things we talked about with the rate rebase, I don't want to keep coming back to an $850 million investment. It's a significant investment. It is a huge part of the solution. I understand it doesn't solve all of the problems, right? OPWDD has also partnered with our providers in a number of other ways to try to facilitate the retention and recruitment of staff. We had a $10 million investment through the National Alliance of Direct Support Professionals to create a credentialing program, and we've partnered with 41 of our nonprofit agencies to make that credential and the stipend that comes with that available to their staff. That's been very successful. We also have a $50 million contract through the State University of New York to provide micro-credentialing and college credits, which are funded through that grant for DSPs to go back to school and get up to 12 hours of college credits along with the micro-credential that comes along with that. So things like that to really professionalize the career of being a direct support professional. I go to those graduations and talk to those DSPs, and it really has gone a long way to making those DSPs feel valued and professional and supported in those workplaces. So thinking about how to support our providers from all angles. I talked about our strategic plan a little bit and ways that we're coming up with to try to get other capital funding to providers faster and to reduce some of the administrative burdens that we hear complaints about as well.
Well, thank you for that. I do think, though, that the COLA increase is certainly an important piece of what you've just said. I agree that those other pieces are part of the package, but if you can't pay your own bills, it's very difficult. In addition to those challenges that we've talked about, there are increased costs facing provider agencies in order to be in compliance with the state's environmental and efficiency laws and regulations as part of the CLCPA. Does the executive budget include funding that reflects these increased costs to assist these agencies with these costs so that they aren't forced to choose between complying with new mandates versus adequately funding their workforce?
So what's included in our budget is the 2.1% targeted inflationary increase to help with increased costs like things, for things like that, right? We also provide property funding and capital to providers as they look to renovate their physical plant. In terms of compliance with the Climate Act, I'm not aware of any specific funding in this year's budget to support the nonprofit.
Okay. And then I know that the capital budget, the executive budget recommends an appropriation for capital funding that's been increased. And my question is, how are we going to use that cap? All right. Thank you.
Assemblyman Burdick. 3 minutes.
Thank you, and thank you, Commissioner. This is, of course, to the Commissioner of OPWDD. Among the people in the disability community with whom I work is the Senior Vice President of the New York State ARC. She tells me that there are an estimated 5,000 to 7,000 on waiting lists for group homes, and many in the Mid-Hudson region. I would appreciate your getting back to us on how the lists are maintained, the number of vacant group homes, where they are located, and your agency's plan for getting them reopened. So not looking for an answer now on that. Another one that I'm not looking for an answer now on, but wanted to get it on the record is, we've been looking at the model for integrated housing the United Way of Northern New Jersey has been involved in. They've established over the last decade 44 housing communities supporting adults with autism and other neurodiversities, veterans, seniors, and working families. Senator Harckham and I toured one of the communities in Florham Park 2 years ago, discussed it with your predecessor and her staff, and I don't believe that anyone from OPWDD has had a chance to visit the site, though they've had plans to do so. We recognize that Jersey has a different waiver than New York, but we think that it appears that the model could be adapted and still be compliant with New York, and we'd appreciate your getting back to us on the status for visiting the site and reviewing the model. Now, the next question, it would be helpful to get an answer to. There are 2 vacant group homes in Westchester County. One is in my district in North Salem and has been vacant for over 5 years. Let's assume that there is a responsible provider who meets OPWDD requirements and have the staff to do so to operate them. How can we get these reopened, and who can we work with on your staff to do so?
So it sounds like you're asking about a vacant state-operated program. We operate about 1,300 facilities statewide. And so where those programs are operating out of can change based on the availability of staff. When we identify unused facilities, which is what it sounds like you're asking about, happy to engage about better utilization of that space. Our properties would have to go through a DASNY or OGS process, but certainly happy to look at making better use of underutilized state space. A provider looking to open additional capacity would meet with our regional office to see what the need for services are in that area, and there's a process for that. So happy to talk offline about the particular situation.
Great, thank you so much.
Thank you, Madam Chair. Commissioner Bear, Commissioner Cunningham, thank you for being here. Good to see you both. Commissioner Cunningham, Times Union has done extensive reporting on lower enrollment in drug courts following changes to bail and discovery laws. How are you responding to that? And would you be supportive of
I'm
legislation
sorry,
that
Senator
allow-
Ashby, can you speak up or pull that a little closer to you? We're having trouble hearing you.
Can you put more time on my clock?
No, it's okay.
You heard that. So the Times Union has done extensive reporting on lower enrollment in drug courts following changes to bail and discovery laws. How are you responding to that? And would you be supportive of legislation that allows lower level defendants to be remanded so they can receive supervised treatment and detox?
So we work very closely with many of the agencies that deal with the criminal justice system and the courts in particular. So we are working with the overdose intervention courts, making sure that we have peers, people with lived experience in those settings to, help identify substance use and then link those individuals to services. So I think, we're of course very happy to continue to build on that partnership, but we have a pretty extensive partnership with many of the, jails, the prisons, court system to make sure our individuals get the best treatment possible.
But with the reduction of the enrollment that we've seen in those courts, do you think that we're failing to adequately reach out to those who need the help, who may be lower level offenders?
I mean, we really use a harm reduction approach by investing in outreach and engagement teams and really trying to make treatment more accessible for individuals. And so there's investing, over $30 million in that work to go out and reach those who may not necessarily come to us, but to really reach them where they are and all throughout the community.
Okay, thank you. Commissioner Bear, our wheelchair repair process in New York State is in need of revision, to say the least. Would you or the executive be open to reforms including waiving prior authorization for repairs, right to repair laws, and requiring repairs to be completed in a timely manner?
I appreciate the focus on the need for wheelchair repair. I know that there's a proposal in this year's budget around durable medical equipment and wheelchair repair. Unfortunately, that's through the Department of Health, so not my place to weigh in.
Given the population that you work with, do you see this as an issue among the population that you're serving?
I certainly appreciate the focus in this year's budget on making sure that there's a better process to repair wheelchairs, absolutely. We had a self-advocate that was supposed to be here with us today who was unable to join us because of wheelchair issues in her home.
I will take that as a yes, thank you.
Assemblywoman Gallagher.
Hi, thank you so much, commissioners, for coming out today. I have a question for each of you, so I'm going to talk quickly but loudly so that we can get through both. So for Commissioner Bear, I've been hearing, I think this is not necessarily your wheelhouse, but I think your opinion's really going to matter on it. I've been hearing a lot about CDPAP from my constituents. I'm deeply concerned about the speed of the proposed transition and the general thrust towards a single financial intermediary. My question for you is whether you think 7 weeks is enough time for people with serious mental and physical disabilities to make this transition.
So I can't opine about the time of the transition. We do have 9,000 people in the OPWDD system who are also receiving healthcare services through the CDPAP. And I know that our care managers who work with those individuals are working to help them make that transition as quickly as possible.
Okay, that's good to hear. I still am not sure if you think that that's really enough time, though.
I don't oversee that program, so I can't speak to how complicated it is to make that transition.
Rats, okay. So for my other question for Commissioner Cunningham, I was heartened to see the $53 million proposed COLA for behavioral health workers in this year's executive budget. Can you talk about how much this actually translates to individual workers? Because I know there's a crisis of retention in many of the facilities that we rely on.
Yes, so the targeted inflationary increase is $12 million in our system, plus the increase in minimum wage is another $6 million. And I think, it is important because there are many other things that we're doing to also support the workforce. We have many, many scholarships. Over 1,000 people have gotten scholarships, right? We're doing paid internships. So we're really trying to bring more people into the field and to retain them when they come in the field.
That's great. And regarding some of the people out in the field, how many inspectors do you have going to different facilities to make sure people are keeping up with the oversight on behavioral health facilities? And how many would be ideal for you?
So we work, so the Justice Center really does a lot of the inspections when there are issues or reports. And we work with them, but they really have oversight over those incidents. And then we have our sort of regional offices that works with our programs if there's any questions or issues that they need to work through.
Okay, so there's no one that does kind of like pop-up inspections or anything like that?
I mean, our regional office works with the programs and will go and do site visits, but I think when there are reports of incidents, that's handled by the Justice Center.
Okay, thank you.
Okay, Senator Tom O'Mara. Ranker, 5 minutes.
Thank you. Good afternoon. Thank you for both being with us today. To Commissioner Bear, on the just follow up on a lot of my colleagues' comments on the direct service professionals increase in the budget being quite woeful. That's not even keeping up with inflation. I know inflation's been cited as being 2.9%, but actually the New York area inflation is 4.3%. New York area core inflation is 4.7% over the past 12 months. Just the increase to the minimum wage again this year going up is 3.3%, more than 1% higher than what you're offering to direct service professionals. The minimum wage in New York State just over the past 6 years has gone up about 25%. The pace of cost of living adjustments for DSPs is nowhere near that. How are our service providers, agencies, supposed to keep up staffing? We're having group homes closed all over the place because of the lack of ability to hire people when they can work minimum wage at a fast food place with a much more reliable schedule, much less demanding work. Why are we not keeping pace when your own increases for state OPWDD workers have gone up at a much faster rate than DSPs? How can you justify that in this budget?
So I think it's important to remember that the 2.1% targeted inflationary increase this year is compounded on the last 3 concurrent years of providing an inflationary increase to providers, along with the $850 million investment, the millions of dollars on bonuses and ARPA-funded projects, is almost $4 billion across my service system in the last 4 years, which has really been an incredible investment for this field to get them caught up to modern day cost. The rate enhancement alone increased our providers by 13% statewide. So while it is absolutely important to stay current with the cost of inflation so that the cost of doing business is possible for those providers, you have to remember that we're incrementally catching people up to what was years of underinvestment in a prior administration.
Well, I don't see it that we're catching people up. We're losing ground to the minimum wage increase. with the increases that have been giving. So, I mean, how can we continue to lose ground to the annual minimum wage increases and expect our agencies to be able to provide the staffing for these facilities?
Yeah. Our budget also includes a $38 million investment to keep providers caught up to minimum wage increases as well. So that's baked into the overall enhancement for this service system.
I think we need to do better for our DSPs and these agencies, and hopefully this legislature will do that in the final budget here. Thank you.
Thank you.
Epstein.
I got it. Thank you. Thank you, Chair, and thank you both for being here. Really, I just wanted to, Commissioner Bear, I just wanted to,
Does anybody
you know,
else
I know
have
we talked a
that?
lot about the COLA, so I just want to up one that we really need to talk about the workforce. I just want to focus on that for a second. But can I ask you, there are two bills that I passed last year on that, in the infinite wisdom of the governor, she vetoed, I guess with the urging of the agency, really one to establish, to look at and evaluate how we can streamline requirements for applications through OPWDD as well as other agencies. Because what we've heard from a lot of constituents is, I apply for one agency, I have to reapply for a second agency. It takes me a year for agency one, it takes me another year for agency 2 and 3. And so there's no streamlining going on. So we have a lot of frustrated New Yorkers who are just trying to get care and support. I'm wondering what the logic is to not having a process to streamline and why we are not doing more to help regular New Yorkers who need help.
So I think our system is entirely different than OTDA system, which is entirely different from OASS's system, right? And that is a historical product of running those siloed agencies. What I can say is we have come a long way towards integrating that data communication, talking to one another. Our care coordination organizations, which we launched just a few years ago, right, are responsible for not just focusing on someone's IDD needs, but to also integrate their physical health, behavioral health, specialty health. And so we in New York are growing a lot in the space about integrating that information. The governor's new office on innovation and efficiency, certainly focusing on reducing wait times in New York State and enhancing the customer experience for New Yorkers. And I think that touches a lot on what you're getting at.
Yeah, so I have just to say that, you know, unfortunately, I appreciate what you're saying, but to the public at large, they don't see it, and they're frustrated. And the idea of just like, there's a simple way to do it, just to come together and have an official process with an outcome, with an easy way to resolve that we heard directly from a hearing from constituents. And unfortunately, through whatever urging from the agencies, the governor made their decision to veto. Another issue is on hiring for people with disabilities, employment for people with disabilities. I'm wondering how your agency tracks, you know, how successful we are ensuring that in our procurement and operations that we're ensuring people with disabilities get those employment jobs that we're talking about.
Yeah, that's such a great question. We provide a continuum of employment services all the
Right.
way through someone who needs just a
Right.
little bit of vocational training. Up
I
through
mean, in government jobs, how do we know how we're doing as government to ensure that people with disabilities are getting government jobs?
government jobs.
Government jobs,
Yeah.
like you, like us, like all of us. How do we ensure we do a better job getting those people with disabilities, internships, opportunities, supervision? Because we're not doing a good job and we're not even tracking it, so we don't even know what's happening.
It's so important. We had a pilot in New York City that was very successful. Oh, happy to talk offline about it. A lot of exciting work there.
Okay, I think I'm the last senator except for one quick follow-up afterwards. So you were just, I'm sorry, Commissioner, sorry, this is for OPWDD, Commissioner Bear. So my colleague just asked you about group homes closing. We heard in an earlier testimony how difficult it is to cite programs. And we know we have demand, so why are we having group homes closing in New York State? And was that an accurate statement that was made?
So I think in a service system this size, there's always growth and movement within the system. On the state side, which I think is what the question was about, was temporarily suspending programs in state operations, which we do when we can't meet a staffing need in a certain area of the state. So we don't close the capacity to serve people, we move that program to a different location and maintain the capacity to serve people in a different space.
So if I have family members in an OPDD contracted site or a state site, and you close the site that my family member's in and move it somewhere else in the state because, quote, you didn't have adequate staff, isn't that an enormous problem?
Yes, and it almost never happens in the state side that we have programs where people are living that we need to move. When we have programs in the nonprofit side that the nonprofit can no longer run, we do a lot of work in our regional office and with our teams to match that provider with a new nonprofit provider who has the staff and capacity to take over that program in place to cause as little disruption as possible to the people that are using those services.
So would it be more accurate to describe it as one not-for-profit might no longer be running that site, but it continues and remains open under another not-for-profit's umbrella?
That is absolutely the goal when one nonprofit can no longer run a program. Absolutely.
And how often doesn't that happen and you actually end up closing a site where people have been?
I don't have that information off the top of my head. Absolutely everything goes into avoiding a situation like the one you're describing.
If you could just follow up with us on whether there are actual, losses of existing sites, because I feel like we all would agree that's not what we should be doing at this moment in history.
Yeah,
Losing sites that have been there and have people living there and family members in a geographic area dependent on their family members continuing to get services, not 7 hours from where they live.
100%.
That's it for me. Back to the Assembly.
Assemblyman Eckes.
Thank you, Chair. Thank you, Commissioners, for being here. First, for Commissioner Cunningham, a suggestion. I have a wonderful wife who happens to own an adult-use cannabis license and shop. She would love to do anything and everything she can to reduce the risk of, the use of, by, youth. So it just occurred to me right now, produce posters. I will have her put it right on the exit door about the proper storage and the risks of youth using this product. Be glad to do that. And if necessary, I will call OCM and make the mandate that those posters go up on those doors.
We'd love to partner with you.
Okay. For Commissioner Bear, you and your department sailed way up here for me. Just a couple days ago, I called you and you were in a meeting, but you called me immediately back, and I so appreciated that. And we talked a little bit about what I would make reference to today. But more importantly, you right away said when we completed our call, can I call Commissioner Sullivan for you? Which means that you, more than have your two departments in the same building, you actually talk with one another, which is a wonderful thing. But as you know, and you may have heard, I have a very grave concern with what I call a dual diagnosis, but my dual diagnosis is mental health and OPWDD. It's a smaller, perhaps, population than what many people refer to. And so what I would like to do, there's nothing going to be answered today, but what I like to do is request a report on the programs where you are integrated with OMH and a little description of those programs. And then the final thing I would like to do, as my colleague Gallagher referenced, I know that FIs are under the Health Department and CDPAP is under that, but if you have received any comments, because I'm getting comments from all over the place, I want to collect them all together. If you receive any comments from your particular groups, independents or otherwise, please pass those on to us.
I'm happy to provide a report on those OMH projects. We've done such exciting work. You're right that I absolutely talk to Commissioner Cunningham all the time. They have been incredible partners with the funding they've received the last couple of years to create a lot of capacity to serve those dual diagnosed individuals.
Commissioner Sullivan, right.
Absolutely. What did I say?
Cunningham. That's okay. Thank you.
Thank you for knowing what I meant.
Yeah.
So yours.
Thank you.
Assemblyman Marr.
You're a good partner, too.
Thank you. This is for Commissioner Cunningham. How are you? Good. So what I love to do when I'm at these public hearings is I talk to individuals from my district that are in recovery, people that have experienced this firsthand, but also are now in the field and are serving. And I view that as something that is very common, and I think it's amazing. And I'm not going to continue to talk about some of the pay issues. Obviously, I think that's a bipartisan support that we have here today. I do want to talk about some insurance issues. So I have heard from some of these individuals that there are insurance issues that only cover maybe 14, 21 days of care. When it comes to the shortfalls from the insurance side, have you seen that? What has been the reaction? And what has your department been doing to kind of combat that?
Yes, I mean, so definitely a lot of the insurance issues are under the Department of Health and not under us, but we certainly know that there are challenges. So we have an ombudsman program called CHAMP that we definitely get those complaints, and if there are issues, and work with individuals to work through what those issues are. And then, certainly work across the state agencies to be able to address them.
I appreciate that. Another issue that comes up from, again, the folks that are on the ground are talking about some of the documentation that's needed within a 24-hour period, and that there are actually issues where some individuals aren't getting the help that are needed because they need a little more flexibility in getting that paperwork. Can you speak to how those issues come up and what's being done about it?
Yeah, that's an area that we are definitely interested in continuing to work on, because we don't want that to be the barrier. We want to really improve access to services and reduce those barriers. And so we've actually worked to make sure that people know that a lot of times we don't necessarily need that before people can be admitted, but that can be part of the admitting process. So we are working with our programs to really try and reduce that barrier.
Okay, and is that something that's administrative within your purview, or is that something that also needs legislation?
Most of that, I think, is regulatory, and I think it's clarifying with in terms of the regulations.
Okay. Another issue that I'm hearing on the ground is that there are some handicap accessibility issues with some of the areas that actually provide the services, and that can also be a deterrent in some cases. Have you seen that, and what are some of those things that we're doing about that?
Yeah, so certainly the people that we serve are now older and living with more chronic illnesses, including physical illnesses. And so this is an area that we are actually trying to understand a little bit more about that change in the population, and then determine really what the, how prevalent is that issue, and then what the needs are. So that is an area we're actively looking into more.
Is it about collecting information? Have you put something out to say, hey, is there anyone that has this issue? We'd like to quantify it, so then we can then put the ask to the legislature?
It is, so yes.
Okay, thank you.
Yes, my question is for Commissioner Bear. Commissioner, 30 years ago, I was a direct care worker working with our most vulnerable population, so I'm coming at that. I saw firsthand how those direct support professionals impact the quality of care and quality of life of our most vulnerable New Yorkers. So I just want to start with, before I go there, let me say 2.1 is woefully inadequate. I've been through the campaigns for the Be Fair to Direct. We go through this. It's like a dog and pony show every year. But then the governor proposes a $250 billion budget, $19 billion more proposed than last year. Doesn't blink an eye at providing $700 million for the Hollywood film tax credit to subsidize Hollywood leads. But here we are with our most vulnerable New Yorkers and the direct support professionals who care for them leaving because they can't afford this job. So on that process, 2 years ago, there was a FOIA request that showed there were 4,500 individuals on the residential wait list. The Western New York region that I represent, just the ARC chapters alone, from a report 6 months ago, had closed down 90 residential beds over the past 2 years. We have a workforce crisis for our direct support professionals, and that's impacting the quality of care and quality of our most vulnerable New Yorkers. Budgeting is about priorities. The Hollywood elite or our most vulnerable New Yorkers doesn't make sense to me. So my question to you is the differential between the minimum wage and what our nonprofit agencies like our ARCs are currently funded to pay, is that adequate enough in your opinion and Governor Hochul's opinion? Is that adequate enough for them to compete in the local labor market for the talent and dedicated workers, talent and dedicated workers that we are required to be direct support professionals to provide this care?
First of all, thank you so much for your service as a direct support professional. Very, completely agree, lifeblood of what we do. I believe that at this point in time, with the 13% increase we offered effective July 1st, compounded with the last 3 years of COLAs and this year's targeted inflationary increase and investments in minimum wage, that our providers largely are at this point situated to provide a competitive wage. I think that is drastically impacted by the most recent investment, which was the reason we made that investment. And I have certainly heard from providers that they are now offering up to $26 an hour competitively to their region
For not-for-profits.
for not-for-profits.
On that front, because as I mentioned, 91 beds over the past 2 years have closed in my region. Can you provide a list to us, not just across the state, not just for the not-for-profits, but also the state beds and others, so we could have a list of how many have closed over the past 2 years? Because this is a workforce issue, so I'd like you to provide that, and I appreciate you answering my question.
Sure, we can get you information about vacancies throughout the system.
Yeah, thank you.
Thank you. Thank you for being here, commissioners. Most of my questions, I think, are for Commissioner Cunningham. I really appreciate the incredible amount of opioid settlement funds our state has received. And I was just wondering, do you track by county how much of their allocation has been used and how it's been used?
Yes, so our opioid settlement fund tracker website has all of the county information in terms of how much each county's received, what their plan has been, and we are now collecting the reports, their annual reports, and then we'll put that as well in terms of what do they spend it on prevention, treatment, recovery, et cetera. All of that information is on our website.
Okay, and if a county hasn't spent down their allocation, is there any time frame that, like if a county hasn't used a great portion or doesn't have a plan for it, is there any timeline that would be problematic, like that it would get clawed back or something?
No, so the opioid settlement funds are for 18 years.
Oh, good.
But the dollar amount decreases substantially, and so the counties can spend their money according to the agreements.
Okay, thank you very much. And another thing I've heard from many families that are, they have a child or a partner or someone in the family that's struggling with addiction. And I've heard oftentimes through the years that they don't find that there's enough support. Like there's a lot of decisions they have to make. Some families have a family member. I spoke to someone recently that has been involved in some issues legally, and there's a lot of people just don't know where to turn. Should they be paying for English? Should they not? Like there's a lot of things that come up, and they're operating under the stress of having a family member, and so they're also suffering. But a lot of them say they don't have enough support to advise them, and I just wondered, is this anything you hear or would address, or are there any programs that really focus in on the family?
Yeah, I think particularly for young people, this is an area definitely a focus, is making sure that the family members are part of all of the services that they receive. And so that is woven into a lot of our services that really focus on adolescents.
Oh, okay. And is there any information that you could provide that tells me in Nassau County what services are available in that area?
Absolutely.
Terrific.
We can get
Thank
you a
you.
list.
And final question, really quickly, is another area of support that has been expressed to me is that when someone's in recovery and now they're looking to work, they're looking for housing, they often don't have enough support. They don't have the transportation to get to work. Maybe they're having trouble finding a job. Is that something you could send me some information on?
Sure.
Okay, thank you.
Okay, to close out the last 3 minutes, Senator Fernandez. The last 3 minutes of the Senate, excuse me.
Thank you so much. Okay, for Commissioner Cunningham, just to follow back with the gambling addiction services, you mentioned a lot of the outreach being done. Do you see a need for more given iGaming has started, or sports betting? Do you see a need for more outreach, funding, what?
Yes, I mean, I think, we're continuing to expand our services and build the capacity for treatment and prevention in our system. Certainly, additional dollars to make sure that we're, can reach the people and target individuals who are at risk, would be helpful.
Okay, and last question for you. Very happy again about the numbers showing that overdoses went down in New York State, but they still remain a little high in Black and brown communities. What are we doing to reach those demographics?
Yes, absolutely. I mean, for this reason, we would really use a data-driven approach to make sure that we're reaching those who are at highest risk and a targeted approach. And so when we put out, our RFPs and our investments, we're ensuring that those communities who are at highest risk, do have the availability to get those investment dollars. And so this is, for example, looking at, expanding medication treatment, expanding our outreach and engagement initiatives. So it is absolutely with a data-driven approach for those communities that are at highest risk.
Okay, I would hope that includes language access too, which I know we do. So thank you so much, Commissioner. For our other commissioner, last year the legislature included language that required at least 1.7% of the COLA go directly to worker wages to address the pattern of agencies redirecting funds for workers to other operating expenses. Why has the agency yet to produce guidance as required in statute? And without this guidance, what are you doing to ensure that agencies are ensuring funds are going to workers?
So like I said, we require of our providers an attestation about how they spend those funds, and they specifically tell us each year the % of increase to direct support professionals as well as to other title series like their clinicians and their administrative staff. So we do collect that information. Staffing for our providers is by and large the highest, the majority of their costs. So when you get a cost of living increase as a nonprofit, you have to use that, right, for all of your increased costs of doing business, not just direct care salaries, but for us that is the majority of their costs. So we do see that most of that money, with or without that 1.7% directed language last year, goes towards wages of direct care staff.
All right, thank you.
Thank you.
All done.
Get my mic. So the street outreach teams, could you explain what they are and where they are being located?
Sure. So we have street outreach teams really across the entire state, in urban areas and rural areas. We just came out with a new RFP that will fund $31 million more of continuing this work. So they work, in parks, on streets, under bridges. They provide harm reduction education and materials. They link people to services, and some of them start treatment right there in the community.
So the $3 million in the budget is an expansion of that program?
Exactly, and really targeting those with co-occurring mental health and substance use disorders.
And then another question is, you're familiar with the SAPS, or Substance Abuse Prevention and Intervention Specialists?
Yes.
So is there any particular reason why that program is currently located only in the city of New York and not in other parts of the state?
I think it's historical, and I think it's also the interest of the school districts. We certainly want to be in as many schools as possible, and I think schools have competing demands, and so, the substance use prevention may or may not be part of their priority. But we would love to partner with schools, more schools, and have more of a footprint in schools.
So with respect to SAPS, it is a program that's funded partially by the state and partially by the city. The idea would be that if a local school district wanted to participate, they'd have to fund 50 or whatever the % of the program is in order to get one of the SAPS individuals in the schools. Is that something you could support?
I mean, I think we support prevention in schools in a lot of different ways, and so I think it would really just depend on the specific school district. But, often our prevention providers go into schools, we work with the communities around the schools, so I think there's really a variety of ways in which this can be done to really partner with the schools.
I don't have anything further. Done?
Thank you. Thank you again, commissioners. And these are just a couple of more questions for Commissioner Bear. You already had a little bit of a discussion about the certified residential homes that have closed. Do you have a list of how many have closed in the last 12 months? And is there a breakout between which ones are state-operated and which are the nonprofits?
I don't have a list like that.
How many have there been?
I don't have that information with me. Happy to talk offline about the various reasons that some of those transitions happen.
Okay.
And what they look like.
I appreciate that. Thank you. I wasn't sure if I'd missed the number or if you had mentioned it. The waiting list that we talked about the last time, I since got a couple of texts saying, wait, there is a waiting list. So and then of course we hear a lot from the hospitals where there are times individuals, those with disabilities and other high needs, may be quote-unquote stuck in a hospital waiting for a placement. Can you clarify what is defined as a waiting list and what is not, and why have we heard of incidences of people who literally can't be placed out of hospitals, and we certainly hear it here, let alone around the state. So I'm not clear on how we define waiting lists, because others have certainly mentioned that they've been waiting, and that only those who are coming out of ER rooms or where parents may have died get what's, I guess, an emergency placement. So can you clarify that for us, please?
Yeah, but certainly hear the concern about people who end up hospitalized and hospitalized for a lot longer than they should be. We never want anyone to be hospitalized unnecessarily, and we never want to take up capacity in a hospital system. So we regionally have crisis mitigation liaisons that work with regional hospitals to make sure we are aware when there's someone with OPWDD eligibility looking for a certified residential opportunity in our system, and have a lot of communication with hospitals about what the needs are that that individual needs so that we can match them with a provider in the community. The list that people refer to as our
Yes.
certified residential opportunity list, so it's not a wait list, but we do track people who are looking for certified residential opportunities in the system, and that list of people changes every day as people move in, move out, between the system.
So how many are often on that tracking list that we don't call a waiting list?
I don't know that number, what it looks like today, but happy to follow up with you.
Okay, I would appreciate that, because certainly it is of concern. Certainly we want to do all we can to address it. Thank you so much, Commissioner.
it.
Thank you, Chair.
Thank you, Mr. Chair. Just a couple of follow-up questions for Commissioner Bear. I guess I would like to see that list as well, just to follow up on what Senator Fahey just said. In particular, people that are aging out of the system. I know my son it's been a few years to find a placement. We haven't found one just yet, but whatever that is, I'd like to have some idea of how many people are on it and how many people are actually waiting, because I do hear similar concerns as the senator did as well. But I did also want to address some questions from service providers regarding the OPWDD regulations that are somewhat outdated, requiring MDs to actually sign off on all orders for prescriptions and forms that are needed for medical services. The reality is a lot of people use physician extenders nowadays, and there's a shortage of MDs in this particular field. So the question is, is there anything being done to update regulations to closely reflect the medical model used today to treat individuals in the system in clinical settings, and accounting for the fact that most providers use physician's assistants and nursing practitioners, not exactly doctors? It seems that the regulation should reflect the current model. So just maybe your comments on that.
Yeah, I can't say that I'm completely familiar with the regulatory issue you raised specifically, but we do have a work group that meets regularly with stakeholders like our provider community to talk about where our regulations and our administrative processes might need some updating to provide some relief, or just to catch us up to what the modern day world looks like. So we're always open to hearing from providers about ways that we can implement those changes to make those things easier.
In this particular case, it seems like the Center for Disability Services and organizations like that would just streamline and make their process a little easier to get services quicker. And I did want to follow up also on the career pathways for DSPs. We had a little bit of a discussion on that. I know there's been some investments made, and it seems like it's something that's people are very receptive to and like a lot. Yeah. And the system at Liberty ARC, which is in Amsterdam in my district, they had received some federal funding, but particularly I wanted to ask about supporting some investments in our SUNY schools and creating actual career pathways and things that people could get on a path to get a degree and get advancement opportunities and so on. I think it'd be great for retention and recruitment as well. Just your thoughts on supporting maybe additional funding, or is there something in place already that's underway?
Yeah, I think the program that the ARC that you mentioned is our NADSP credentialing program that they've partnered with us to make available to their staff. It has been a very successful program. We're sort of the leading state in the nation in terms of having DSPs run through that program. We're really very proud of that. We also have the $50 million investment through SUNY to create micro-credentialing and credits. It's also been very successful.
Okay.
Okay, so surprise, more senators. Senator Weber, 3 minutes.
Thank you, Chairwoman. Hello, Commissioner, it's great to see you again. I know we had some great talk the other day.
He's a ranker, so he gets 5 minutes. I apologize.
Thank you. Commissioner, for the last couple of years, my office has heard from many self-direction families noting difficulties in accessing benefits for community classes. And, it seems like some fiscal intermediaries are not paying for those classes, even though many of those classes were covered in the past or covered for other people and meets all the criteria. I just wanted to, bring that to your attention, and I'm not sure if there's anything your department is working on that right now.
I'm definitely familiar with the issues surrounding community classes. This is one example of something someone can purchase with a self-directed budget. We're very proud of our self-direction program, which provides a lot of flexibilities to individuals and families to purchase their own services. One of those things that they can purchase is called a community class, which is something you or I could go and take, like an aerobics class, if you're into that, Senator, and then be reimbursed with Medicaid funding for that class. So it really does provide a lot of flexibility for folks who are enrolled in self-direction to explore things that they're interested in and expand their skills. Because it is federally funded, it comes with rules around how to approve that line item. So it can't be a community class that would otherwise need to be that duplicates a certified program, like a day program, and it also needs to be genuinely integrated and open to the community. So it can't be a class, for example, it's developed just for people with autism. So I know that there's a sense of frustration that limits what people can spend those funds on, but there are literally endless thousands of classes throughout the state that people could purchase with that line item. And it's only one type of service available through self-direction.
Okay, thank you. And just one other question. And again, our office has heard from many people in self-direction that they'd like to see a deputy commissioner dedicated to self-direction. I'm sure you've probably heard that as well. Any thoughts to that, and anything that we can expect on that as well?
I am familiar with that advocacy. I've talked to a lot of parents about this perceived need that we need a whole deputy commissioner for self-direction. We have tons of full-time staff committed to the self-directed model, reviewing budgets and facilitating self-direction for the 35,000 people statewide that are enrolled in that program. It doesn't, in my mind, add anything to the function of that program to add yet another state administrator.
Okay, thank you. Thank you, Chairwoman.
So senators seem to be multiplying. So now we have Senator John Liu for 3 minutes, and then closing will be one more senator after him. Yes.
Thank you, Madam Chair, and thank you, Commissioners. I only get 3 minutes because I don't rank, but I appreciate the both of you being here, and it's been a long time. My question is for Commissioner Cunningham. I know in your testimony you talked about trying to address some of the problem gambling issues. My question for you is, it's been several years since we've established new casinos upstate. Has Oasis looked at any potential problems with related to gambling addiction that have arisen from the establishment of those casinos?
So, I mean, we are constantly looking at the data in terms of problem gambling. I don't know that we can attribute it to the specific locations, but we have a robust data collection statewide among young people about their gambling behaviors. And we're looking at, the number of calls to the Hope Line, the number of people who are accessing treatment, and asking for help. And so, we're using data to certainly guide our approach. That's a targeted approach, and to ensure that we have the capacity in our system to address the need.
It seems like, based on your testimony, that it's kind of like it's being treated as a potential problem as opposed to a real problem. And the data collection is not necessarily related to the casinos themselves, but more sports betting, online betting, etc. So is there a plan to look at the impact of casinos themselves?
I mean, yes, so we're looking at both, the online sports betting and, you know, gambling behaviors in general. So, I mean, we are monitoring what comes in for the calls, the reasons why, so how much is sports betting, how much is, you know, gambling at tables, how much is lotto, et cetera. So we do break it down, and we can provide that specific information.
And is there any kind of, perhaps, for lack of better terminology, culturally and linguistically capable monitoring of this situation, maybe working with community-based organizations to help with that?
We absolutely do, and we do work in different languages and understand there are definitely different cultural issues around gambling and where that fits in communities.
Has OASIS identified cultural disparities with regard to gambling addiction in different communities?
We're looking at that now, and we're working with specific communities to make sure to enhance the services there that are culturally relevant. Yes.
How long does it take to look at this data and come
We're
to some kind
constantly
of
looking at
conclusion or lack of conclusion?
Yeah, I mean, we're constantly looking at the data, but I think
So no conclusions as of yet?
off the top of my head, for specific communities, I don't have that, but we can certainly take that back and look in more detail.
Thank you.
Thank you, Madam Chair. Good afternoon, Commissioners.
that's it.
My question is for Commissioner Cunningham, and it's kind of piggybacking off of Judy Griffin's question regarding the opioid settlements. So how involved is the department in reviewing those plans? Do you have to approve them? Are they accompanied with a spending plan?
Yes, so per the legal requirements, we had to approve all of the planned spending for the opioid settlement funds for every county. That's part of our regional abatement. So some of the counties get money directly from the Attorney General's office. That's not under our purview. So we have that information actually on our website of the planned spending, and we are collecting the information on the actual spending now. And once we have that information, we will also include that on our website for each county.
Because I'd like to flag, I'm not sure that any of these plans that are on your website or that you have approved are falling into this category, but I'm going to use Nassau County for an example. Nassau County has settlement money, and it might not be your money, but I'm flagging this for you to look at. Nassau County has spent only about 10 to 15% of the funds that they received, the $90 million. They are accruing interest on that money, sitting on that money, not utilizing it and putting it out there where people are struggling with addiction. They're actually making money on it. And so that's a challenge that we find back home in Nassau County, and I'd like to make sure that any of the state mandated plans are not being utilized in that same fashion.
The plans that we approved were for the counties that we gave money to. That does not include the counties on Long Island or New York City, but we are talking with the Attorney General's office about the reporting to us for how those dollars are used. But we are accountable for 36% of the opioid settlement funds that come to the state. That does not include New York City or Long Island counties.
No, I'm aware of that, but I'm just trying to flag for you to make sure that those that did receive money from your efforts, from the efforts of the AG's office, that they're spending that money according to the plan. Because what we found is that families are still struggling, and Nassau County is benefiting by gaining interest on the money to the tunes of over $3 million. Thank you.
Staff, and continue to go out there and work for us. We need all of you. Thank you.
Thank you for your time.
And with that, I'm going to call up the last government panel, the New York State Justice Center for the Protection of People with Special Needs, Maria Lisi Murray, Executive Director.
Unbelievable. Mhm.
Good afternoon.
Good afternoon. Are you able to hear me okay?
Yes.
Excellent. Okay. Good afternoon, Chairs Fahey, Brooke, Kruger, Santa Barbara, Simon, and Pretlow, as well as to your distinguished colleagues of the Senate and Assembly. My name is Maria Lisi Murray, and I am the Acting Executive Director of the New York State Justice Center for the Protection of People with Special Needs. Thank you for the opportunity to testify regarding Governor Hochul's fiscal year 2026 executive budget proposal. I also want to extend my sincere thanks to Governor Hochul for her continued commitment to funding the only agency in the country mandated to both protect vulnerable populations and ensure the workforce has the tools to prevent future abuse. When the Justice Center was established over a decade ago, the state ushered in the strongest protections in the nation against abuse, neglect, and mistreatment. With each passing year, our agency continues its vital mission of protecting vulnerable populations receiving services from 6 state agencies. Our agency is unique in that most of our staff have not only worked in settings under our jurisdiction, but also have a family member in care. Over the last year, the Justice Center substantiated nearly 4,000 cases holding subjects responsible for egregious conduct. We prevented over 300 violent criminals from re-entering the workforce. And over the last decade, we have barred over 1,000 of the worst offenders from working with vulnerable populations. In March, I was elevated to acting executive director. With that change, I can draw from my previous experience to improve our operations. This includes my nearly 7 years in the City of Binghamton Police Force, including my time as a patrol officer and investigator in the Special Investigations Unit, more than 2 decades as a litigator in both the private and public sectors, including 3 years in the Attorney General's office, and the more than 5 years as a Chief Risk Officer with the Department of Motor Vehicles, and most recently, my time in a similar role here at the Justice Center. During the last year under my leadership, the agency focused on 3 main growth areas: improving the quality and efficiency of service, strengthening current and forging new community partnerships, and expanding our abuse prevention efforts. To meet our first goal, we have developed ways to close cases faster and get quality staff back to work quicker through process improvements. While our primary duty is to serve and protect individuals under our jurisdiction, we understand the tremendous burdens placed on the state's direct care workforce. That is why we have prioritized evidence introduced early in an investigation that exonerates 1 or more staff members implicated in a Justice Center case. We have also placed increased attention on our ability to find a facility responsible for an act of abuse or neglect rather than the individual. Known as a Category 4 finding, this oversight function allows the Justice Center to address systemic issues at a provider, holding them accountable for inadequate care that could be putting individuals at risk. To satisfy our second goal, engaging with new and existing stakeholders, the Justice Center reached beyond its typical audience to connect with first responders, a group that frequently interacts with vulnerable populations in the field. As a former City of Binghamton police officer, I know that law enforcement and first responders play an important part in promoting the safety of vulnerable people. However, these interactions present unique challenges for emergency response professionals and require specialized training to improve outcomes. Leveraging more than a decade of experience working with individuals with special needs, the Justice Center developed and launched an expanded portfolio of courses to train attendees on respectful communications, forensic interviewing skills, and investigative best practices. In 2024, we presented to over 200 participants, including members of the New York State Park Police Recruit Academy, the Bronx District Attorney's Office, and several city and county police and sheriff's departments. Agency staff also continued several initiatives to support our longstanding stakeholders. We participated in nearly 70 outreach events, advised hundreds of individuals and families throughout the course of investigations, held roundtable discussions with our sister agencies, and shared the Justice Center's story. And to address our third goal, expanding our abuse prevention efforts, more than a decade of data has afforded us the opportunity to educate our workforce and close critical gaps in care. For example, in response to our data showing an increase in choking incidents at residential facilities, we created a toolkit that outlines best practices for adhering to food safety care plans. My time heading the agency's quality control efforts underscores the need for a holistic approach to proactively use the information we collect in our investigations to prevent future abuse and neglect. On the regulatory front, the agency engaged in 2 rulemakings. One to foster inclusivity by adopting gender-neutral terminology in our regulations, and the second to codify the use of remote meeting platforms for our surrogate decision-making committee hearings, which supports the nearly 800 hearings conducted last year. These hearings make critical and speedy medical decisions for individuals who lack the ability to make these decisions themselves. As I touched on earlier, this work is very personal to the staff at the Justice Center. Let me tell you why. Approximately 40% of our nearly 500 employees have a family member receiving services from programs under our jurisdiction. That means our staff, they have stake in the game. They want justice for victims of abuse or neglect, just like the families we serve. At face value, we can summarize our work in just a few words: investigation, education, and action. But to the more than 1 million New Yorkers under our watchful eye, this agency means so much more. To the parent of a child with Down syndrome, the Justice Center provides peace of mind that your child will be protected even after you're gone. To the service recipient enrolled in a substance use program, our agency is a welcomed safety net and fierce advocate for justice. And to the providers under our jurisdiction, we are a vital resource that offers education and training to create safer programs. This is why we will continue our important work and are grateful to the governor for once again investing in the protections of our state's most vulnerable populations. Thank you for your time, and I'm happy to answer any questions.
Okay. Hi. Very quickly, is it true that the Justice Center does not have jurisdiction over recovery programs?
I'm sorry, it's a little hard to hear you.
Is it true that the Justice Center does not have jurisdiction over recovery programs?
With respect to Justice Center jurisdiction over recovery programs, are you speaking to the question that was offered up to Dr. Chinazzo earlier? Dr.
Oh, I
Cunningham?
missed it, I'm sorry.
Oh, okay. We do have jurisdiction over certain OASIS-based programs, if that's the question that you're asking. And when individuals report abuse or neglect in those programs, we do have the ability to come in, conduct an investigation. They are conducted to conclusion, substantiated or unsubstantiated. In either case, whether substantiated or unsubstantiated, the Justice Center does have the ability to utilize what we call our CAP program, our Corrective Action Plan program. So the provider provides us with a corrective action plan, and we audit against that to ensure that any issues or concerns, gaps are being appropriately corrected.
Okay, yeah, because it's been in my experience that some recovery centers have been denied help from the Justice Center, so I wanted to know if you were aware of that, because I do know that some OASIS-covered programs do have jurisdiction by the Justice Center, but please know that there are recovery centers that do not, that could use it. Thank you. Button don't work.
Thank you. Excuse me. Thank you very much. Sorry. Thank you for your testimony and for your work and for meeting with me earlier this session. I had a couple of very quick questions to ask you. And one is, I appreciate this Category 4 investigation that you're doing. I am curious, how many of those investigations have you done? What are the kinds of systemic issues at a provider? And then when it comes to sort of holding them accountable for inadequate care, what are those remedies? What are the penalties, if any, to that provider? And how do we remedy that situation for the people who have been the victims of this inadequate care?
Thank you for that question. So we receive approximately 90,000 complaints of abuse and neglect through our call center each year. Wow. Of those 90,000, approximately 11,000 boil down to abuse and neglect investigations. With respect to Category 4 findings, our statistics are they are at about 5% of our abuse and neglect investigation workload. It's a new eye, quite frankly, the Justice Center has taken towards being sensitive to the workforce situation, being sensitive to sometimes individuals are asked to work multiple shifts back to back. If I can offer an example of what a Category 4 might look like, you might have an individual who's worked multiple shifts, is asked to transport an individual receiving services some ways away to a doctor's appointment. They indicate they're tired, they don't want to, told to do it anyway, and ultimately there's some sort of car crash, they fell asleep at the wheel. That could in fact be a type of Category 4 finding, because it's looking at the incident holistically in the totality of the circumstances beyond the individual who is being blamed, because is it really their fault, or are we looking at more systemic issues like lack of workforce, being asked to work repeatedly, not being able to turn down an instruction to drive someone if they're too tired.
Great, thank you.
Yes.
And another question I have, which I'll use an example in my experience that is not relevant to your agency, but supported housing facilities, right? I must have 5 within 3 blocks of my house, right? So I'm pretty familiar with the programs, and it seems to me that one of the key issues is good management. Mm-hmm. And particularly where you may have an issue with staffing, et cetera, good management is even more important. What, if anything, does your agency do to help with that situation? So in other words, if part of this problem is that it's just not good management, how do you address that issue?
Well, we don't have a role with respect to supporting housing. That would be outside
Well,
of our
that I know, that's why I said that wasn't really the right example, but
Yep.
it could be in your situation as well.
Absolutely. And it would go back to the CAP audits, that I referenced earlier. These are our opportunity for the Justice Center to come in. The provider will provide us with their plan for making improvements. We can identify issues such as, like I said, staffing issues, issues of inadequate training, whatever those issues may be that are systemic to the facility or the provider. We go back in and we ensure that the remedial actions are being taken and that the provider is adhering to the corrective actions that they committed to implementing.
Great. Thank you. I
Sure.
appreciate that very much.
Yeah.
Thank you. I'm done.
Sorry, mics, and they're still hard to get on. Thank you for being with us, Director, and thank you for your testimony. Can I just pick up very briefly on the Category 4? And, was there some impetus for this? And is it data-driven in terms of sites where you have seen repeated problems? Can you just explain what the impetus was and what you're hoping to achieve here?
Absolutely. So under my leadership, one of the things that I felt was really critical to the agency was taking the data that we receive, using that to drive data-driven decisions. I think it's really important that we're not relying on anecdotal evidence, but in fact the data that we see. It's no secret that there are concerns with the workforce. We know firsthand people are working longer hours and being put under more pressure. These individuals are doing a very, very hard job. We felt it was important to take the totality of the circumstances into consideration in this regard and in essence, identify what are the actual causal factors to this outcome that's problematic.
Okay, thank you.
Thank you.
And in terms of your regular cases, and obviously we appreciate what you do, as you can imagine, especially when the Justice Center was first launched, we used to hear about a whole host of concerns. And one of the concerns that I continue to hear about, and I think we spoke about this last year, is the timeliness of the investigations. How difficult that is. We've heard all afternoon about the pay of many workers in our facilities and how difficult that is. And there are times because of an allegation that may be a very old one or a long-standing employee who is faced with an allegation and they are removed and not paid. They're off a payroll for months and months and months at a time because of an investigation. And again, while we all recognize the importance of being vigilant, there are some dire circumstances to the individual, especially if they are, recused from any of those allegations. Can you talk about the timeliness and what the procedures are in our facilities? Does somebody actually have to be removed completely from the facility? Or at times, can they remain on a payroll? Can you just talk about what levels that is, and again, a focus on the timeliness?
Certainly. So back to the timeliness issue, one of the things, when I started in this position, I wanted to look at ways that we could expedite, move our investigations through without reducing quality, obviously. So we took a look at our intake. We operate a 24/7 call center where we receive the 90,000 calls each year. And part of that unit has what we call 3 BDR, a 3 business day review model. These individuals, when there's a call with respect to abuse and neglect, they begin the process immediately of collecting whatever typical documents you might have, care plans, policies, and they begin to put the case together and identify the plan moving forward in order to help expedite the actual investigation process and weed out those that should not be going through a full investigation process. So that has been step one. Step two that we implemented what we call early unsubstantiation of cases, and this operates through our investigations unit. Our investigators will take cases where we have maybe multiple subjects accused of abuse and neglect, and if we can look at the evidence that's been collected right in the front of the investigation, oftentimes we find there are individuals who we can quickly exonerate. They weren't working that day. It's not a question of did they do it or not, but they were just in no way, shape could be responsible for this. And we now sever those people off and drop them from the investigation in order to return them back to work in a more timely fashion. And then again, in terms of moving through investigations in a timely fashion, the Category 4 findings, we believe, does help do that. We help to get people back to work if we're not focused on the individual and we're more focused on the systemic issue within the facility, because that's the thing that needs to be fixed, right? And then with respect to putting people out of work, that really falls to the employer, the provider, the employer of that individual. The only time the Justice Center, truly, mandates somebody being removed from work completely is if they're put on our staff exclusion list, and then they can't work with any of the vulnerable populations. So, there's always safety to be concerned about. There's always safety care plans can be implemented. There may be other ways around it that I can't speak to that would need to be addressed by the provider community. But we don't instruct people to be taken out of work unless they fall on our staff exclusion list.
Thank you, and I look forward to hearing more as you roll out the Category 4 to see, whether that helps to really target some of the more routinely problematic sites, and if it helps to really target some of your work. And I think we still have some implementation work in terms of some of the providers and the homes on this staff exclusion list and whether people are off payroll or not. It just seems like there still is, given the calls that we receive about individuals who, in a number of cases where it was not substantiated. So I appreciate your fresh look at this and trying some new ideas, and thank you again for your testimony. Thank you, Chair.
Thank you, Assembly.
Assemblyman.
Thank you, Chairman. One thing you said in your testimony intrigued me. I want to sort of dig in a little bit on that. You had indicated, all right, we've been doing this 10 years, and now we can sort of see patterns, and you indicated choking incidents were up. I would think 10 years in is sort of a good time to sort of go back and say what's working, what's not working, what are we seeing more of, what are we not seeing more of, what problems have we solved, what are new problems we didn't anticipate. Are there any other patterns that are sort of like that you could point to as far as the type of incident or the type of victim or a geographic pattern, anything like that, now that you have 10 years of data?
Absolutely. So historically, we've looked at this data and then identified areas where we felt training should be improved. Like I talked about the choking in the food, safety care plans. We've looked at wheelchair securement, developed toolkits for that. We've looked at issues with respect to inappropriate boundaries. We developed toolkits for that. These are on our website, so anybody can look at them. But we have always felt, that at the Justice Center, that having this data affords us the ability to identify, areas where people may be we may be seeing more reports, or people maybe need more training, or there should be some clarification. That's where we want to dig in. I really want to focus, in my year ahead on preventative measures, utilizing our data to instruct us on where prevention can make a difference.
What would be sort of the biggest difference in the type of investigations you're doing today compared to when you started? What would be the biggest change over that time?
Well, I've been at the agency for about 1.5 years total at this point, so.
Yeah. Over the whole life of the agency, maybe not your tenure,
Yeah.
if you have that information.
I do think, though, that the big new fresh look, so to speak, is Category 4. The Justice Center, is charged with protecting the health, safety, and dignity of vulnerable populations, but we're also charged with, supporting our direct care workforce. And that's where I see, at least in one aspect, we can make a real difference, and that we can provide the tools and the training give the workforce, at least from our perspective, the things, that they should be thinking about and have front of mind as they care for our state's most vulnerable people.
Well, thank you very much for what your organization does, and as a special needs parent, I really appreciate it. So, I'm all set.
Excuse me, we have Senator Konzenary Fitzpatrick.
Thank you, Madam Chair. Thank you so much for being here today and for testifying. In your testimony, you mentioned developing and launching best practice training courses, which had over 200 participants. I was wondering if you could expand on how that is organized. Is this across the state? Do you have interested departments contact you, or do you contact them? Or they, and just how that training is going about?
Thank you for that question. This is one of the new initiatives that I've implemented as soon as I came into the acting executive director role. Based upon my background in law enforcement investigations, I have always felt there was a gap in terms of this training and understanding. And our first responders, EMS, fire, police, they need the tools in order to do better and in order to recognize that sometimes approaching a situation with a law enforcement or a criminality lens isn't the right way to go, right? So we implemented what we call our mandated reporter trainings. Those are done remotely via WebEx. Individual agencies or any first responder agency can sign up for it. It's free. And then they get renewed training, renewed understanding on what their responsibilities are as a mandated reporter, because they are a real vital source of reporting and information to the Justice Center. The other area of training that we are building out, and we've got additional training scheduled for the upcoming year, is in our forensic interviewing training, or we call it our FIVP. This is the training when you have an individual who cannot articulate themselves verbally. This is the training that allows first responders or any investigator to engage with that person effectively. So it's a unique training. It's something that within our expertise that I think brings something different to the first responder, and investigators world.
So what type of feedback are you getting from those who are participating? Do we need to expand this? Should it be mandatory? What other suggestions might you have to improve this?
We've had excellent feedback. I mean, it's fairly new in this regard, but as I said, we've had over 200 folks respond to the training, and it literally was only rolled out a few months ago. So I think it's very important to understand that first responders want this information. They want the tools. They want to do better. I have definitely leveraged my experience and relationships in the law enforcement and first responder world to make sure that people understand and have awareness of what it is that we can offer. Crimes against individuals with special needs who can't speak for themselves or can't articulate themselves, they're a much harder case to successfully bring to trial. And we want to ensure that people, who do wrong are brought to justice. And if we can help in that way, we're happy to do so.
Well, thank you for your efforts, because hopefully what you're doing is preventing them from these incidents from ever occurring. And I do know of a couple of families that have dealt with these types of incidents, and it's so traumatic. So thank you for your efforts, and I have nothing further.
Thank you.
Assembly distinct? None. Assemblyman Ross? Assembly Santa Barbara?
I'm just going to my list here.
Okay.
Not turning on. Okay, thank you, Mr. Chair. Thank you for your testimony. Thank you for being here. I wanted to just ask about a few different areas, mainly with how are we ensuring that individuals with disabilities, particularly nonverbal individuals, have input on things that, reports and things that happen, and some of the policies that the Justice Center has implemented. How are we getting that input, and how are we making an effort to include nonverbal individuals?
Sure. So with respect to input to the Justice Center, I'm sure you're aware we have an advisory council that we meet with regularly. These are individuals who work in the provider field. We have self-advocates on our advisory council, and they are, they are the boots in the ground folks who bring us back the information in terms of what their concerns are and what they're seeing day to day. With respect to the nonverbal community, we do have a training. It's a forensic interview training that I was talking about earlier, which allows first responders or investigators to be able to, utilize skills in forensic interviewing to communicate effectively with nonverbal individuals. So we do have an expertise in that area that we are bringing to training and trying to roll out to the broader population of first responders.
And you mentioned mentioning first responders. That's a good segue to the next question. I guess there has been a bill circulating about mandatory 911 reporting when something happens at one of these facilities. And I think that bill was amended, and I think ended up with some informational materials that are now posted or supposed to be posted in certain areas. But what's your opinion on that, on mandatory requiring for a 911 call if something happens, especially if it's a nonverbal situation where you're not exactly sure what happened? Is that something the Justice Center supports?
Well, the Justice Center is not an emergency response or a first responder agency.
I understand.
Our call center operators, there's they have a script, and one of the first questions that they ask is has 911 been called? Is this an emergency? There are other ways to submit a report. We have a web report, so it doesn't have to be verbal. But to the extent, pending legislation, I really wouldn't want to comment on that, but we would not be, the Justice Center would not really be positioned as a first responder agency, given what we do. The vast majority of our reports are not emergent. They are after, after some time has passed.
And in terms of funding and resources, staffing, do you have the resources and the staffing available to investigate all the cases that are being reported?
At this time, we are sufficiently resourced to do, and complete our mission. We thank the governor once again for supporting protections for vulnerable New Yorkers.
And are there training programs for DSPs as well to prevent these neglect and abuse? Are they in place, and is there anything else we need to do to bolster those programs?
Absolutely. We have an entire unit that's dedicated to prevention efforts. Our prevention efforts and toolkits and guidance, it's on our website, so it's publicly available for anyone to look at. We take it we take training very, very seriously. We feel that giving direct service providers the information and the guidance and the best practices is an effective way to prevent abuse and neglect.
I guess with the system in place, can you just walk me through, like, once an incident is reported, could you just walk me through the process of what happens next, and what are the following steps, and what is the follow-up from the Justice Center?
Sure, absolutely. So if our Office of Incident Management receives a call and there's an allegation of abuse or neglect, it will go through the process. Typically, it will go through this 3 business day review process, and the documentation will be requested up front. So like care plans, what specific diagnoses might be relevant to the individual who is, the victim. And that information is collected up front, and then a plan is prepared in order to move forward. We identify who the witnesses would be. We identify who the subject would be, and obviously we go out, our investigations team would go out and on site and talk to these people individually, and begin the process of collecting evidence to determine whether we can substantiate an abuse or neglect finding against the subject. So once somebody is, you go through the process assuming they are substantiated, it's the term we use. They do have a right to request an appeal from that. We have an internal team of attorneys that will review the appeal, go through all the evidence, make sure that there is sufficient evidence in order to move the matter forward to a hearing. And ultimately, any subject accused of abuse or neglect has the right to an administrative hearing.
And who has access to those documents? Do caregivers and parents, are they able to access the reports?
Yeah, and it depends. There is an investigative summary report that gets prepared, and yes, parents can access it. We have privacy protections in our statute that prevent certain people from seeing certain things. If there's a specific ask that you want or you think you need to see, we can certainly have a discussion offline on that topic, but we're always trying to balance those two competing interests.
In addition to that, I guess the other question is that process you just described, how long does that typically take? How long does it take to get information back on what happened?
It
Or
depends.
to get I guess an answer either way, determination of what the situation actually was.
Sure. It can depend wildly. Like
Okay.
if we have an incident where there's criminal conduct and we're in contact with the district attorney's office, it would not be unusual to be asked to hold our administrative case while they complete the criminal case. That being said, we work in parallel. It's not like we don't. We continue working our administrative side, but we collaborate. We help ensure that whatever evidence is useful to a district attorney to obtain a criminal conviction, that we're helping to sort of package the case for them in order to ensure their success on the criminal side also.
And you mentioned substantiated versus non-substantiated. How many cases, do you have an estimate of how many cases come your way, either month or year? And how many of them do end up being substantiated versus
Sure.
not?
So each year, we have approximately 11,000 abuse and neglect cases that we investigate. We substantiate approximately 40% of those each year.
And most of the ones I've heard of have been reported by someone else in the facility. In your opinion, are there barriers to that? People reporting the cases, actually having the mechanism or the opportunity to report something if they see something?
Yeah, barriers to reporting are completely unacceptable. That is something we make very, very clear. There can be no retaliation. There has to be a clear reporting line. People are mandated reporters, and we expect them to, make the reports if they see something that they believe is an abuse or neglect situation.
Okay, thank you for your answer and your testimonies
Thank you.
today. That's all I have, Mr. Chair.
I'm just double checking. I don't have any more senators on my list. Am I missing any of you? No. Assembly, it's yours.
Assemblywoman Giglio?
Yep.
Thank you. So as a follow-up to what the chair on the committee said, so out of all the complaints that the Justice Center gets, how many of those actually rise to the Justice Center doing an internal investigation instead of the agency?
Yes, thank you for that question.
What
So
percentage?
So the Justice Center retains approximately 40% of the cases of alleged abuse and neglect that come through. These are typically the most egregious, most troublesome cases, and we have about 60% that get sent back to the oversight agencies in order to do their own investigation. That being said, please understand that when we send those back to them to do an investigation, we have a guidance document in terms of what we expect, what our agency requirements and controls would be. And then when the investigation is complete, they always come back to the Justice Center at the end, and we do a final review, and if we're unhappy with an investigation, we can always send it back. But we have the last say in terms of whether that investigation is properly done and complete.
Okay, and then you had said that you work in parallel with the district attorney's office. What about cooperation with local police? Do you think that an investigation from the Justice Center should be automatic when there is a police or an ambulance or somebody's hospitalized? Do you think that should just automatically be something that the Justice Center investigates? And how do you track and analyze data on cases involving people with disabilities to identify systemic issues?
So you know, one of the reasons that we've rolled out this first responder initiative and this first responder training and reminding them of their obligations as a mandated reporter is because they are a critical reporting source for the Justice Center. So yes, these individuals who may respond to a scene or may have, you know, be taking someone to the hospital and they suspect abuse and neglect in that situation, yes, we would want them to call us. So that's really kind of been the crux of you know, why we're rolling out our training and outreach efforts to first responders. With respect to, can you just remind me of your second question?
Yeah, I mean, back to the first question, because I do have a couple minutes left, but, so, when police or when emergency, because this was a question I asked of the commissioner earlier, is, you know, you're getting a call, you have people that are in the house, these are minimum wage employees that are dealing with people that are disabled, that cannot speak for themselves and cannot stand up for themselves. So you're depending on, you know, someone in the house to just say, okay, I better call an ambulance or I better call police. And then when they come, don't you think that that should warrant an investigation by the Justice Center as to whether or not the people in the house are properly trained?
Well, I think that the key to warranting the Justice Center involvement is if that first responder believes there's some evidence of abuse or neglect.
Yeah, but with discovery laws and litigation and everything else, first responders are going to be reluctant to actually follow up on a complaint. I think that it should be automatic. And then the second question was, how does the Justice Center track and analyze data on cases involving people with disabilities to identify systemic issues? So this is happening over and over again in this house. Is it the workers? Is it the, you know, the behavioral needs of the people that are in the house? Or, you know, what triggers that, like the Justice Center to say, hey, we might have a problem here in this house?
Sure, absolutely. So we do have the ability to track individuals who may come up in our data as somebody who's a victim, you know, who's shown up repeatedly. If we see a situation like that in our data and we do track that data, we have the ability to send out our quality and audit teams. We can do an unannounced site visit. We can, you know, we have the power to do that. If we feel that there is some situation going on at a provider that's problematic, we will utilize that resource and, you know.
Thank you. I think you'd get a better picture if all reports of police going to a house and an ambulance going to a house and all hospitalizations, I think you'd get a better picture if that was automatically reported.
Fair enough.
Thank you.
Assemblyman Berger?
Thank you. Hello. It's my understanding that the provider employee at an OPWDD-funded agency, they often work for multiple agencies. And currently, if they work for provider A, they have to go through fingerprinting and a criminal background check. And now if they also want to work for a second agency, which happens often enough, they have to go through the whole, you know, the cost and the background check, a second, third time. That comes with the additional extra cost, delay in employment, and delay in services. Has a registry or central registry or some sort of other modernization effort been considered, and do you believe a registry would alleviate those workforce challenges?
Sure. So let me just start with saying our criminal background check and our staff exclusion list checks, those really are our first line of defense in terms of protecting vulnerable persons. You know, it sounds like what you're talking about would have multiple like moving parts, and we would need to work with our, you know, sister agencies to determine what something like that could ultimately look like. So I hope I've answered your question, but if I haven't, please let me know.
That's good. Thank you. That's it.
Thank you for being here today. I just first want to congratulate you on the incredible work you and the Justice Center are doing. I appreciate your approach and the accomplishments made with protecting and serving this very vulnerable population. I wondered when, I appreciate the focus on the systematic issues that are reoccurring. And what I wondered, when did that start, that focus on looking at the facility as more responsible?
Well, the impetus for looking at this started closer in time to when I started at the Justice Center. This is the first year where I think we've had actual data where we can, talk about having 5% over the, course of 2024 as, being our Category 4 findings. It is an area because, I come from a background of quality, internal audit, quality, internal controls background. Like I see this as really an area that is going to help drive improvements in quality, prevention, and ultimately then protection.
Yeah, which is really what we need.
Yes.
Is there, like, if you were a family and you were considering different options of where you would be having someone served either daily or live-in, is there any public listing or anything they can access? Because, so they wouldn't choose one of these places that has some investigations, serious investigations against it or serious findings.
Thank you for that. Yes, to my knowledge, there is no sort of scorecard, I think is what you're asking
Yes,
about. We don't, there's nothing of that type currently that I'm aware of.
And do you think there should be?
I think that would require, again, probably legislation, and it would certainly require working with sister SOAs. There's a lot of data and maybe some privacy concerns, but if there's a proposal that will protect vulnerable people, we'd like to be part of that conversation.
Right, thank you. And one final question is there seems like you have a lot of, must have a decent budget because you're getting a lot accomplished, and even with the training of first responders, is your budget adequate for what you're trying to accomplish and with your new focus on the training of first responders?
Yes, so our budget as it stands, is sufficient. We're pleased to be resourced. We're pleased with the governor's investment in protecting New York's most vulnerable populations. We're very fortunate in that the trainings that we are rolling out for law enforcement, the vast majority can be done online, via WebEx, and that makes things a lot more cost effective.
Okay, thank you very much.
Yes, thank you.
Thank you very much. I have gotten a lot of feedback, and I think you've talked at length about some of the items and some of the practices and training that's involved to really take ownership over the fact that there can be harm potentially done with some of these investigations. I really appreciate that. I will say that some of the feedback that I continue to get, and it's a work in progress, I'm sure, is the same phrase. It's as though folks are presumed guilty and not innocent, and that's a sentiment that hopefully, with a lot of the things you discussed, can change over time. One question I wanted to ask you is there's a really interesting model, I want to say, in the state of Texas. I'm going to have it emailed as well, where they use individuals with different experiences, 30, 20 years in the field, to supplement some of the initial information that's brought in as more of an evidence-based approach. Would you be open to utilizing that model or something similar to make sure that some of these investigations, before they get too far, some of the very easy low-hanging fruit, folks can kind of just make sure that we get to that evidence-based approach instead?
It's interesting because, I talked earlier about our 3 BDR, 3 business day process. That is part of, it sounds like, and I'm not familiar with that report. If you'd like to send it, I would be very happy to read it.
Sure.
But this is the first instance when we get something that comes in through our intake unit. These folks identify, what are the typical documents you're going to need? What are the typical, what would we need to support an investigation? There are always documents that are, routine, like care plans, medical orders, that sort of thing. So we know right out of the gate what we need to look at least to get a handle on what the investigation may look like. That also allows us to create a plan internally, and when it goes to investigations, it streamlines it. It makes it quicker, and that dovetails on the other item I talked about with respect to this early evidence, review and this process of being able to take an investigation that may have multiple potential subjects, and if we can, basically drop those individuals from the investigation at the front end, we try to do that immediately so they can get right back to work.
I did hear you mention that, and I've been very impressed with some of the things that you've said, and they've been in contradicting to some of the other items that I've heard. So what I'd love to do is have a close relationship with your office, and as I receive some of this information on models that work in other states, would love to pass that along.
Excellent, thank you.
Thank you.
Appreciate it.
Double checking, anyone else for this director, sorry. All right, hearing from no one, I'm going to thank you very much for your participation today, and you're welcome to take your leave and continue your work. And we are going to move on to our first non-governmental invitee panel. We're calling you Panel B. So New York State Conference of Local Mental Hygiene Directors, Mental Health Association of New York State, the National Alliance of Mental Illness New York State. If you'd all like to come and take your seats. Okay. And now for the remainder of this hearing, everyone should remember the rules have now changed to 3 minutes for each testifier and 3 minutes for each legislative questioner. Being a chair or a ranker no longer gets you extra time or a second bite at the apple. So we will all learn to be very, very concise. And I see 3 groups on my list and yet 4 people. So let's have you each introduce yourself so the communications people upstairs know how to describe you when you do go on camera. Hi, why don't you just introduce yourself?
Introduce.
Yes.
Courtney David, Executive Director, New York State Conference of Local Mental Hygiene Directors.
Thank you. Hi.
Nathan McLaughlin, Executive Director, NAMI, New York State.
Julie LeClaire Netchis. I'm a board member of NAMI New York State, psychologist and mother of somebody with a mental illness.
And which group are you with, I'm sorry?
I'm with
You're with
same
him.
organization, NAMI New York State.
Sorry.
We're going together.
Thank you, okay.
Glenn Liebman, CEO, Mental Health Association, New York State.
Okay, so we go back to this side of the table. You have 3 minutes, the two of you together have 3 minutes, and then the final for 3 minutes. Thank you.
Thank you. Good afternoon. Again, I'm Courtney David. I'm the Executive Director of the New York State Conference of Local Mental Hygiene Directors. The conference consists of the Directors of Community Services for the 57 counties and City of New York. Thank you for the opportunity to testify today regarding the proposed executive budget and our priorities to improve the mental hygiene systems locally. First, we must reform the state's competency restoration process. For the last several years, the conference has been advocating to implement these reforms, and it is time to finally overhaul the archaic statute that governs the process for determining a defendant competent to stand trial. In fiscal year 21, the state shifted 100% of the cost of competency restoration onto the counties. The per diem rate for one individual in a state-operated forensic facility is approximately $1,300 per day. Over the last 4 years, this policy action has diverted hundreds of millions of dollars away from counties and their local systems of care. For example, Warren County, with a population of 65,000, has experienced a 10,000% increase in costs. 14,000 was 2019, 2024 was 1.6 million. In many counties, these costs are now exceeding the property tax cap. Restoration services do not replace appropriate treatment and supports, which in many cases has led to repeated cycles of incarceration. More individuals deemed incompetent to stand trial are being sent to state forensic facilities, and many have been in restoration for periods of 3, 6, or even 10 years. The DCS has also received little to no clinical information or timelines for discharge. I want to thank you, Senator Brooke, for your ongoing support by carrying our bill, which includes the reforms necessary to address this issue. We are also requesting your support for a 20% administrative state aid increase to sustain county-based single point of access programs. SPOA programs are vital local supports which link individuals and families to needed services, especially those with histories of homelessness and criminal justice involvement. SPOA coordinators make referrals to treatment and supports, provide care coordination, and work with clients to help navigate complex systems. In many cases, they serve as an advocate for individuals and their families. Despite increasing responsibility, state funding for these programs have remained stagnant, and many rural counties struggle to retain full-time coordinator positions. We also request the inclusion of a provision outlined in Addendum 1 of my written testimony to require the sharing of clinical records under AOT orders with the county directors. A 2011 legal case, known as the Miguel M. decision, has at times restricted their ability to obtain these records, particularly in New York City. We strongly support the governor's enhancements to AOT programs and inclusion of $16.5 million to assist counties with this process. However, the final budget must include our suggested amendment to ensure the appropriate coordinated care is available to support these individuals. Thank you for your time and consideration. I look forward to working with you and your staff this budget cycle.
Good afternoon. Thank you for the opportunity to provide testimony. Again, my name is Nathan McLaughlin. I'm the Executive Director for the National Alliance on Mental Illness, the New York State chapter. The issues we'll be testifying on today have long impacted myself and my family as a parent of a child with mental illness. With me today is NAMI New York State Board Member Julie Leclerc-Netchus, who will also share a piece of her story. Our message today is really about progress. And collaboration with both the executive and the legislature. As you'll read in our testimony, we're really looking at our three legislative priorities this year, which is fighting for people like Alex and Nicole, some of the most vulnerable New Yorkers living with serious mental illness. Also breaking down barriers, building bridges, and increasing access to mental health services for all New Yorkers who need them, and of course addressing the youth mental health crisis. There are two issues that we would like to see improvement on, which is the 2.1% increase and the prescriber prevails issue we'd like to have another look at. But I hand my time over to Julie Leclerc-Netchus.
Okay, so I already said who I am, so I'll just get started. So my daughter Alex was diagnosed with bipolar disorder her freshman year of college, and I was called onto the campus, and I actually lived in the infirmary in the parent room while she was in the psychiatric unit. It was a little like the movie Freaky Friday. I was living the campus life, but she wasn't leading my life. And while she was on the psych unit, she emailed the entire freshman class at Dartmouth and got stigmatized, so she ended up transferring to NYU. And while she was there, she did great, and she advocated for others with a mental illness. And I'm also so honored that Governor Kathy Hochul told my daughter Alex's story at the State of the State so that she could still make a difference. And it's like my daughter, who was advocating for those with a mental illness, was still advocating from up in heaven. And my daughter ended up having an issue when she transferred to NYU when my dad died, and she ended up needing the services that Governor Kathy Hochul is prioritizing, and they really helped her. And even though my daughter did not make it and passed away at age 25, some wonderful things happened. NYU posthumously gave her a college degree, and also at the funeral, all these people I didn't know came up to me and said they were on psych wards with my daughter, and she had uplifted them while she was on the psych ward and made a difference even while she was in a manic episode. And one person who couldn't come to the funeral went gravesite, read my daughter Alex a 7-page letter, said she wouldn't be in med school if it wasn't for my daughter, and that she was going to name her first child after her. And so I want to thank you for letting me give Alex a voice, and she is still advocating right now. So thank you.
That was incredible. My name is Glenn Lieben. I'm the CEO of the Mental Health Association of New York State. I've been CEO for over 20 years now, and I've had the privilege of testifying all these past 20 years. So our organization has 26 affiliates in 52 counties throughout New York State. We provide community-based mental health organization. We're a community-based mental health organization. We provide services on the ground. I just want to welcome Assemblymember Simon as our new chair. Thank you. And I also want to acknowledge Aileen Gunther, who was our former mental hygiene chair in the Assembly. Aileen was a really strong advocate and a really good friend, and we wish her luck. And I also want to recognize we're so glad that Senator Brooke is back as the mental hygiene chair as well. So we have extensive testimony, which I'm obviously not going to read, but it's largely based on workforce, our response to Kendra's Law. We have a 10-point plan, behavioral health parity, youth and teen mental health first aid, mental health training for teachers. Thank you, Senator Fernandez, for your support for that bill. Mental health in colleges, first responder peer support, prescriber prevails, and equal payments for adult home residents. I'm going to just, on my brief time, I'm going to talk about workforce. And almost all of you articulated it so well, much better than I could, about the challenges that we have. We have a 30% turnover rate on a yearly basis. Yesterday, a woman spoke at our press conference about how her son had 11 case managers in 10 years. How do you develop a therapeutic relationship if someone leaves after 10 months? Now, Governor Hochul has been the best governor we've ever had in terms of her commitment to workforce. She's provided more than the last 4 governors combined, but as we all say, it's still not enough. We are advocating for a 7.8% increase, which is based on how funding over the past 4 years did not meet the Consumer Price Index. This year, she's proposed adding 2.1%. It's a start, but for someone like my son, who is a direct care worker who makes $30,000 a year, that amounts to $12 more a week. That's hardly a recruitment tool. Our people are mission-driven. That's why they take these positions, but mission-driven doesn't put food on the table. We can't keep up with salaries in the for-profit companies like Amazon and Walmart and fast food. We can't keep up with the state workforce either. For equivalent jobs, they pay higher salaries, and we just found this out a few months ago. Their benefit package is 65.5% for the state workforce. Ours is capped at 27%. When a state worker retires, they receive a nice pension. When a not-for-profit worker retires, they receive a nice handshake. So that's really where we are in terms of the funding for this program, and we really urge your continued support to move from a 2.1% to a 7.8%. These people are doing the most incredible work in our community, and we need to support them, and anything we can do to respond to that support is really important. And including, Senator Brooke, your bill about capping CPI with COLA is something we would love to see happen, and we're obviously advocating for that. So thank you.
Surprise guest, will you say your name once more for our tech people? Because we don't have it in
Me?
writing anywhere.
Oh,
Yes.
Okay, so I am Julie LeClaire Netches, N-E-C-H-E-S, Julie LeClaire Netches.
Thank you very much. It's
Okay.
just so that our tech people know what to put on the screen and
Oh,
the
okay.
record. Thank you.
All right, thank you.
Thank you. And our first questioner is Senator Summer Brooke, Chair.
Thank you so much, and thank you all. Julie, it's really nice to see you again. Now we've become fast friends as you've been here advocating, and your story, I don't think anyone will forget. And thank you, obviously, to our partners that we do this work with. I do want to talk about 2 quick things. One is, when you shared that part of your story, Julie, around the power that Alice had on her peers, it really, I think, for all of us shows why we talk so much about peer support, because there's nothing more powerful than someone who can understand what you are going through. And so it's not a question, but it's more of an urging of folks to think about that and how powerful that is. I mean, I have chills hearing it, and these individuals who are doing this work, professionally also deserve, living wages and the support they need, because what they do is powerful and can't be replicated. So I want to thank you for putting such a fine point and just for your courage to stand here and be helping others with your story. And then I want to talk about workforce. It's come up a lot. And there's one thing that I wanted to point to. So obviously the governor has the 2.1 inflationary increase. I guess, Glenn, I'll bring this to you. Do you have thoughts on how you would want, I think you gave 7.8% as, okay. So do you have any thoughts on, I know we've talked in the past about splitting, carve-outs. Is there a sense of what you want that percentage to look like? Because this isn't technically a COLA that the
Correct.
governor has put in, right? The language is different, so I just want to be very clear on what it is you think you need to be successful, keep that 30% turnover from getting even higher.
And I appreciate that, Senator, and thank you for your support. What we're looking for with the 7.8 is simply what used to be a COLA, whatever we're calling it now, but What a COLA did in the past was it provided the flexibility. So when the governor puts out the 2.1%, there's flexibility there. So for agencies, yes, priority is workforce, but for agencies that have concerns and issues about the rising cost of healthcare or oil or gas or whatever they need to run their business, they can use that COLA for that as well. So we envision great flexibility within that 7.8 if we do get there. We envision it COLA-like in terms of the flexibility of it.
So thank you, if we're able to get, my bill, thank you for mentioning it, to actually tie these things to inflation, what will you do with all your free time when you don't have to fight for a COLA every year? 17 seconds to
that's
tell
not,
us.
look at those 12 pages. That's not an issue. You know, you've been chair for several years. You know it's never an issue.
All right, thank you so much. I appreciate that.
Sure.
Assemblywoman Simon.
Thank you. Thank you. You know, I have to apologize. I was watching you gesticulate, and it's because I was looking at the closed captions because the acoustics aren't great in this room. So I was wondering what you were doing this about. Anyway, I apologize. So I have a couple of questions for you. You know, one question I have for NAMI is, you know, some of the issues that we face when we are looking at AOTs and involuntary commitment, that, of course, there is people who from time to time need that, right? But a real concern about expanding some of these notions that as if that was really the problem, right? Sometimes the problem is that there's a determination to release somebody before they're quite ready, or there's no place for them to go to transition. And so they end up then getting off their meds, or they end up back in a very difficult set of circumstances. And so I was glad to see that you're advocating for, you know, holistic care. And in that, I would also include family, support for families, and helping families figure out how to help and how not to further engender some of the issues with interfamily that could just exacerbate things, for example, without knowing. What is your view on that?
So I strongly support, you know, these holistic or what we call natural support systems, right? And I think NAMI is kind of uniquely situated, not uniquely, but we're situated to address that, right? We provide programs such as Family to Family that actually addresses that need directly, right? We can train families to support one another, which I think really supports what we're calling enhancements of AOT versus
Could you say that
expansion.
again?
Sure. Which we call enhancements of AOT versus expansion, right? Which is looking at some very detailed parts of AOT that we talk about in our testimony. But I strongly believe that these are all parts of the overall puzzle, you know, and with family support in there, that NAMI New York State can really help provide through our own programming.
Yeah. I guess one of the issues that I see with the way there is, and this is why we have these hearings and a process, is what has been upheld for inpatient circumstances. It doesn't translate as well to the initial referral. Of course. But thank you. I've run out of time.
Thank you.
I
Any
forgot.
senators?
God, it was not
checking.
I only had 3 minutes.
Oh, yes, thank you. Senator Canzaneri Fitzpatrick, Ranker, 5 minutes. Oh, I'm sorry. I take that back. I forgot my own rules. Everyone only gets 3 minutes. We're on that stage.
Thank you, Madam Chair. Thank you all for the work that you're doing. As was stated, I'm the ranking member on mental health for the Senate, and I really very passionate about this. And thank you for sharing your story about your daughter. The most personal of situations that you've gone through, and I appreciate that you're sharing that because that does help other people out there that are suffering. I wanted to always encourage people to go into this field because of the workforce retention issues that we've talked about. And as we've mentioned, the 7.8% increase would be a lot better than where we are right now. But one of the other things that I have advocated for is student loan forgiveness, other programs to encourage people to go into this field with the idea that if you go in and serve in a community-based center, in an underserved area, whatever the criteria are, that we would then help people with the tuition and loan forgiveness, give that incentive for people to go into this field. So my question is, are there gaps that you're seeing that a loan forgiveness program would help, and specific job titles or other things that you could see where a program like that might offer some help
Sure.
to improve?
I'll start, I guess, and then, thank you. That's a very good question. And by the way, I loved your advocacy on the 7.8. Thank you when you initially spoke of it. I think where we're missing, obviously, we have an issue with clinical hiring, being able to hire clinical staff. We know that. But another issue we have is we have an issue with paraprofessionals and peers as well. And in the other fields, in OPWDD, in OASAS, they have stronger sort of mentoring programs, the beginning of mentoring programs. And I know that the Office of Mental Health is moving forward with their paraprofessional program and their licensure around it, but I think that that is an area where we're really lacking. Young people are coming out of high school. They might not want to get a college degree, but they want to get into the field. My son's a prime example of that. He went into the OASAS field because he was able to become a KSAC. They don't have those kinds of options. They're going to get those options, hopefully, at some point, but they don't have those options now around in mental health. So.
Okay. Well, certainly, I think it's important for you to tell us how we can help you legislatively to strengthen the workforce, because people are so important to the work that you're doing, and we do recognize that. So thank you all for being here. That's all I have, Madam Chair.
Thanks. Sorry about that.
Thank you, Chairman. So hi, everybody. I'm Joe Semplinsky. I'm a new Assembly member. I'm the ranking Republican on the Mental Health Committee, so I'm looking forward to working with all of you. So we'll try and do the quick 3-minute version here. It's Mr. Liebman. I would also want to raise my voice on the COLA situation. I brought that up to both the Commissioner of Mental Health and the Commissioner of OPWDD earlier today. Why don't we just start with inflation? If you're below inflation, you can call it all sorts of nice terminology, whatever you want to call it, but it's not really a COLA, it's really a cut. It's just how it's maybe a little bit less of a cut than we've had from other governors. So, and then to Julie, thank you so much for sharing your daughter's story. And I know she's happy watching you speak on her behalf today. So thank you for being here. And then to Ms. David, I wanted to dig a little bit in the 2 minutes I got. Did you say 10,000% increase for Warren County? And the reason I point out is the places, I do not represent Warren County, but I represent places that are very similar to Warren County as far as being rural. And where did that number sort of come from?
So in 2019, there was a cost shift. In 2020, there was a cost shift where, because of the way that the statute reads on this competency restoration process, it dates back to 1920, and the way that there's a piece, a part of the CPL 30, that's the reference, we call them 730 orders. There's a section in mental hygiene law that dates back to that old statute that says that the cost for these services would be borne by the county. But again, we're way past 1920, and up until 2020, OMH would cost share those costs with us, 50-50, right? And then in 2020, the cost shift happened, went to 100% back to the counties because they could just do that through a financial action and because it was already in the statute. And we're seeing more and more the courts using these orders. I think they believe deep down that this is supposed to put folks into treatment, but these are competency restoration services, which is really just to get folks to understand the charges against them, get them back to the court so that they can, proceed with the legal process. But we're finding that folks are being, they're languishing in some of these state forensic facilities for years. It's a high cost per day, $1,300 per day per person. So you can imagine order after order, person after person, and that starts to add up, and that's where you're seeing these increases happening.
Well, yeah, anytime a rural county's got a 10,000% increase in expense, it's going to prompt a follow-up question
Yeah.
from me. So thank you very much,
Sure.
and thank you to all of you for your time.
We have a spreadsheet that kind of
Send
looks
it
at the
over to
whole
me.
entire
I would love to
county.
see
This
that.
was just a
Thank you.
quick excerpt.
Thank you. Senators? Well, then I have a question. Hi. So there has been some national news about health insurance companies refusing mental health payments for people in search of care that they need, and at least under federal and previous state law, they have to provide mental health care parity. And the articles I were reading were more the national scandal, and I'm curious, are we seeing the same problem here in New York? Because there's probably nothing worse than knowing you are desperate for help, going in search of help, actually believing you were entitled to payment for that, and then learning you are not.
It is, thank you for that question. I've got to say that we've had Timothy's Law now in the book for almost 20 years. It was a comprehensive parity law. And unfortunately, we're still fighting those issues that you referenced. We're still fighting those same issues today. And there is nothing worse. And I think, you know, the commissioner this morning referenced $1 million for DFS and Department of Health and OMH to improve enforcement. We need more than $1 million to improve enforcement. We can't sit there and go case by case. We have to have a systemic response because too many people are falling through the cracks. It's wonderful that the governor is putting, you know, this program together around parity, around making sure that somebody is engaged with services within 7 days. I think that's great, but what's the fail-safe for that? What are we going to do to make sure that that happens? We have to have a really comprehensive response, and I think what's going on nationally, sadly, is the same thing in New York State, and there's nothing worse. There's absolutely nothing worse. Thank you.
Thank you, Glenn. I would like us to try to be better than the national problems.
Yes, well.
That is my hope, right?
I agree.
I don't know if anyone else wants to chime in. Okay. I think that's my actually one question.
Assemblyman
Assembly.
Santa Barbara? Natalia has.
Okay, there we go. Thank you all for being here, and thank you for your testimony. Just a couple of questions. Counties are often on the front lines of mental health services. I just wanted to ask about state aid formulas and funding structures, how they're meeting local needs, and what changes would you like to see in this state budget?
Yeah, so again, it's when we talk about the 730 issue, I mean, this is draining millions and millions of dollars every year out of the local system, right? So this is taxpayer dollars that are county tax levy that's going into the state general fund. So when you pull those dollars out, then it leaves less for, you know, mental health care. So, you know, yes, there are certain programs that I think are sustainable, given the local assistance that we get, or I should say state aid assistance. But things like I outlined in my testimony, you know, those SPOA coordinator positions, they're highly valued in the counties. They have them for adults and for children. Sometimes they have to be the same person, and sometimes that person has multiple roles within the county. Those programs have not seen an increase in probably 2 decades. So programs like that, again, I was happy to see the $16.5 million on the AOT enhancements because that will help. We also have county AOT coordinators that work on those referrals and those petitions as well. So those are two examples of where we would like to see more state assistance.
Yeah, no, that's good information. Thank you for your answer.
Sure.
Just a quick question for Mr. Liebman on the need for parity of mental health funding. I guess same question to you as well. What specific policy would you like to see as far as mental health services to be able to be funded at the same level as physical health services?
You know, I forgot to reference the other point around this, and you're so right. There are so many ghost providers out there, and the Attorney General's report last year, I thought was so damning about the lack of a response from, you know, the community, the managed care community on this. And I think, again, where I would go is enforcement. We know that there are these issues that come up from time to time around parity, and I think we have to have a really strong systemic response. And nothing sends a message out like in enforcement and looking at the enforcement and giving a heavy fine if necessary. That sends a message out to the entire community that you can't be doing this. And again, with the support of the governor's office, the attorney general, the legislature, I think we can get there. So I'm very hopeful for that.
Thank you for that. I think I'm just about out of time. Thank you, Mr. Chair. That'll be it.
Sorry. Senator Fernandez?
Thank you so much. Thank you all for being here. Really quick, Glenn, you did mention my bill. Thank you. And happy to see that, continuing investing in youth mental health. But could you just explain a little bit, remind me, because this bill I've had for a while and it hasn't moved, unfortunately, why this is necessary to train our teachers and school administrators about mental health awareness?
Sure, and again, thank you again for introducing the bill this year, and for Assemblyman Kells as well. I think we know we have a youth mental health crisis. The governor's articulated, we've all seen it. About a decade ago now, we had mandated, we were able to pass mandated instruction for mental health for young people in schools, that they were make sure they got trained. But what about teachers? Teachers, there are many teachers out there who are essentially seeing these issues in young people, and they don't know, is this a mental health issue? We don't want them to be clinicians. The last thing we want them to be is clinicians. They got enough on their plate. But we want them to look at the individual and say, clearly there has to be some concern. And maybe it's referring somebody to a school-based mental health clinic, or the ability to at least have an essential understanding. And your bill really just talks about that. I think it's a very common sense bill that essentially says, hey, teachers, you need to have a basic understanding of mental health. Not all of you do. And again, we don't want you to be clinicians, but at least have a basic understanding of mental health. So we hope, obviously, it passes this year. There's not really a fiscal attached to it, so we're very hopeful. So
Thank you so much. A reminder that knowledge is power.
Assemblyman Marr.
Thank you all for being here today. Thank you for the work that you're doing. I specifically wanted to ask a question of Ms. David. Being in your capacity and working with so many different mental hygiene directors, is there something aside from the labor and the workforce that is a consistent theme that you can talk about that comes up in some of the conversations you have?
Well, our directors are very uniquely situated, right, for what they do in the county. They have oversight of all 3 mental hygiene systems, so mental health, SUD, and IDD. So I think one of the consistent, because they have that lens, obviously co-occurring complex needs is a huge priority for them in making sure that while, the agencies are siloed at the state level, they intersect at the local level. So really trying to promote more service provision, more service expansion for folks that hit each individual service system, but, that are, so it's a complex needs co-occurring issues that they see mostly.
No problem, and this is for anyone at this point. We focused a lot on elementary, middle, and high school children and how important the services are, especially for some of the high schoolers, especially post-COVID. What are some of the challenges that you've seen when it comes to the programs that are being tried, and what can we do better?
So we have a program, you're talking specifically K through 12 or college? Or
I was actually looking at SEL and how that's being brought into the equation.
Okay. I would say that I'm not really an expert in that area, but I would say that we have to really kind of figure out how to make sure that young people have a basic understanding of mental health. And whatever the criteria, SEL or whatever criteria is necessary to make that happen, I think that was sort of when we pushed for the mandated instruction of young people in schools. I think we really wanted to make sure that they at least had a basic understanding of mental health.
That's an interesting point, and one comment I got from a youth was they never thought about mental health and they never had certain issues. But when it began being discussed so much, that became something that entered their mind. Do you see some of that conversation out there in the industry?
Well, I think the pandemic had a lot to do with that.
Yeah.
I think that you can't underrate what the pandemic meant to young people and the impact it had, the psychological impact, the mental health impact it had to young people. And the good thing about the pandemic was it sort of ended some of the stigma that was engaged with young people in mental health. But that said, you can't underestimate how important mental health education is.
Thank you all.
Assemblywoman Griffith?
Okay, thank you all for being here. Glenn, I wanted to ask you, well, I wanted to tell you, I appreciate the 10-point plan in regards to involuntary commitment, and especially the importance of implementing the incident review panel, which seems like that would really be helpful in this process. In regards to your recommendation about fully supporting the community service continuum for mental health care after a person is discharged, what is the funding? Like, we know that isn't funded in the budget. What level of funding would you suggest to make that happen?
That's a very good question. I think that, you know, in terms of the whole Kendra's Law issue, I think we put this 10-point plan together to respond to, you know, what we've seen in the news, and certainly from, you know, the governor's office and some of the legislators too, that we think that we should be going in a different direction. I ran the Kendra's Law program when I first started the Office of Mental Health. I see that we should be going the alternative direction, frankly. I think that. So one of the things we see is the community support piece. Because, you know, it was articulated this morning by Commissioner Sullivan that it sounds wonderful, and I think that she's doing a great job, and the governor's doing a really good job of making sure that we have strong discharge plans. But I'm very concerned that from a hospital perspective, from an enforcement perspective, are those discharge plans really going to happen? We had the whole question about mental health parity. How are we going to ensure that we're going to be able to sustain these plans? We have a workforce crisis. We have a community service crisis. I don't know the number. I wish I could give you a solid number, but clearly there needs to be this continuum, and we're very concerned that there isn't that continuum currently in place. And people just, as we know, it's rinse, cycle, repeat, sadly. It's just like somebody goes into the emergency room, they get, you know, maybe some sort of response, and then they're out the door in 72 hours. And what's going to happen? They're going to end up back in the system. The same with, you know, people coming out of jail. You're going to see this recidivism. If you don't have services right away, and I like the construct that the commissioner has developed, but if you don't have those services right away and immediately impactful, and they have to be, you know, something that resonates with the individual, people will fall through the cracks.
Right. Thank you very much. And Julie, I just want to share my deepest condolences to you and for the loss of your daughter. And I would not, we don't have time now, but I would love to learn what you think would be the most important thing, you know, for your daughter. What would have been the most important thing to help her? I would love to hear. Maybe afterwards we can talk.
Sure.
Okay, thank you.
Thank you, Assemblyman.
Assemblywoman Gallagher?
Hi, everyone. Thank you so much for your life-saving work. I know that for some lawmakers, and forgive me because I was in conference, I came back, so you might have already answered this, but just humor me. I know that for some lawmakers, expanding Kendra's Law eligibility to increase involuntary commitment has been presented as a panacea for improving safety or at least making people feel safer. But I'm wondering, and it sounds like maybe you're on my wavelength, is involuntary commitment actually the best way to improve public safety, or would ensuring that people have adequate housing, health care, and community-based mental health solutions present a more reliable data-backed way to ensure mental health is protected and communities are kept safe?
Yep, I would say that absolutely. I think you nailed it. I think we talk about this in the 10-point plan. Like I said, I was the first person who ran the program, so I know what the program is like. And tweaking, it's been tweaked for 25 years. And we have not seen the impact of that. We don't know what the impact of that is, frankly. What the real impact is what we talk about in this 10-point plan. It's community services, it's good discharges, it's workforce. It's the idea of having an incident review panel. I know we talked about that this morning. Those are 4 basic tenets of why we think that's incredibly important. And I'm sorry, I didn't want to, I know you were about to speak. I didn't want to.
I was just getting, obviously from the county perspective, you know, they oversee these programs. And, you know, while we wouldn't want to promote, you know, expanded use of AOT orders, it is a tool that I think the counties have felt necessary over the years to utilize. I mean, utilizing every tool in the toolbox, right? So while I agree with Glenn, you know, obviously we really want to seek diversion programs, but, you know, there are opportunities when folks really need, you know, a court level interaction to help facilitate some pathway into treatment, so.
And, you know, the last question that I have for you, particularly top of mind, is that the city was reporting this week that there are currently at least 127 people incarcerated in Rikers who are unfit to stand trial because they are so mentally ill that there's no space at state-run facilities. It seems to me like unless we deal with the root cause of mental illness, the way that this society is making people sick by failing to provide essential supports, we will continue to face this issue. So, yeah. I guess that's not a question, it was a statement. Perfect.
It's all about stigma. It's a lot about stigma. Yep.
Assembly still? We're done. Okay, are there any other senators who want to ask questions? And we're finished with the assembly side? Then we're thanking you all very much for your attendance today, appreciate it. Oh,
We have
excuse me,
a late entry here.
well, you have to ask.
Assemblyman Palisamo.
A late entry. Yep, hold on.
Thank you, and I apologize to my colleagues up there. My question is directed to Courtney. I talked earlier about a constituent of mine who lost their son to suicide, and we're trying to take action, and I know the mental health system failed them, their entire family, and he's a county legislator too, and I know he's been trying to make inroads at the county level as well, in addition to here at the state level. One question is, would you be willing to meet with him to talk to him offline about strategies and ideas on how to work within the county? But also, given the fact that the rural suicide rate in the state of New York is twice that of the urban suicide rate, what other suggestions? I mean, I know the governor vetoed that bill, unfortunately, and apparently the Office of Mental Health said that they were going to try to work and try to address those things. Do you have any suggestions that you would recommend moving forward for Mr. Toby, who's testifying later, and for him and his family and the work they're trying to do at the local level, but also at the state level? And would you be willing to meet with him at some point in time?
Absolutely, I'm happy to meet with him anytime. You know, obviously, a big, you know, we have a portion of the state that is highly rural, right? And we have directors that represent those areas. And I know suicide prevention is close and dear to our directors' hearts. And I know that there was a bill that was going through last year that was vetoed on the Rural Suicide Prevention Council. We supported that bill. We thought it was important. We have many of our directors in the rural counties also run direct clinic services, which I don't know that most people understand because there aren't a lot of services offered in some of the rural areas. So yeah, I mean, the resources are needed, obviously. A lot of them are very innovative with some of their suicide prevention programs. They support, you know, a lot of different national groups, or, you know, they work with national groups. They have other, you know, state-based groups that they work with. And so, yeah, I think we could certainly have a conversation and we can see where we can go from here.
Can I ask one more follow-up question? Are there any barriers or challenges that the state of New York is putting up for local mental hygiene directors at the county level to be able to be more effective in this outreach and providing the services and the coordination of care? Is there anything that you can cite that the state of New York is really kind of regulation or whatever posing an obstacle for you to address this issue and other mental health issues?
So, we work really closely with the 3 agencies, right? Office of Mental Health, OASIS, and OPWDD. Obviously, we have an element of Department of Health in there, right, on the Medicaid population. I think we just have to do a little bit more education and reminding folks of what our directors do.
Thank you, I appreciate it.
Thanks.
Thank you.
No more late showers up? Now we're going to ask you, thank you very much for participating today. Appreciate it very much. Thank you for your work.
Thank you.
And we're going to call up Panel C, which will be Joseph Tabaya, Kaylee Zaloga, Ronald Richter, and Paige Pierce.
Thank you. Get that out of your way.
Okay, everybody settled in? Oh, thank you. Why don't we start with you, Paige, and then we'll just, each of you introduce yourself so the tech people know what names to put up on the screen, and then we'll just go in that order. Thank you.
Hi, Paige Pierce, CEO at Families Together in New York State.
Thank you.
Hi. Kaylee Zaloga, President and CEO of the New York State Coalition for Children's Behavioral Health.
Ron Richter, CEO of JCCA.
Joe Tobia, advocate for the mental health and county legislator for Steuben County.
Great. Okay. 3 minutes each, and 3 minutes for questions, everyone. Okay. Paige, if you don't mind starting us off.
Thanks, Senator. As I said, I'm Paige Pierce. I'm the CEO at Families Together New York State. We are a statewide, family-run, family-governed organization, meaning that we have over 75% of our board of directors and more than 80% of our staff. We have 42 staff across the state who are people with lived experience, either their parents or their young people with lived experience with involvement in the behavioral health systems. I also am a parent myself. My 33-year-old son, Emmett, was diagnosed with autism 30 years ago. So I spent much of his elementary and middle school years being an advocate for him, and then his high school and college years empowering him to be his own advocate. The thing about Families Together is that we say nothing about us without us, because we have some expertise because of our lived experience that we want to share with lawmakers and policymakers so that you can better do your jobs, because we have that expertise. We're on the ground. We know what works and what doesn't work, and we're here to help. The other thing that we do is we have a workforce that Families Together trains and credentials family peer advocates and youth peer advocates across the state. It's a whole workforce where those people, those advocates, are able to bill Medicaid or get money from the counties to be able to provide family peer support and youth peer support, which is really critical because we know that, and I heard Senator Brook and I heard Assemblywoman Simon talking about the importance of peer support. And really what's so important about it is that because of our lived experience, we can say to other family members, we've been in your shoes. And that garners a level of trust and credibility that any number of letters after your name doesn't have, and no matter what kind of emblem you have in your car when you pull into their house. We have that trust, and we can engage families in a way that other people can't. And that ends up saving money and time and ultimately lives. So we really want to encourage peer support as a way to sort of prevent further involvement in deeper, expensive services. These family peer support programs across the state are struggling. They, as I said, some families can be, if they're Medicaid eligible, they can bill Medicaid. The rates are too low. It makes it so that they're unable to sustain their programs without additional support. And that additional support comes from counties in the form of aid to localities, which is woefully underfunded, hasn't been increased in decades. And these programs are bobbing to keep their heads above water. And as I said, it's a cost-saving, effective, efficient program, and it just needs the support. If you look at my testimony, you'll see the rest of our policies.
Hi, Kaylee Zaloga, President and CEO of the New York State Coalition for Children's Behavioral Health. Thank you for the opportunity to testify. We represent young people who need behavioral health services, the families who need help caring for these young people, and the service providers who support all of them. I think we all know that more and more kids than ever are struggling with more and more mental health difficulties than ever before. I hear from providers that they're seeing younger and younger children with more severe and more complex conditions than they ever have before. And in the context where we are hearing increasing concern about mentally ill adults struggling to take care of their needs, I have to drive home. Every mentally ill adult was a sick child who didn't get the help that they needed. We're also, I'm glad to see that youth mental health is a topic of conversation, especially in the context of the budget over the last couple of years. And yet there are no meaningful investments in services for kids proposed in this budget. And this in a context where we've got tax receipts, billions of dollars over projections, a proposal to send $1 billion per year into a rainy day fund that it will never be raining hard enough to use, and $1.5 billion proposed increase to Medicaid from the Medicaid Managed Care Organization tax, none of which is proposed to be invested in behavioral health, let alone children's behavioral health. We continue to starve our system of the resources it would take to eliminate wait lists, to retain skilled and committed staff, and to stop the cycle of young people with unmet needs into adults with more complex and expensive unmet needs. And look, when a child is suspected of having pneumonia, we don't say, we're gonna put you on a wait list. Maybe you'll get a doctor's appointment in 6 months and we'll go from there. We don't suggest that what they really need is a new peer support club at school, and I don't mean peer support in the terms of the service, I mean the student training is important, and it's also not a solution. And I sure hope we aren't saying that we need to wait until you can't breathe because your pneumonia has gotten so severe that you need to be treated in the emergency room. But that is what we're doing to children and families if their primary diagnosis is mental health and not, considered physical health. And at the same time, we have providers who are closing their programs and reducing their service capacities because they can't afford six-figure losses for another year in the home and community-based programs that enable kids to stay in their homes, to communicate better with their families, to connect with their peers and their teachers, and to engage in life how we all think that kids should be. We need to raise reimbursement rates specifically for children's programs. You'll see in our testimony, we have a proposal with the Healthy Minds, Healthy Kids Coalition to invest $195 million into the specific outpatient services that currently 3 out of 4 kids who would qualify are unable to access. And we need to raise the cost of living up to 7.8. Thank you.
Good afternoon. My name is Ron Richter, and I'm the CEO of JCCA. I have previously served as New York City's ACS Commissioner and as a judge of the Family Court. JCCA is a child and family services agency that works with over 17,000 children and families each year. Our services sit at the intersection of child welfare and behavioral health. Governor Hochul's proposed budget provides safe spaces for youth, mental health first aid, and after-school support, which, of course, we applaud. But it does not address the needs of youth with intensive mental health needs. There are treatments for these young people that we know work, kids who have high acuity needs, but this population remains untouched by the executive's proposal. An important point for my board of directors is that due to Medicaid eligibility rules, JCCA is losing almost $1 million each year on young people 21 and older on our residential campus. And I'm afraid to say that while we may not call it a waiting list, at least a dozen of these young people are waiting for OPWDD placements. In some cases, they are over 21. So for those kids, because of our licensure, we as a provider are not reimbursed for the expenses of providing physical and mental health services to young people over 21. The reason we have them is because OPWDD, which doesn't have a wait list, has them waiting for placements for which they have been certified. This is an issue of when they get to OPWDD, they'll get Medicaid. But in this window, we're not approved to take care of 22 and 23-year-olds, but we're not going to render them homeless, so we continue doing it at our own cost. With the rise in mental illness among children, we are seeing increased rates of psychosis and severe depression among young people. Many youth in our residential campus, which is licensed by OCFS, qualify for OMH residential treatment facilities, a higher level of care. But despite OMH's recent RFP for RFT beds, capacity has not increased, and youth with severe mental illness remain in inappropriate settings, in some jurisdictions, in hotels. We offer an array of mental and behavioral health supports, and like my colleagues, are lamenting the possibility of a 2.1% COLA, or whatever we're calling it. Thank you.
Joe Tobia, good afternoon. I failed to mention earlier that I am a suicide survivor. First of all, I would like to thank Commissioner Sullivan and all those who serve on the mental health committees for the great job you each do. As a member of the Governor's Task Force on Suicide Prevention, we also have been assigned with strengthening our current suicide prevention services and policies, which we are accomplishing with each and every meeting. However, when looking at methods to better these policies and services toward suicide prevention, we must exhaust every method and explore every avenue to better those policies. New York State Bill 3610, the creation of a Rural Suicide Prevention Council, is a low-cost bill that would investigate suicides by gathering data in regards to individuals who died by suicide. This bill would explore the paths these individuals took in their last year or so of life and investigate such things as risk factors, trends, barriers to their well-being, lapses in systemic responses. We must look at where along these paths these individuals lost hope, where our interventions were not effective, and why these interventions weren't effective. I am convinced that by examining our failures and making the needed corrections will only reduce the number of lives we lose by suicide each year. Only one other state that I know of in the U.S. actually examines individual suicide deaths, and that is Maryland Suicide Fatality Review Committee, signed by Governor Hogan in April of 2022. I recently had the opportunity to meet with Senator Helming, sponsors the bill, 3610, and we discussed changes. We discussed revisions to the bill to make it stronger and make it a better bill in aiding suicide prevention. Though this bill finally passed in the Assembly and the Senate last year, it was vetoed by our honorable governor. With your continued support and with some important changes in the bill, I truly believe that Governor Hochul will sign this bill. It's a different approach to gathering data, but I'm convinced the findings will save lives. In August 2021, I lost my boy to suicide. The last year of his life, my wife fought hard to get him the help he needed, only to be denied or told that he did not qualify. My son was a strong, compassionate young man, an excellent athlete. He was a tough kid, yet he would call me at all hours of the night crying, "Why won't anybody help me, Dad?" I never had an answer, and I'm just hoping we can find those answers. Thank you.
Thank you. Sorry, the bell went off just at the inappropriate time. Senator Tom O'Mara.
Thank you all for your testimony here today, your advocacy on these very important issues, and your work on these causes. Mr. Tobia, you got cut off there at the end, so if there was more you wanted to add, give you the opportunity to finish what your full thought was there.
finish what I had?
Yeah.
That's just a short paragraph. I was just gonna say, that question he asked me so many times, why won't anyone help me, Dad? And I never had an answer, but, I feel now it's time to find those answers. So I ask each and every one of you to please support our efforts and do whatever it takes to help create a rural suicide prevention council. There's so many individuals in New York State who are suffering like my son did. So please, let's not fail them. And I do want to thank you for giving me this time to speak on something I feel is very important and very dear to my heart. Thank you.
Well, it's clearly very dear to your heart, and it's a very important issue for all of us. And we struggle with dealing with mental health in this state year in and year out. I have been pleased to see the attention that the governor has given this in the last 3 budgets. Really, it's needed. Hasn't gone far enough. We need to go farther. The legislation that you have with Senator Helming, and I'm a co-sponsor of that, we'll continue to work to get through. But with so many of these bills, as I think I've explained to you in the past, Joe, that they get vetoed because they should be done in the budget. And then we get here in this process, and they don't get in the budget. So we're going to continue to push, try to get this type of thing in the budget this year. There's a bunch of bills similar on suicide prevention for, yours is rural, but there's other groups, identities for that, so there's a bunch of them. So how does, if you know, your approach on this bill on the rural suicide differ from maybe some of the other ones that are these types of commissions, and why do we need one particular to rural as opposed to urban or black or LBGT? What's the purpose of having it differentiated like that?
Well, I think, first of all, when we look at a rural council, to look at suicide fatalities, we know that rurals are twice as high as urbans. We know that. That's a common fact. Rural suicide's twice as high as at urban. And we know we're going to be looking at, they say what, mental health diagnosis attached to usually 50% of suicides throughout the state. So when you look at the rural, I think you're going to look at a large number of the suicides. And I really think, I know some of the things we're going to find. We're going to find, the telehealth is just not available to some of these people. But I think, you can cover so much looking at those people.
Thank you.
Thank you. Assembly?
Assemblywoman Simon?
Yes, thank you for your testimony, all of you. Mr. Tobia, sorry for your loss and your experience, and I think that your proposal for rural suicide task force makes a lot of sense. I think one of the things that we all struggle with are suggestions that are made for how we can fix things when we haven't really looked at what were the barriers that caused a certain set of circumstances to occur. The lack of treatment, why there are denials, where are the holes in the system. And also, where are those transition points, and those points is where there's like a cliff, right, which is the age 21, and you fall off a cliff. And how can we help families better understand and be part of that recovery, right, and addressing those needs? And so I'm very curious about the fact that we haven't really done anything to support families in a demonstrable way who are very much a part of the picture that could be part of the healthy plan. So I'm curious to hear from you. I have a minute and a half. Go for it. Either anybody, actually, but certainly you, Mr. Tobia.
Well, first of all, I'm embarrassed to say I have some severe hearing problems.
Sorry.
I've got 2 hearing aids in. I'm hearing a lot of echoes.
We have...
From everybody, so I'm sorry.
That's okay. We have lousy acoustics in this room, but we also have assistive listening devices.
You got a T-coil?
We have the...
You got a T-coil?
Yeah.
That would be great. I
don't
use it
know
in
who would
church,
get it,
so,
though, at this juncture. We have an infrared system that works with that.
I was going to do something with it. I didn't
Yeah.
want anybody to think I was on my phone.
No, that's
texting,
fine, actually, if you look at the captioning, but it's a little delayed. So Why don't you look at can you pull up the captioning on your phone and see what the conversation was? Okay, I'm not sure how to, so I'll try and talk louder. How's that? You're not going to get it?
Take oil didn't work.
Okay, I'm sorry. So I was asking about families and the support, the lack of support that we're giving. We're not really funding support for families who can often, not only to help them, but they can also help be part of the recovery of their loved one or the path of their loved one to get the right treatment, because they would be able to address those issues better. Does that make sense to you? So maybe you want to address that, maybe Ron, you want to address it, maybe you could hear them better.
Thanks,
I know
Assemblywoman.
that Paige is really, this is
That's
her
my
thing.
Okay.
thing. So as I said in my testimony, the family peer support is crucial, and we have hundreds, if not thousands, of family members across the state that we poll, that we survey, that we talk to, and ask them, what are the things you need? What are the things you would have liked to have had? What are the things your child needed? And often it's support. It's support for the family and support for the youth. And that's why, we really urge you to look at where we're investing. But yeah, support. You're absolutely correct.
Okay, thank you. Thank you. Sorry I ran out of time.
Thank you. Senator Canizeri Fitzpatrick.
Thank you, Madam Chair. Mr. Tobia, thank you for sharing your story, and I'm so sorry for your loss. And thank you for turning your family's tragedy into advocacy, because we appreciate your input very much. Mr. Richter, I was very touched by what you said, that even though these children turn 21, you're not putting them out on the street. I'm sure that's a tremendous burden for your facilities and your agency, but as a mom of 4, I know that just because they hit 21 doesn't mean they're really self-sufficient adults, as much as my kids will kill me for saying that. Ms. Zaloga, I wanted to ask you a question, because your testimony about 1 out of 4 children on Medicaid are not getting the behavioral health services that they need.
1 out of 4 is getting.
1 out of 4 is getting. And as I just said, being a mom of 4, I can't imagine telling one of my kids that you get mental health services and the other 3, sorry, you got to suffer. So my question to you, though, is what is the biggest barrier? Is it that there aren't enough providers? Is it that the families don't know that these services are available? And how does it compare to the non-Medicaid population? What are you seeing, if you know that answer?
Sure. The biggest barrier is the lack of service providers, and that is from decades of underfunding in the system. We have not been able to pay the staff who are doing really difficult and really meaningful work enough for them to stay in our workforce. And then there's a different challenge with the non-Medicaid population, is that most services we're talking about are not covered by commercial insurance. Peer support, not covered. Most of the in-home services that we're talking about that really enable families to better integrate the care of their children and to improve the whole family system, not covered by commercial insurance. So there's a whole side of what needs to be done on the commercial side. On the Medicaid side, it's really been about funding. And then for those services that are covered by commercial insurance, they've never been paid at a rate that most providers can actually cover their costs with. So last year's legislation, thanks to a lot of you, we do see a rate floor for covered licensed outpatient services for commercial insurers. The problem is that they're not required to cover the majority of the services we're talking about.
So during one of the other panels, I talked about loan forgiveness programs and incentives to encourage young people to go into this field. And I'm just curious if you think that would help in your, fund our, provide workforce to provide these needed services and train professionals,
Yes,
create
loan
professionals.
forgiveness programs are definitely helpful. We've appreciated the OMH Community Mental Health Loan Repayment Program, especially the expansion to more practitioners beyond psychiatrists. We also need scholarships for those who can't afford to outlay that cash in the first place.
Thank you all.
Assembly.
Assemblyman Sepulwinski.
Thank you. Thank you to all of you for being here. Direct my questions to Mr. Tobia. Mr. Tobia comes from Steuben County, and all 4 representatives who represent Steuben County are in the room, Mr. Palmisano, Ms. Bailey. Mr. Tobia is one of Mr. Palmisano's constituents. Senator O'Mara is one of Senator O'Mara's constituents, and I represent a portion of Steuben County, and actually am from the area where, we're both from the Corning area originally. So as a rural area, I really appreciate the work you've done and how you've honored your son by doing it. I want to point out sort of one of the beauties of the mental hygiene space. The bill you're referring to passed unanimously. Mr. Tobia is an elected official. He's a Democrat. I'm a Republican. Doesn't really matter on these issues. And a lot of things that we cover today across all of the mental hygiene areas. And I want to reemphasize Senator O'Mara's excellent point that when the governor vetoes these type of things, she says we should do it through the budget. So this is the time to work on it, and I'm glad that you're here for that. The question I want to ask you is, given the tragic story that your family went through and the loss of your son, what's the one thing that you would have changed through that process that you think would have improved his access to care? And again, thank you for being here.
Well, we knew my son needed long-term care. We knew he needed a bed. We couldn't find one. We couldn't get him into Elmira Psychiatric Center. They refused. My son he was bipolar, he was depressed. Schizophrenia came when he was about 26. And my son was very normal. He was, he was a normal kid in high school, popular kid in high school. I know that. I was his principal. It's just when he hit his mid-20s, we started seeing changes. We just started seeing the paranoia. We started seeing the delusions. And then when the voices came, and they were 24/7, and he told us all the time. So we knew he needed long-term care. We couldn't get him in. We were told, no, he doesn't qualify for this. He doesn't qualify for that. And I always remember after my son passed away, it was, my wife and I used to say, boy, they could have learned so much if people just took a little interest in what Matt went through. And it was 2 years later when I came across the Maryland bill that I saw, wow, this is what we need. So I Googled and I found the Rural Suicide Prevention Council, which was very similar. And that's when I started my letter writing, voicemails. I became that pest that I'm sure a lot of you got my letter. So.
Thank you for your advocacy. I definitely support
Thank
that
you.
legislation, and thank you for honoring your son's memory.
Thank you.
Senators, that I just want to follow through. First off, thank you all for your work, and very, very sorry for your experience with your own son.
Thank you.
And of course, we know that many of these very serious mental illnesses don't show until someone gets into their early 20s.
right.
So your
That's right.
story is very familiar to me from other people's lives. Ron, so you're not licensed if they're over 21. Can we just get your license expanded?
So we have an Article 29I license on our campus, which was the license that was designed to allow foster care agencies or residential agencies through OCFS to actually bill for Medicaid services. That license only allows us to cover kids up until they're 21. Even though, as you know, our population on the campus is dual diagnosed serious emotional disturbance, intellectual developmental disabilities. So they're not even chronologically close to 21 or
Right.
2, but it's because of the 29I licensure. And we've brought this to the attention of the state, and there's varying levels of interest in trying to solve this, but it is not just my agency. This is a statewide
No, because I've
problem.
heard that as a statewide issue also, even just for people who are providing, assistance to people who've aged out of foster care,
Yes.
runaway youth, et cetera, et cetera, et cetera.
Yes.
This concept of you hit 21, you're on your own seems really poorly thought through. But can we just legally change your license or change the definitions of eligibility so that you can draw down Medicaid?
So I believe that, and by the way, if we took our kids out into the community to get behavioral health services, we would be able to bill Medicaid differently. But we're obviously a therapeutic environment where we
Right.
do this. I don't want to answer yes without saying that some of it is a function of the permissions from CMS in DC. And so I believe the 29I licensure had to be approved by the feds in order for us to draw the federal Medicaid money. Certainly if the state of New York wanted to cover it, then the state could do that. But as you probably all know better than I, our state is very determined to capture federal Medicaid revenue, and so sticks very much to the rules in that regard.
And it's going to get harder and harder to stick to those rules since it's a moving target every minute of every day. But again, just to follow up with my few seconds, you can't get an additional license status that does meet CMS so that you can serve some over 21-year-olds in your wonderful programs?
That's an excellent question.
Okay, well, please let us know if there's some way we can be helpful, because that seems to me, I'm sorry, I'm over time, like that we ought to be doing that.
Yeah.
Thank you.
Thank you.
Santa Barbara?
Thank you, Mr. Chair. Just wanted to follow up, Kaylee, back to your testimony about children's mental health services being underfunded. What are some of the budget priorities, I guess, you would like to see in this budget? And can you talk specifically about the school, expanding the school-based services?
Sure. So our top priorities are, along with the rest of the behavioral health advocate world, raising the COLA, targeted inflationary increase, whatever you want to call it, to at least 7.8% so that we're actually combating the inflation of the past few years, like you discussed, Mr. Sempolinski. We also need to invest at least $195 million to begin with in children's clinic, children's home and community-based services or waiver services, child and family treatment and support services, and substance use outpatient services as well. There's a proposal put together about that. Treating children is a lot different from treating adults. They're not just smaller adults. They're a lot more complex. They have whole family systems that we're working within. So rates need to go up in those instances. When it comes to school-based mental health clinics, we're glad to see that there's so much interest in them. They're really beneficial in the schools that they're viable in. They're not viable in every school. Not every school has the population to support keeping a clinician there at all times. The rates are, not high enough to support having that clinician there all the time as well. And even with the addition of coverage requirements to commercial insurance, it's still, most providers are not getting any payment from commercial insurance for those services. But in order to make them more viable, there could be more startup funding, which is one of the things that we included in our proposal. Some providers have been successful in having schools partner with them and contribute to some of the costs because they know how important it is that those services be accessible to all students, regardless of their insurance status and other things like that.
Can I just give a quick example?
Yes, please.
So in New York, through OMH licensure, you can, if you're designated, provide respite services, which for a family that has a developmentally disabled child or an emotionally challenging child is critical. Most of the providers across the state are de-designating because we cannot afford to provide respite. So we provide it at a loss. I have a colleague who runs a big agency in Rochester. They're de-designating simply because the rate structure makes it impossible but yet respite prevents, it's relief. And so it's a problem.
Yeah. And going back to your discussion earlier, at age 21 is when the school system stops paying, right? Is that what you were referring to?
Yes.
But normally the state will pick up after that if they're in a program. But that doesn't happen with your situation.
With our kids, the county continues providing us with a maximum state administrative rate, which is the foster care dollars.
I see. Okay. Thank you. Thank you for your answers.
No. Assemblyman Mayer?
Thank you very much. So I wanted to kind of hit on what you were talking about, Ron, and I think you answered the question that I was going to ask with you're going to look into it, but I was just trying to confirm that there is actually a legislative solution that can be provided to that issue that you brought up.
I believe so.
Okay.
We've actually yesterday spoke to, I want to say it was Senate Council or the Governor's, it was Governor's Council. And she seemed as though she was very interested in solving the problem because it's a legally interesting problem
Right.
to solve. So they've heard it. But I do believe that legislation could certainly resolve it simply as the chair is saying, figuring out how the license can be modified or perhaps trying to get licensed as an Article 31 on our campus, which is odd. But it's a legal conundrum.
Well, I'm glad you're advocating for it, bringing it up. It looks like it's getting the attention it deserves, and I'm hoping that we can also do that with all of the issues that you guys have brought up. You're doing tremendous work. Some of the statistics that you've shown, and honestly, it's been an education for me to listen. So we look forward to partnering with you. I do want to talk about with Ms. Saloga. Is that right? You talked about a lack of providers, and you talked about the workforce issues and seeing providers shut down. You had some data about 1 in 4 don't get the services they need. Do you have any data on how many providers have actually shut down over the last 5, 10 years?
I don't have that offhand, and sometimes it's not so much that a whole agency shuts down, as that they stop providing a certain service or they stop providing it in certain areas of the state. So I know the provider Ron mentioned yesterday, I think there will be thousands of kids that they can no longer serve. They have to pull a program out of several counties of the state. It's something that we've monitored, I think, kind of the reduction in the number of services available in each county. I can send you some information on that.
I'd love to work with you to quantify, even statewide, but obviously in my district, where those services have decreased, because educating myself and more folks on that could really help move the needle in terms of providing solutions.
I'll follow up with you.
Thank you. Thank you all.
I would ask the state for data on the number of children that were receiving services through Bridges to Health, which I can explain, and how many children are receiving services today. Post the end of B2H, Bridges to Health, and the waiver that allowed us to provide OMH licensed services, that's been transitioned to Medicaid managed care, and I have been asking for that data. We should be able to get that.
Send me an email. Let's
I will.
request it together, and let's work on it, okay?
Yes.
Thank you.
Assemblyman Palasamo.
Thank you. Joe, thank you for being here, sharing your story.
Thanks for having me.
It's, you bring in your story, your face, your name, Matt's story to share with us is very powerful and impactful. And I'm hopeful my colleagues here heard your story and it motivates us to act, motivates the governor to act, motivates the OMH commissioner to act. We talked about it, and when the legislation passed, you were a bulldog pushing that, emails and calls, past the last day of session last year, at 5:30 in the morning. I remember texting you a picture of the board.
Yeah.
And but since then, and I've said to Governor Vito that you've been talking about this, you have thoughts on how to improve the bill, to make it better, make it more efficient. Do you mind just talking a little bit about some of the other things you would add on this? Because this bill was actually introduced by our former mental health chairwoman, Aileen Gunther, so it's great that it passed. But do you have any suggestions on what you might recommend, whether it's done through the budget, whether it's done through a bill, whether it's done through OMH? What kind of suggestions you would make to make some positive changes?
Well, I'm still looking at it as a council to go through a bill. So that's the way I'm pursuing it, just like I did last year. So I met with Senator Helming last week, and there were 7 changes I felt were needed in the bill. And I've seen a lot of similar legislation throughout the country. Maryland's is excellent, I thought. One of the changes I think that's needed in the bill, you have to have an immunity clause. You know, you're going to collect data. People are going to submit data, you know, on some real touchy things coming from social services, medical records. You know, there's got to be an immunity clause where it says anyone receiving or submitting data is immune to liability, or you're not going to get accurate data. I know after, you know, Matt passed away, counselors, no one would talk to us. No one wanted to talk to us. I think they were a little afraid we were going to sue them or something. We weren't going to. We just wanted to know, you know, what was going on. So an immunity clause, I also thought that the term of the current bill, which is 2 years, it's got to be 3 years. Right now, it's 2 years. You can't, you have to meet no less than 3 times. My recommendation, make it 3 years. And you've got to meet at least 4 times a year. It's a lot of data to collect, a lot of data to look at. Another one, I hope it doesn't sound selfish, to give the bill a name. I think it packs more meaning. Of course, the name I thought of was Matt's bill. I just think when you attach a name like that, people start asking questions. Sure. You know, who's Matt? What? It's better than saying, well, yeah, Bill 3610, you know? So that was my third recommendation. I had a couple more, too.
Great. Thank you, Joe.
Thank you all for being here very much. My question is actually going to go to Mr. Tobia, and your story is very touching. And a year and a half ago, my best friend lost her 16-year-old to suicide.
I'm sorry.
As Assemblymember Semboletsky mentioned, I cover part of Steuben County as well, all of Livingston County, part of Wyoming, Rush and Monroe, and part of Ontario, so very rural. So your insight in what you, the energies that you have put into this to remember Matt is very important to me, both from the rural perspective, but also disappointing that the governor did veto the bill. Yeah. But I do like your outlook that you have, that now you look at the veto as the governor as a good thing to make these changes. So in the next 2 minutes, you can either continue answering what Mr. Palmisano asked or what Senator O'Mara had as far as the rural area and why this is so desperately needed for our area.
Well, it's a different way to gather data when it comes to suicides. What you can do is you follow the path of the individual who died by suicide. You know, find out where did they lose hope? I mean, what are some of the trends? What services did they have? What services didn't they have? What services should they have had? And why didn't they have these services? And it's not just mental health, even though mental health diagnosis is usually attached to 50% of the suicides. You're going to find other services, you know, someone without a mental health diagnosis, you're still looking for certain trends and risk factors, lapses in systemic responses. So it's a different way to gather data. It's just looking intently at that path that individual took. And I think we can just learn a lot of little things there and how to better serve them. OMH does a great job. They do a great job. We've got great policies out there on suicide prevention, but some of them aren't reaching these people. Why? What's preventing? We want to know why. So we can look at some of that. To go back to Assemblyman Palmisano's question, another improvement I thought was, what was it? Oh, you got to put a price tag on it. You have to put the cost of the bill, because Governor Hochul didn't see a cost. So she grabbed all these bills, you know, that didn't have a cost on them and kind of vetoed them all. So it's very, very low cost. I mean, there's not a lot to it. So you put the cost on it, and I think that'll help.
Thank you very much for being here.
Any other?
Assemblywoman Griffith.
Okay, thank you. Thank you all for being here today. Mr. Tobia, my deepest condolences to you, on Matt's loss, and I really appreciate your meaningful advocacy here.
Thank you.
Because what you're doing can make such a difference in the lives of other young people. So thank you. In my hometown of Rockville Center, over the past 10 years, there's been a real uptick of suicides in teens and also young adults in their 20s. And so it's a very raw issue where I live. And in response to that, and some of it was along the way, some of our high schools were able to build mental health centers in their school. And that's really helpful, accessible for kids. I was able to allocate funding for one high school to establish one in their high school. But then in addition to that, there's Northwell Hospital opened up a mental health center in Rockville Center, but all the local school districts can put money in every year, and if they, whatever that cost is, then their students can go to Northwell Health it's local in Rockville Center, but it's the neighboring school districts. So that's a good plan. So some of those things, they're making some strides, but one of the problems I've seen, because I know some of the kids, I call them kids, if they're in their 20s, that have committed suicide, even my cousin committed suicide and he was 30, you age out, like those mental health centers in schools till 18. The Northwell is 18. So I just wondered, I know there's such an issue with, we have to increase and upgrade for children, for families, for teens, and young adults, but I wondered, do you see a big disparity in this young adult age where there's almost like a real less than anything for them? Even though it's still bad for children, it seems even worse for this age group of 18 and over. Anyone can answer.
Yeah, I mean, we call it transition age youth. Those are mainly 18 to 26. I can't say whether. I think the gap is bigger, smaller, but it's certainly there. Like you said, they're aging out of a lot of the supports that are available to school children and other certain systems, and it's difficult to get eligibility for the other systems. So I've been glad to see a little bit more attention and work on trying to better serve that population. I know our Youth Act teams are one of the services that can serve older adolescents. There are some specifically for transition age youth, and seeing more investments in that.
Okay, anyone else want another comment for 15 seconds?
OMH is really working hard on that, on the transition age youth thing, and they're reaching out not just to high schools, but also to colleges, because those are the age where they're sort of changing, their life is changing, you know.
Okay, thank you.
Okay, I believe that is all the questions from all the members up here. I want to thank you all very much for your participation today and for your work on behalf of so many people who don't necessarily have the opportunity to voice their own problems to us. So appreciate it very much. I'm now going to ask you to leave so that I can call up the next panel. We have Donald Nesbitt, Jim Karp, Eric Geiser, and Kevin Ryan, who's a replacement for the Self-Advocacy of New York State coordinator. And then when you get up here, we'll have you each introduce yourself so that the media department up at the top knows who's who. Oh. There aren't better or worse chairs, not to worry. Okay, so starting to my left, your right, why don't you just introduce yourself and go down the line?
Jim Karp with the Coalition for Self-Direction.
Press the push until it turns green, you got it.
Donald Nesbitt, Executive Vice President, Local 372.
Thank you.
Hi, Eric Geiser, CEO with the ARC New York.
Thank you.
Oops.
Thank you. So why don't we just go down the line as you presented? So why don't you go first? You're gonna have to speak up a little bit. Okay.
I'm sorry, I was seeking to go last, but that's fine. My name's Jim Karp. I'm the father of a young adult who's served by OPWDD. You have my written testimony, which is rather wide-ranging. What I'm going to do today is focus on one person. Daryl lives in a group home, and he's been going to Dayhab for years, for decades. He's woken up 6 a.m. every morning, showered, dressed, fed, rolled onto the transport van for 6 hours of Dayhab. Until this last summer, his sister arranged for him to get a taste of retirement. So for 8 weeks in his 70s, Daryl got to choose what to do. Some days he would go with his staff member to a local senior center. Some days he would just stay in the group home with his staff member. And some days he would choose to go to that same day hab. That 8 weeks ended, and with his sister, he arranged to get a self-direction budget. And here's the problem. New York State assigned to him a self-direction budget which is half the amount that they're paying for his day hab. Now, if they gave him 88%, we would still save thousands of dollars a year, and Daryl would finally get to retire. I mean, I'm asking you, just imagine for a moment what it's like in Daryl's shoes, in Daryl's wheelchair. He gets this taste of retirement, and now he's learned, unless something changes, he's not going to be able to do it. We can give Daryl's story a happy ending. What does he need? He needs a budget that's roughly equitable with what he's getting in the certified system, and he needs a place to appeal, a forum to go to, if that budget is not adequate. And of course, we're not just talking about Daryl. There are 10,000 seniors, people 60 and over, who are sitting in group homes. 7,000 of them are going to day habs every weekday. And then there's tens of thousands of others who are not yet seniors, who want that freedom, who want that equity, so that they can choose whether to be in the certified system or be in the self-direction system. Thank you for your time today.
Thank you. There you go.
Good afternoon, chairs, and distinguished, esteemed members of the presiding committees. I am Donald Nesbitt, Executive Vice President for Local 372. Thank you for the opportunity to represent Local 372 here and our Substance Abuse Prevention and Intervention Specialists, our SAPs in New York City schools. Since 1971, SAPs have provided a range of mental health services, mental health and intervention services in the largest school district in our nation, teaching social and emotional strategies and behavioral support to ensure that our children are ready to learn. SAPs use evidence-based programs that are approved by OASIS. SAPs provide students and their families with tools to navigate the personal peer pressures that may derail from healthy academic development. SAPs are also responsible with individual work plans each year that are specifically tailored for our children in our schools. It is with willing partners like you that we can ensure that our children's concerns will not go unheard. We appreciate the $2 million of funding that you give to the SAPs program every year, but it is imperative that the state of New York continue to protect our vital program, such as the SAPs, for the mental health and wellness of our children. Middle school and high school students who responded to City Schools' annual survey last year said that their classmates are bullied, harassed, and work to intimidate each other, which is up 44% from 2019. New social challenges and family financial losses, cyberbullying, exposure to pressures from social media, the uses of cannabis continues to prove to be a higher need for SAPs in our schools. Evidence also suggests that programs implemented at early stages of a child's life may be effective in the preventative efforts in providing behavior adjustments, especially in high-risk populations. But there are 236 SAPs in our schools supporting 912,000 public school children. And individual SAPs can effectively help 500 students in need. But this is not enough. Our SAPs are moved from different campuses based on evaluation of who needs it more. That should not be our system to determine whether, to pick and choose whether one child should have services and one goes without. This is why Local 372 requests that instead of $2 million this year, that the reach is farther in that we request $6 million into the SAPPERS program, as that would equate to 48 full-time SAPPERS and can reach 24,000 more students. I thank you again for my time.
Good late afternoon. My name's Eric Geiser. I'm CEO of the ARC New York. We are the largest provider of supports and services for people with intellectual and developmental disabilities in New York State. This morning, you heard Acting Commissioner Baer speak about the significant investments that the governor and OPWDD has made into our system through the rate rebasing process. This increase and recent investments signals a meaningful shift away from the neglect New Yorkers with disabilities have experienced for decades. We are grateful to the governor and the acting commissioner for leading that charge. But it's dangerously easy to hear about that investment and think that the needs of New Yorkers with disabilities have been met. That is far from the case. Rate rebasing is a federally mandated process to better align the rates providers receive for providing services with the costs of providing those services. The increases we received through the rate rebasing process were significant, but they were significant because after years without investment, our rates were completely unaligned with costs. The state's investment in our service system over the past 2 decades still lags inflation by 20%. The big investment numbers you've heard today, while great, don't even compensate for that inflation. The investments will go primarily to wages, but they will not be enough to bring compensation in line with the skill and responsibility required of our staff. And they only begin to address the inequity between the wages of the nonprofit providers and the state-operated programs. And they do not support our full system of care. Rate rebasing only applies to some of our programs: critical services, community hab, respite, supported employment. They receive no increases through the rebasing. So people who rely on those services are still struggling to access support. Parents miss work because services are not available. They can't get respite to help them live a life beyond caregiving. Longtime staff are leaving people they've supported for years because they can go to a state-operated home down the road and make 30% more for the exact same work. These aren't hypotheticals. These are real experiences of real New Yorkers who need your help. Our commitment to meeting their needs drives everything we do at my organization, but our ability to meet those needs is limited by your commitment. So we're calling on you to include a 7.8 inflationary increase in the budget to support the comprehensive needs of people with disabilities. We're calling on you to convene a wage commission to examine the roles and responsibilities of human service workers and establish fair, sustainable compensation standards. And we're calling on you to move the responsibility for rate setting back to OPWDD to ensure future rate setting is timely and appropriate. In short, we're calling on you to help in finally ending the neglect for people with disabilities. Thank you.
Hi, I am Kevin Ryan. Sorry about that. Hi, I am Kevin Ryan. I'm a board member on behalf of SANES. Thank you for allowing me to testify. It is important that you hear from people like me. SANES is an organization founded by people with developmental disabilities for people with developmental disabilities. We have been speaking up for ourselves and others for over 30 years. I'm not going to read our written testimony today, as you already have that. You will see that we are seeking your support on increases to direct support professional pay, increases to CDPA and HAA staff pay, problems with the transition to a single FI for CDPA, reforming the Nurse Practice Act so people can have the staff support they need to get medications in their own home, increased rate to durable medical equipment vendors, investments in transportation and housing. However, I want to focus on sharing my experience and the experience of my friend and colleague, Shamika Andrews, who couldn't be here today due to an ongoing issue with her wheelchair. Shamika has been trying to get her wheelchair repaired since October. Since that time, she has had multiple breakdowns and had more than a month when she was unable to leave her home. Her chair was to be fixed yesterday, but it's still broken. Believe me, Shamika is not alone with this issue. This happens far too often. So I think it's ironic that she was going to speak about the issue with durable medical equipment today if she could be here. In the State of the State briefing book, Governor Hochul stated that she would increase wheelchair access by increasing rates for clinical specialty evaluation for new wheelchairs, expanding coverage for repairs. We want this promise to be kept. It is not clear that this is represented in the proposed budget, but it is essential. Now, I want to tell you that I rely on my staff, and so do others all across New York State. I have seen far too much turnover of the staff I rely on, and too many of us don't have enough staff to meet our needs. In closing, you will see the specific requests we are making in our written testimony, but you need to understand how important it is that New York State invests enough in wages to solve our longstanding staffing crisis. Thank you for your time.
Thank you very much. First Senator? Oh, we have Senator O'Mara. Or we have, excuse me, Senator Canzoneri Fitzpatrick.
Thank you, Madam Chair.
I got it.
Mr. Geiser, in looking at your statement, I know you could only highlight certain things, but a couple of things that stand out to me that I know are a problem, and I want to acknowledge them. That the starting wage for DSPs employed by nonprofits is only $17.23 per hour statewide. And in contrast, DSPs who work for OPWDD start at $25 an hour outside of New York City and $27 per hour within New York City. And that this disparity is terrible because of what you said today and how somebody could go down the street and work for a lot more money. And I don't understand why that is, and that's something that I continue to question. One of the other things that you mentioned in your testimony is about how the Department of Health took 6 months to approve the adjusted rates for residential, pre-vocational, and day programs, and that I believe it was probably close to 10 years ago that OPWDD used to approve those rate increases. And I'm wondering if you could share with us what would the approval process look like when OPWDD had that approval process?
Well, it's our hope. I mean, one of the things we're advocating for is switching back the budget authority to OPWDD. Nothing in government moves quickly, and anytime you add another state agency into a process that's complicated and difficult, it becomes even slower. So we think by kind of streamlining the process, removing the Department of Health from that process, putting the onus back on OPWDD, who understands the rates, understands the costs, understands the needs of the providers, that's where that task should lie.
And do you have any sense of what that would do to the approval process as far as timeline?
My hope would be that it would streamline things. It's our understanding that between the state agencies going back and forth over these rates for some period of time, that was a big part of the delay. So eliminating that piece of it would be very helpful.
Okay, thank you very much.
Thank you. Assembly.
Assemblywoman Simon?
Thank you. Thank you all for your testimony. I have a couple of quick questions. One is about with the Consumers Directed program. Are any of your folks using the Consumer Direction, the CDPAP program? And if so, are you able to, what's your experience with this transition to a single FI? And then I have another quick question as well, and just want to acknowledge this issue with durable medical equipment, which has been an issue for the 45 years that I've been in this field. So we really do need to make changes in that and provide the COLA.
Eric, maybe you and I can split this. We heard from Commissioner Baer this morning that there's 9,000 people in OPWDD who are using CDPAP. Most of them are people who are either living at home. I think actually all of them are people who are either living at home with their parents or living on their own with self-direction. And actually, Sandy's might want to weigh in on this as well. There's a lot of confusion about what's going on. There's rumors were flying around just yesterday that parents are no longer going to be able to be caregivers for their children under the new FI. There's other rumors that nothing's going to change. There's other rumors that lots of people are going to be dropped. So there's a lot of confusion and a lot of anticipation of pain. Does Sandy's have
any other experiences? And tell us how we can clarify that so that those rumors and those concerns aren't prevailing.
Yeah, it's not a huge issue for our organization. Our organization primarily, the majority of our services are in certified settings, residential, day hab, things like that. So many of our folks do not utilize the CDPAP program. It's more of a self-direction fiscal intermediary process, so it's not really applicable.
And is there a self-direction aspect of folks who are part of the Self-Advocacy Association? I'm sorry, I don't remember the person's name. You're looking at the captions.
I believe we want New York State to slow down and take time to determine the best path forward regarding improvements to the CDTA PA FI system, a planned development that will transition to new practices.
Okay. Thank you. I think some of us would probably like to follow up with you on that.
O'Mara?
Thank you all for being here today, and we did hear the acting commissioner's testimony earlier, and particularly in regards to your operations, Mr. Geiser, and the ARCs. The differential in pay between the state-operated OPWDD facility and an ARC facility, or many similar entities providing these services. I represent an area of the Finger Lakes and Southern Tier. The ARCs that I represent, the Francisco Racker Centers, I keep hearing about group homes being closed because of inability to hire enough workers to staff them. Yet I believe we heard, to some questioning of Chairwoman Kruger, of the commissioner, that homes were not being closed. I don't know if she meant OPWDD homes were not being closed or ARC homes weren't being closed. Where do we stand on the staffing issues because of this significant gap in pay?
Yeah, I think the short answer is homes both in the state system and on the not-for-profit side are closing for different reasons. The not-for-profit side, it's primarily staffing. If you're not able to staff a home, you can't afford to keep that home open and the costs associated with it. So I don't think it's accurate to say that the homes are not closing. They are. Now, I have to give credit, again, to the acting commissioner and to the governor. The massive investment that has recently been made is going to help bring our salaries up. It's not going to be equal with the state-operated workforce, but it's going to bring us closer. But it still begs the question, I think, which I hope many of you have, is why would two sets of people doing the exact same job get different rates of pay? And it's something I have a hard time explaining too.
Exactly, particularly when on the back end, when it comes to retirement and other benefits, your operations are much less costly as well, less costly as it is from the state perspective with all the benefits and the retirement contributions going in there as well. So in the long run, I think it can be more cost-effective, more efficient for your agencies to being able to offer equal or substantially similar pay to these workers, to have them in the workforce doing this work. So thank you for your advocacy, all of you, for your advocacy on these issues here. You know, again, it's frustrating sitting here for the number of years I have dealing with this issue over and over and over, and there seems to be unanimity among this legislature on what should be done. Yet every year we're back here talking about the same thing. One of these years it has to change. Thank you.
Assemblyman Sempolinski.
Thank you, Chairman. First of all, thank you all four of you for being here. I also want to just point out how important it is to have parents and self-advocates who are on the front lines of dealing with these issues. So especially thank you for being here. Mr. Geiser, I want to first of all give a shout out to my local ARC affiliates and Steuben Allegheny and in Tandem. I have a great relationship with both of the leadership of both of those, and they're in my office all the time. We have a constant communication. So shout out to the folks back in the southern tier. I share Senator O'Mara's concerns on staffing. I've heard the same stories from those local affiliates. That's greatly concerning, especially in a rural area where if a group home closes or some program closes, that it's not easily a replacement to that. When we were questioning the commissioners earlier today, I made a supposition. I want to see if I was right regarding the concerns where every year we have to deal with a COLA or whatever you want to call it this particular year. I would imagine for yourself and for your local affiliated organizations, it makes it really hard to plan, right? How do you plan long-term for staffing, even if staffing's available, when we keep having this situation every budget time? How does that affect your operations to have those lack of planning and lack of certainty challenges?
Is specifically about COLAs or,
Yes, sir.
or increases?
Yeah.
Well, I mean, it all comes back to staffing. You know, if we're not able to pay our staff a living wage and a competitive wage, we can't staff our programs. And every year we come back, and like I said, we're very thankful for the investments that we've gotten over the last 4 years. They've been significant. The recent significant increase in our rate rebasing is going to be super helpful for us. But that alone still leaves us, over the last 2 decades, 20% behind inflation. So it's going to help us catch up. And now going forward, we need a cost of living, which I think you alluded to earlier today. Like 2.1 is still less
Still a
than
cut.
2.9.
Yeah.
So we're actually going to go backwards a bit.
If I can jump in for a second. And from a parent perspective, the entire parent community, it shakes our faith in the system that we have to come up here year after
Right.
year after year to fight for what should be routine.
Right. And I hope your takeaway is, at least from this panel, there's really bicameral, Assembly and Senate, and bipartisan, support for making sure that you're getting a true adjustment that really reflects your costs.
Thank you.
Okay. Any other senators? Senator Purcell, that's why I asked everyone.
You're forgetting me. Thank you all for being here. Donald, I'm going to start with you quickly. SAPIS, with the increased use in cannabis amongst our youth, what kind of a strain has it placed on your SAPIS counselors? Every year you come and ask us for money. Every year we fight to get you that money, and it's still not enough. And now they have this added strain of crazy behavioral issues because of the increased use in cannabis in schools.
Yeah, great question, Senator. So if you hear President Francois speak, he says often, if you stay ready, you don't have to get ready. And so what we're pushing for at the very least is for SAPIS to be in every middle school, campus school, If they are there, there's not one issue that they won't be able to sustain or overtake. The issue right now is there's only 236 of them servicing over 900,000 students. So where one principal may have an issue at one school, that SAPIS is now torn from one school to another. In some cases, we've had reports of a SAPIS that service 4 and 5 schools, just to try to figure it out and make sure that they're servicing all of the students. And in some cases, some schools actually have to go without services because the SAPIS, they're overworked, right? They can't be pulled so many places. That should not be the system that we have, where we're picking and choosing which students we're going to service when we should be servicing all.
Every student. Thank you. And Kevin, I just want to thank you for your advocacy. You know, I'm listening to you and you're reminding me of someone who calls my house every day and calls my office. Her name is Debbie Schwartz. And when she speaks, she is advocating not only as a self-advocate, but she's always talking only about the needs of the DSPs. The needs of the DSPs, and she always reminds me, Roxanne, this is what she says, Roxanne, you have to take care of them. If you're not taking care of them, they cannot take care of us.
That's correct.
And so what you're saying is exactly what she's saying. So it's incumbent upon us to ensure that we take care of the DSPs. You know, I have the bills trying to ensure that they are paid equally across the board. You heard the commissioner this morning speak about it. We have to ensure that we're paying them so that we retain the dedicated workforce. Because the people who are DSPs, they're doing it because they love what they're doing.
Right.
If they didn't, they would be every single one of them would walk away because we're not paying them. They could make more somewhere else. So again, I thank you for your advocacy, and we will continue to fight on your behalf. Thank you all.
Thank you very much.
Lee.
Assemblyman Santa Barbara.
Okay, thank you, Mr. Chair. Just wanted to circle back on the discussion on the self-direction. Mr. Karp, maybe you can just give some comments on the program itself. Obviously, as you said, has empowered individuals with disabilities to take a different route if they choose to. But we know that there's barriers, administrative barriers, lack of adequate funding, and additional challenges that I talked about earlier, actually, when the commissioner was here. What specific budget changes would you like to see that could enhance the accessibility of self-direction?
There's a couple of things that would be wonderful. One is if there were funding available to allow every fiscal intermediary to front the money to parents. Right now, parents have to reach into their pocket. It's tremendously inequitable. This doesn't have to be that way. New Jersey's self-direction system is, there's no reimbursement. It's all prepaid by paid by the state without the family having to reach into their pocket. So that's one tremendous change. Another great change would be if there were, and not just for self-direction, but for the whole system, if there were some sort of innovation fund that would allow us here in New York State to try things out without having to go through the very lengthy waiver process that's required. I can wait. My son's not yet 30. People like Daryl can't wait. He's in his 70s. If he doesn't retire soon, it's all up for him.
And we also had a discussion earlier today about the rates themselves. When they fluctuate, when they increase, are you finding that the budgets are also matching that, or is there a lag?
So for the COLAs and now the TII, there is a rate increase, and that's great. This $850 million, this 13% rate increase, that did not increase the budget for people in self-direction. So somebody in self-direction, like my nephew, who purchases day services, he's just gotten a cut. Because his budget now has to stretch to cover this extra 13% charge.
And that was the discussion I was having earlier. Thank you for your responses. I do want to say that I think the Wage Commission is a good idea. I don't have much time left, but maybe you can give us a little more detail on how that would work. I would appreciate it.
Oh, a wage commission? Yeah, so one of our requests this year is to convene a wage commission that would evaluate and study the human services workforce and determine from an objective body, what's an equitable, competitive wage for our workforce that's sustainable going forward. So I'm super hopeful that you will all support that effort and finally get us to the point we need to with our staffing.
Assemblyman
salaries.
Brown?
Sorry.
Thank you, Chair. Thank you all for being here. Mr. Nesbitt, I'm intrigued by what I heard, and my colleague who was here earlier asked a question to one of the commissioners about the possibility of expanding SAPIS statewide. What are your thoughts about that?
Well, I was listening in to the hearing as well, and was also intrigued by that question, right? SAPIS, the vital, I want to say the most vital thing about most of our SAPIS, they live and work in the community where they live, right? So in order for, I think it would be great statewide as an initiative to look at what the SAPIS do in New York City. They live in those communities, the students know them, the families know them. So whenever there's opportunity for them to intervene in a situation, or they find a student that's actually being bullied, they're able to go to those families and intervene and get things done. So we see substance abuse, and we say it's just a drug issue that they actually do. They do anti-bullying. They do peer-to-peer mentorship, where they teach students how to deal with different issues, not just dealing with drugs. It's a really great program and definitely needed around our state.
So one thing that's interesting, back in my home district, someone I went to high school with, she went to the Board of Ed, and she asked them about having all of the people inside the building being trained for crisis identification for a child who might be in crisis. And she got nowhere, so she actually went to the athletic director, and he was very interested and willing. Her boys had played sports, so she had a personal relationship with them. So what they did was they had every coach in the high school, in that particular high school, trained in crisis identification. So as part of what your union does, is that part of your auspices?
No, so most coaches in New York City are actually teachers, so they're represented by the teachers union.
But do they get, my question, sorry, my question was whether or not they're trained in crisis identification.
Oh, yes, so they're able to deal with most situations that a student may go through. And like I said in my testimony, their reach, so a counselor in New York City schools may have one-on-one interaction with a student. SAPIS actually have a whole curriculum where they're teaching classrooms, so their reach one SAPIS may reach 500 students.
And there's a new program, I only have 22 seconds, so I'm going to talk fast, where out east, on the east end of Long Island, the school district is now working with the local police department that if they're called to a house where there's a child that's exposed to any type of trauma in the household, then they notify the school district so that the school personnel knows, and it's at least to keep an eye out for that child. But thank you so much.
Thank you.
Assemblywoman Chandler Waterman.
Thank you, Chair. Okay.
Another one.
How you doing, Donald? Thank you all, everybody, for your advocacy. But this question is directed to Local 372, DC 37. Thank you for the work and advocacy for you and your president, Francois. Regarding SAPIS worker, we know that they focus on substance abuse prevention intervention, but I don't know, as a former educator running programs as a coach in the New York City public school, I work intimately with SAPIS workers. They do way above and beyond the call of duty, from even DJing sometimes at events, to build that connection. So they become the partner for the community-based organization, they become the partner for the principal and the families and the intermediate to support. So it's kind of disturbing that they're not in every school for me. It's hard to believe that. I want to know, are they in they're not in all elementary schools, they're not all in junior high schools. So how we get a plan where we could, like junior high school, I would say that's the highest need because that's that moment, right? How do we get a plan where they are in all junior high schools throughout the city, then work towards, you know, the highest need with high schools and then elementary school to go to a plan? Because $6 million doesn't seem like enough to do all of that. I'm sorry to give you such a compounded
No,
question,
so-
but we know this is very important.
No, so Assembly Member, that's actually a great question. We're currently working with the New York City Department of Education to look at the numbers of what it would cost to
Yes.
have a SAPIS in every campus and middle school. Most campuses have multiple schools in it, so we're looking at that model right now, but we know that there's a cost associated to it. And I'd just like to put this out there to your question. Our teachers do a great job in teaching our students, but we like to say Local 372 members are the support staff in New York City schools, and they're the foundation of the house. And we know when you build a house, if there's no foundation, the house crumbles, right? So just think about that aspect of a SAPIS not being there to able to reach those students. It gives the teachers also a difficult time in teaching, right? And administration and running the building. And so we're pushing, but we're working to get some numbers now with New York City Public Schools as to how much it would cost to have a SAPIS in every middle school and campus.
Yeah, and it definitely takes the load off the administrators and the teachers who has to do a lot of work. This is something that we definitely want to prioritize and make sure is fully funded. Thank you.
Thank you.
Okay, we have a senator, Senator Fernandez.
Thank you so much, and thank you for whoever mentioned SAPIS, because I do have a budget letter to support $3 million. But is that enough? Is that going to be able to address the need that is in our schools? Could you speak a little bit as to how much $3 million would do? If not, do we need more?
So the ask is for $6 million this year.
Okay, so
$6 million, and with $6 million, as I said during my testimony, $6 million, we know that would help with hiring 48 more SAPIS and would reach 24,000 more New York City schools. And we know that's not enough, but as I said, we're working to see what the numbers look like for middle schools and campuses. That way we expand upon the amount of students that we're actually able to reach.
Thank you very much.
Thank you, Assembly.
Assemblyman Palisamo.
Yes, my question is for Mr. Kaiser. First, I just want to say thank you for what all your dedicated employees do for our most vulnerable citizens here in the state of New York. So please send our thanks and appreciation to them. When I talked to the commissioner earlier, I mentioned that in the past 2 years, according to a report 6 months ago, 91 residential beds have been closed in the Western New York region. I asked the commissioner to follow up on that about beds across the state. And I don't want you to answer that question yet, but I'd like if you had any number on the number of beds that have closed in the ARC homes across the state, if you could share that at the end. But my question, I want to ask you the same question I asked her. Now, she seemed a little bit more optimistic about it with the funds that have been allocated, but I kind of have my disagreements. So I want to ask you the same question. Is it differential between the minimum wage and what nonprofit agencies like ARCs are currently funded to pay? Is that adequate enough for them to compete in the local labor market for the talent and dedication required for these very important positions that are tasked with improving the quality of life and care of our most vulnerable citizens?
The short answer is no. A decade ago, 15 years ago, our salaries were twice minimum wage. Over that period of time, our salaries are now at $17 and change, are about 10% over minimum wage. Now, the investments are going to help. Our salaries are going to raise modestly, and that's a great thing. But I'm not sure that $20 an hour is still enough money for the skill and responsibility we are asking for our staff to accomplish every single day. And that's why we have to continue to fight for a 7.8 increase, which will allow us to invest more in our salaries and catch up from the inflationary measures over the last 2 decades, where we're still 20% behind the 8 ball.
I mean, I've seen in my area people leaving. They want to be there. They care about these individuals, but they just can't take care of their families. They go work at Burger King or Taco Bell or McDonald's. It's just wrong. Truly, the work that they do is God's work, so I wanted to say that. Do you know how many beds, do you have a tally of how many ARC beds have closed across the state in the past 2 years? Or is
Yeah,
it-
I don't have that information at
That's
the
okay.
ready right now. I certainly could go back and do some research, but we certainly have had to close programs as well because of staffing shortages. That's for sure.
Well, we'll keep up the fight, and
Thank you.
for me, I guess it's hard for me to understand how, this governor, every year she puts in a allocation for $700 million for the Hollywood film tax credit to subsidize the Hollywood elite, but yet our most vulnerable citizens and the direct support professionals who are tasked with their quality care and improve their quality of life are left asking over and over again, it's a dog chasing its tail, it's wrong, and it needs to be changed now. Thank you, sir.
Thank you.
Okay, any other legislators? Oh, Assembly.
Assemblywoman Giglio.
Yeah, so thank you all for being here. And I did visit the ARC at the end of 2023, and at that time, we were talking about the CANS assessments. And I'm just wondering with the CAS and the CANS assessments, if any of those services have been pulled away and funding to you has been decreased. Have you received any funding cuts, or have you been cut based on these assessments?
No, the CAS assessments are it's in the works. It's been in the works for a while. I think there are still concerns with the reliability and validity of the assessment. So at this point, they are not being used to determine payment for our supports and services.
Okay, that's good. Okay, and then my next question is about the day hubs and sheltered workshops, because New York State is starting to phase out of the sheltered workshops, which gives organizations an advantage to maybe make some money, let the people that are in their homes go to work and have this rewarding experience of going to a place. And I know that I had visited a shelter workshop in Manorville, New York, and it was very successful, and it was funded by the state partially. And they were working every day. They were scanning in documents for the courts. They were changing batteries on remote controls for the cable companies. And it seems like all of that just went away, and it just went out with the water in the washing machine, and as the state pulled back funds. So I want to hear your experience on the day habs after COVID and getting back to the day hab programs, and then also about the sheltered workshops. And then to finish up, if you could just let me know what incentives DSPs are looking for. What are you hearing from them in order to retain them? Because I know housing is a big subject, especially the rates. We've been talking about this for 4 years, that they need to be paid more, that we need to catch up with the rate of inflation over the last 20 years, and then we need to keep it steady based on the CPI. But it doesn't seem to be happening. So are there incentives that we can do for the workforce so that we can retain them?
Yeah, so I'll start with the first question, which is the day habs and the impact of COVID. Obviously, COVID had a tremendous impact on our day hab programs. When COVID happened, many of our day hab programs were required to shut down. Their congregate settings, a lot of people in close quarters. So, obviously, a lot of people had to go home or stay in their certified residences, and while they have recovered some, they have not recovered fully. Some people have decided to stay home or seek different service supports. But we have to go back again to staffing. We've had a difficult time reopening our day hab programs because we can't find sufficient staff to reopen. And that leaves folks, unfortunately, in a tough spot where, I have to stop.
Thank you.
That's okay. Day habs are important.
I can follow
Thank
up with you. Yeah.
We'll talk more. Thank you.
All right, now I do believe we have taken the questions of all legislators. So I want to thank you all very much for your participation today and for your work every day.
Thank you.
Appreciate it. Thank you. And we are now up to panel E.
It's a big one.
Yes, we're going to need some extra chairs, I think, for this one. We have Ruth Lowenkron, New York Lawyers for the Public Interest, Alliance for the Rights and Recovery, Association for Community Living, Treatment Not Jail Coalition, New York Disability Advocates with a substitute speaker, and New York Alliance for Inclusion and Innovation. Hi. So let's make sure everybody gets into a seat. And everyone, thank you for being so patient and waiting so long. We're trying to move along. Let's start on this side of the table, just to introduce, well, we're just going to do introductions first, so that the people with the cameras and video know who's speaking when you speak. So introduce yourself, please.
Good evening. I'm Michael Seareiter. I'm President and CEO for the New York Alliance for Inclusion and Innovation.
Next.
Hard to believe it's evening, but I'm Doug Cooper. I'm the Acting Executive Director at the Association for Community Living.
Thank you. Next.
Oh, thank you. Winifred Schiff from the Interagency Council of Developmental Disabilities Agencies.
Thank you.
I'm Thomas Calkin. I'm an advocate with the Treatment Not Jail Coalition.
Thank you.
Ruth Lowenkron with the Disability Justice Program, New York Lawyers for the Public Interest.
Harvey Rosenthal, Alliance for Rights and Recovery.
And great, why don't we start with Harvey? So we'll just swing back down the table.
God
That's
bless
okay?
you. Thank you for that.
Thank you.
So I was hospitalized at Rockville Center at Mercy Hospital for 6 weeks with a severe depression a long time ago. And so I know of this. This is really my life. And I have been the director of this Alliance for Rights and Recovery for about 30 years. The people I serve are the people you read about in the papers. People who have severe issues with, with mood, with judgment, who are homeless, who are hungry, who could come in and out of jail and prison or hospital. Not all of them. Lots of people have found recovery. But we're in a terrible climate of fear right now. People are afraid of us, and we're afraid of them. And it doesn't help that the New York Post talks about the deranged, fanatics, and lunatics every other day, with an eye towards pushing forced treatment. And I'm here to fight forced treatment. I'll tell you that 4% of our community is violent. 11% are victims. We have names for them. Jordan Neely, who was choked to death on a subway, and Daniel Prude, who was killed by the police in Rochester. We know what works, though, not coercion, but we know what works. And we've created some of those programs. We've created the INSET program over here, which is a peer-led program of engagement team that has engaged 83% of people who otherwise would be on a court order. They engage the unengageables. We have we're working on Dana's law, which would send the police, not the police, the peers and EMTs out. We created the Peer Bridger program, which helps people leave hospital and not return. Once they leave hospital, they should get into housing first, which will take people, regardless if they're taking medicine or drinking or drugging or what have you. We've got to be there for people no matter what. Then the Clubhouse movement has not been up in upstate New York for years. The governor's going to do that. We're grateful for that. In this budget, there's $16.5 million. You've heard about it, this afternoon. It must go to voluntary services, not AOT. We urge you, please come out in that way. We're against, like so many groups here, we're against forced treatment. We're against it involuntary forced treatment. Do you know when they pick you up on the street? That's called a mental hygiene arrest. If you have trouble with food, shelter, and clothing, now you can be picked up and put involuntarily in a hospital. I think we just read for New York City, 40% of the time, they weren't eligible. They didn't have to be admitted, but they were picked up and went through that trauma. Even some of the tragedies you read about in the paper, they were in the hospital a few weeks before. Hospital is not the answer to this thing. Also, assisted outpatient treatment, or Kendra's law, the legislature has found this to be controversial. They've not made it permanent since 1999. They review it, oh my God. Well, you'll have to do the other. It affects people of color. There's a second study that's going to prove that. You want to wait, please, until the second study comes out.
Thank you, Harvey. I have to cut you off.
Thank you, Senator.
Thank you.
Good evening, Ruth Lowenkron, New York Lawyers for the Public Interest. I, too, like many of you, am a family member, both of a person with physical disabilities, mental disabilities, and I've been an attorney in this space for almost 40 years. And our office is counsel for the Willowbrook class, for the Brad H. class, and many more developmental disability and mental health cases. I understand that we're here because we have a goal of improving public safety, but how have we come to the point where we think that getting people with mental health diagnoses is going to make us feel safer. They are not the problem. As Harvey Rosenthal said, this is a stereotype that is being peddled at us by newspapers and the media and literature. And people with mental health diagnoses are not the ones causing the harm. They are no more likely to cause the harm than people who do not have diagnosis. And even if this is not the case, do we want to lock people up and make these mental health arrests? Hospitals are not the answer. I, too, was with my sister in the hospital where she received limited, if any, treatment and then is turned away after a brief amount of time. Forced treatment is not treatment. Take a look at the literature. It is very devastating for people with mental health diagnoses. It's a disincentive to seek help. It has increased suicidality. And even if hospitalization forced were the answer, as others have said, there's no capacity at the moment for the people who need hospitals. How are we going to all of a sudden increase this? Just heard about the people on Rikers staying for days without beds. And even if there were capacity, unless you're thinking about throwing away the key, what are we going to do with these people, with my sister, with your relatives upon discharge? We can talk all we want about discharge planning, but where are the services? And that is why we recommend a full list of services. And if you take a look at the tragic incidents where people with mental health incidents were causing harm, you look and you see that every one of them have been in a hospital, but they didn't have the coordination of services and they didn't receive what was needed. A real quick thing about forced outpatient treatment, take a look at the huge racial disparity. Our office is putting out an updated report in days. The disparity is humongous. And most critically, even though the commissioner has said that people are being helped by AOT, we don't know that. We know that people who've gone through AOT have had good resolutions, but is it because of the services or is it because they were forced? Please think that through strongly, and thank you so much.
Hello. As I said, my name is Tom Culkin, and I would like to thank you for the opportunity to testify here today. I have submitted a comprehensive written testimony. I'd just like to briefly tell you about myself and the coalition that I'm part of. I'm a lifelong Buffalo resident and a recent graduate of the University of Buffalo with a master's degree in social work, and I'm currently a mental health therapy aide at the Buffalo Psychiatric Center. I have a serious mental illness and substance use diagnosis, and like so many with these medical conditions, I'm also a survivor of the New York prison system. I'm a member of the Treatment Not Jail Coalition, which is a collective of statewide mental health care professionals, law enforcement personnel, faith leaders, and importantly, people with lived experience. This group advocates for systemic reform at the intersection of mental health, substance use, and criminal justice by championing expanded access to diversion opportunities. My story is like that of so many other New Yorkers who have dual diagnoses of mental illness and substance use. I have been suffering from drug abuse since my teens, when I first encountered the symptoms of what I would later learn to be mental illness. This included uncontrollable mood swings and obsessive thoughts that I allowed to dictate my behavior. Due to the combination of stigma, a lack of access to medical resources, and my own juvenile brain beliefs, I turned to the only way I knew how to quiet these thoughts, and that was self-medication through illicit drugs. By 2012, my addiction had reached crisis levels, which led to multiple arrests for residential burglaries. Recognizing that addiction was at the root of my behavior, my lawyer tried to get me admitted to drug court, which would have allowed me to continue my recovery and avoid incarceration. However, I was deemed ineligible because, despite there being no actual violence in the crimes, some of the charges were classified as violent felonies because of the potential for violence. I was instead sentenced to 9 years in state prison. I was suddenly thrust into one of the most hostile and chaotic environments known to man. Drugs, violence, sex, gambling, and gang affiliation are pervasive in prison. Most incarcerated people do turn to these in order to survive their time inside. While in prison, I lost several friends to death by suicide, and I seriously contemplated ending my life every single day during my first year of incarceration. Those of us with underlying addiction and mental health issues were the worst off. Carceral settings naturally enact nearly insurmountable obstacles to obtaining meaningful treatment to those of us in need. The conditions of incarceration exacerbate our underlying issues, and we're more prone to violent abuse by both fellow detainees and corrections staff. We're also more likely to be released mentally gutted and facing acute overdose risks. We re-enter our communities disconnected from housing, public assistance, treatment, and struggling to establish livelihoods under the stigma of a criminal conviction. That is why even short periods of our incarceration have been proven to increase recidivism. I share my experience here in the hopes that future generations will never suffer the way I did. A good start would be to pass legislation to expand and modernize diversion opportunities, create more treatment courts, open eligibility, make sure they're following best practice standards. Expanded access to diversion programs would give people in the state the opportunity for recovery and grace that I did not get. Learn from me and the thousands of others like me who were condemned to dungeons of incarceration for their sickness. Prison did not make me better. It nearly killed me.
Wow, okay. I'm here on behalf of New York Disability Advocates, which is a coalition of 6 provider associations representing over 85% of New Yorkers with IDD. And while we thank you for the opportunity to present, the discussions today show that we have some clear support from the legislature. So we're truly grateful for the past 3 years of increases and the recent increases associated with our rate rebasing, and those funds will be used and have been used for salaries and other rising expenses. But as shown by our NIDA recent survey results, we still have a 17% vacancy rate for staff and a 35% turnover rate. And those really damage the continuity of care for people who require consistency, including people who are nonverbal and those who have additional physical and behavioral health challenges. So while we're in a much better position now, continuing support is needed to bring us and keep us current with operational expenses and able to pay what would be even approaching a livable wage for our talented and selfless staff who dedicate their lives to helping others. On the inflationary increases over the past 3 years, we've received 12.2%, and that led to almost 15% in staff increases. But inflation during this period exceeded 17%. So without continuing to give to keep up, we'll be right back where we started before Governor Hochul took office. And now I will give you our asks. You've heard some of them before. The 2.1% targeted inflationary increase in her proposal is a great first step, but based on the past 3 years of inflation, we're asking for a 7.8% increase to bring us level with current expenses. And we also ask for the creation of the Human Services Wage Commission to study the wage adequacy for a number of direct care positions. The Wage Commission would provide recommendations for the creation of a longer-term plan to provide adequate compensation for frontline human services workers who most of us will eventually depend on. And one more request, we would like to restore the rate-setting authority to OPWDD from DOH. Since the transfer about 10 years ago, providers have endured a slow and unpredictable flow of funding, which has challenged their financial viability. Thank you.
Hi, again, I'm Doug Cooper. I'm with the Association for Community Living. We represent the providers that operate about 95% of the programs or beds that the Commissioner Sullivan mentioned that are housing for people with mental illness. So it's a pretty vast system. And just along with all of our colleagues, we support that 7.8% increase, and recognizing that the 2.1 is just going to put us in a further deficit. But that 7.8 really just maintains the status quo. It doesn't address our built-in deficits that have been years in the making. Our staff, and there's been a lot of discussion about, the quality of services or the adequacy of services, the capacity that's out there. All of our staff in our programs are paraprofessionals, but the needs of the people coming into our programs require more than that. We don't have any nurses. We don't have any clinical workers. We don't have any health aides. We don't have nutritionists. I heard someone mentioning that's reimbursed in our system. Those services are needed in order for us to provide adequate services to the people that we're serving. The current staff that we have, you've been hearing about staff vacancy rates and turnover rates. Our staff vacancy rate currently statewide, the average is about 30%. Our turnover rate is close to 50%. I don't know how our members are keeping their doors open. We need we need the 7.8, but we need more of an investment than that. We actually have an ask, which has been in my testimony, for an additional $230 million. We don't think that's going to happen all at once, but we need a plan that actually will help us provide the services that are needed by the people who are our residents, who rely on us for their home. And how would we spend that $230 million? One example is we have a program that's called the CRSRO. Assemblywoman Simon, you mentioned that earlier. That's a program that's licensed, provides a high level of services, and the funding level for that is anywhere from $8,000 to $10,000 a year, less than what is being proposed for ESHI. ESHI needs those additional dollars. They need to be funded at a higher rate, but we need that same rate, if not more. We're a licensed program providing a higher level of service. So, our two asks this year is we need to maintain the status quo, just to keep our doors open, and that's that 7.8%. But we also need a plan for a larger investment that will really give us the ability to provide the level of services that are needed for the current people that are living in our programs.
Good evening again. Michael C. Ryder with the New York Alliance for Inclusion and Innovation. For the first time in my memory, we are not coming to the legislature in absolute desperation regarding the staffing crisis that has plagued our OPWDD service system for the past 15 or more years. And that's largely thanks to the governor and the 7-1 rates that we were talking about before, you've been talking about today, that she just released for OPWDD certified residential and day programs that are subject to the rebasing on a 5-year basis, including continuation of those resources in this proposed budget. An extra special thanks to Acting Commissioner Willow Bear for her leadership that she has shown to secure the most significant single investment in OPWDD in my 26 budgets that I have been involved with. We very much look forward to working with her as commissioner should she be confirmed. Is it a panacea? Hardly. But it does help to stabilize dangerously unstable parts of the system that I and my colleagues have described to you in previous years. We are appreciative to the governor for continuing to make investments in our systems and others this year with a 2.1% targeted inflationary investment, especially after so many years of neglect. That's especially important for programs and services that OPWDD operates and functions and funds that are not subject to the rebasing that we have talked about as well today. We join with our colleagues in asking that that targeted inflationary increase be targeted inflationary investment be increased to 7.8%. As referenced by many of you today, the 2.1% doesn't actually help us keep up with the current inflation rates, and we need to avoid losing any further ground with regard to competitive salaries, ability to pay insurance, and remain compliant with OPWDD's program requirements going forward. There are many other items in the executive budget of which we are supportive. It's found in our written testimony. A few places where the legislature could improve upon the governor's executive budget, including the targeted inflationary increase of 2.1 moving to 7.8%. Move the rate setting authority from DOH back to OPWDD from the 2015 move 10 years ago. We believe that this would improve some of those challenges that Mr. Geiser was speaking about before in relation to all of that administrative effort that goes into actually getting money out the door for things like targeted inflationary investments and COLAs. Include the OPWDD service provider organizations as eligible entities that can access the state's capital resources for targeted climate action. We have nearly 6,500 physical locations that could benefit from things like solar panels if we had access to capital resources. And lastly, we do recommend and join with others in recommending the creation of a Human Services Wage Commission to study and make recommendations for next year in relation to the wages that would be commensurate with responsibilities that direct support professionals and others in human services provide on a regular basis. Thank you.
Thank you so much. This questions is for Tom Culkin, Treatment Not Jails Coalition. I am familiar with the coalition and its goal to change how we address those that are suffering with substance use disorder. A concern has been put out that the bail reform laws have allowed people to fall through the cracks and lose that touch point to getting them to substance use disorder. Could you speak about that and how this might be a better idea?
Yes, could you repeat the question, please?
How can we ensure that we are still reaching these individuals without rolling back progress of bail reform?
Well, I mean, I think reaching the individual is based on making treatment more available and more easier to navigate. I know myself, for years, I had the hardest time navigating a treatment system. I got kicked out of more rehabs than I cared to count. Just applying for treatment is a huge process that a lot of people just are not capable of completing, especially when you're not in your right mind. The system needs to be streamlined, and we need to make it easier for people to get into treatment in order to get better, rather than just continuing to, incarcerate them, let them out, incarcerate them, let them out. I believe that were treatment courts to be expanded, we would have a lot less crime in a matter of, a relatively short period of time. I hope that answered your question.
Yeah. Recently, at one of the press conferences, I believe there was a former sheriff, a law enforcement official, who has come out in support of this legislation. Could you speak about how law enforcement has now turned to say that this is the method that we should be utilizing?
Yes, I believe that was at our advocacy day just a couple weeks ago. I believe he was an Albany County sheriff as well. He spoke last year. I think that as law enforcement learns about what will actually occur if this law is passed, I think we're getting a lot more support. And recently, I've been a member of the coalition for almost 3 years now. There wasn't much law enforcement support when I first joined, but there definitely is more now. I think a lot of law enforcement officials understand that the carceral system we have now does not heal people. It doesn't encourage people to stay out of the system. Prison's a finishing school for criminals, okay? I could have contacts for drugs, guns, cars, people, if that was the way I decided to spend my time in prison. That's not how I spent my time. But that's the way most people do spend their time when they're incarcerated. Positive things just aren't done. Prison's not
MAT
rehabilitating.
programs aren't happening in all prisons and jails as they should be, so.
What was that?
I said MAT programs are not happening in prisons and jails as they should be, for what I've been told. So we could assume that, yes, this
They do have programs, but they're not run very well. Basically, as far as I'm concerned, what it comes, can I finish or no? In prison, the priority is always security. With mental illness and addiction, the priority has to be recovery or it doesn't work. I know that from painful personal experience.
Thank you.
Assemblywoman Simon?
So thank you all for your testimony. Get this a little closer here, sorry. I'm, I think everybody, I think you have a lot of support for increased TII, which is the new word for COLA. And I think everybody understands that need and the fact that we're sort of digging ourselves out of a hole that we've been digging for a long time. And this is a big step, but it's not going to solve every problem. I also want to kind of just explore with you, because I think this big issue this year is involuntary commitment, expanded AOT, money to help counties pay for things, even though we believe it, let's say, shouldn't be coercive. But there's a real challenge here with people feeling that they need to do something to address this issue, which appears to be, and what people are thinking, is criminality, right? And yes, we could say we're criminalizing mental illness, but that's been done, and everybody has this association, and it's being ginned up by the press for sure, but we've also had some really horrible things happen. And how do we separate those things or achieve a balance that people feel like we have made some progress on this without going to the other extreme, which I think people don't realize that the balance is actually against people with mental illness, when people may think it's for them and it's an excuse, right?
Those episodes were horrible. Those episodes were horrible.
Yes.
But they represent such a small minority. And there are other murders like that that happen, but if it's a person with mental illness, it's on the front page of the New York Post.
Right.
And we're being told to force them. So just want to make a distinction there. The services I mentioned are for people who are that troubled, who we worry about, who are struggling and suffering. We don't stand by because we're for human rights. We provide the service that actually works. You're just going to force people into the same bad services if you don't create the right services. That's what we need your help for. Don't go to coercion. It really is not going to get it done. I know the public is afraid, but stand tall with us, please.
If I can just add, we have a whole list in our testimony of positive, voluntary, community-based programs that are the answer. So we're not just saying, don't do this, we're saying, do that, which has an excellent track record. And one of the things that I want to quickly squeeze out is something that Senator Brooks spoke about, and that is the panels of
The incident review
we're going to
panels.
talk about the incident review panels. And so many people have spoken about the need to look at what are we doing wrong in order to figure out what we're doing right. That is the answer. It's already in statute.
And you can put in the law, it says may, you put shall. Have a OMH do that.
You can answer. Whose turn is it?
It's your turn.
Harvey, would you continue to answer the question for me, please? Now I have 3 minutes. Answer the question.
What, I
Go
couldn't-
answer the
Finish your
question.
question, finish your answer.
Finish the answer.
Oh, more time?
Yes.
Yes.
Okay, thank you, Senator. So, first of all, I want to say that people, even the county officials have said to me, I only put them on an order because the waiting list for services is so long, and if you put them on AOT, then they'll get front. So you're dragging people in front of a judge and criminalizing them only to get them to the front of the line. So we got to pay attention to that as well. The Instant Review Panel is really critical. It was recommended in 2008 by a panel in New York City. You put it in statute in 2014. OMH, the commissioner's great. She doesn't want to do it. We have a right to know what happens each time. Otherwise, these tragedies happen and, you don't hear what happened. And they don't have to break up some kind of confidentiality. We've reviewed these things, and what we find is the services are not coordinated. That's a big one. So the Incident Review Panel will probably get us services that are better coordinated, more effective, more engaging, and like that. I forget the fourth word, but
Thank you.
thank you,
Assembly.
Senator. Thank you so much.
Assembly Member Giglio.
Okay, so I agree, OPWDD needs to take back the rates. The 7-1 rates, we just got them when, 2 weeks ago? Yep, and organizations such as yourselves are owed millions and millions and millions of dollars that you've been operating on a tight budget since 7-1 because these rates just came out. But hopefully you'll be getting those checks within the next couple of weeks, and it will be retroactive. So yes, I agree with you. OPWDD needs to take that back. DOH has a lot on their plate right now with early intervention and with the CDPAP program, and OPWDD should be taking care of your agencies. So I 100% support that. I also support the rate increase, and I also hope that my colleagues and I can get together and make it that you will get your increases every year based on the rate of CPI. We're seeing a lot of inflationary increase in the budget this year for state agencies, but we are not seeing it for our not-for-profits. And a lot of our state agencies are closing down, and those people are coming to you. So I'm just, I love the idea of a wage commission. I love the access to capital resources for energy. I think these are all really important things because not only are you dealing with not getting the funding that was promised to you in the budget because the rates weren't set, but you're also dealing with high utility costs and other inflationary items that could reduce your expenses so that more of this money could go to the DSPs. So if you could just tell me any other ideas that any of you have so that we can all work together on this to make sure that we fully fund our most vulnerable population.
If we started with those, we'd make a huge dent in trying to address some of the challenges that have been pervasive in this system for an awfully long time. The things you just rattled off would make a gigantic improvement in our service delivery system.
Just thank you very much for your support, and we'll continue to work with you this legislative session. It has to be about this.
They done? Senator Fitzpatrick?
We have more time or no? No. Oh, I'm sorry, I'm looking at the clock there, no problem. Oh,
Thank you. I
stopped
just
working.
wanted to follow up on a question that Senator Fernandez asked to Mr. Colkin.
Going back and forth. I don't know.
With cashless bail, criminals are, arrested, we release them. How do we motivate them to voluntarily enroll in a program to help them with either their addiction issues or their mental health issues? How do we reach those people and motivate them to get the help that they need?
I think that that's a great question. I think that one of the ways is to make recovery more attractive, and the increased use of peer specialists, I think, is a great way to do that. The word has to get out that you can live a good life without drugs, without alcohol. You can still be okay taking mental health medications on a daily basis. How we do that, I don't know. I'm not a public relations person, but I think that would really help the situation quite a bit, and also streamlining the system, like I spoke about earlier. I mean, people with master's degrees have a hard time navigating the treatment system today.
Yeah, thank you very much.
Barbara?
Thank you, Mr. Chair. Thank you all for being here. It's a big panel, so thank you for all your testimonies. A lot to take in, but it's all good information. I also want to echo what I said for the last panel. The Wage Commission, I think, is a very good idea, and I saw it on some of your websites and social media, along with some other things as well. The wages are one piece of it, I find, with my agencies, and particularly Liberty ARC in Amsterdam. They have really embraced a credentialing program. They've had several graduating classes. So the recruitment and retention is a whole other piece of it. So I'd love to hear your thoughts on, besides the wages, I think we also need to do more career pathways, and I suggested investing more in the SUNY system and those type of career pathways. Maybe just comments and maybe some things we can do in the budget to improve these pathways to professionalize and credentialize.
Sustaining the things that have been piloted by OPWDD that have proven good outcomes would be remarkably valuable, whether that's professional development in our direct support professionals themselves, the credentials, the SUNY CUNY micro-credential, building a pipeline through the BOCES programs and other things like that, will pay gigantic dividends if we are able to reflect the complexity of these jobs in the wages that are paid for them. Quite frankly, this sector of OPWDD service providers would be in a more competitive position with regard to other positions in any other sector, including, quite frankly, human services as well, because of some of these types of investments, if we get to wages that are indeed more competitive, because it becomes more attractive. It's not just that I have to leave the job to go to get something different. I can make this part of a career, especially if I'm passionate about that, and I want to remain as part of someone's life, and supporting them to become supporting them to pursue their dreams and achieve their dreams the best as possible. These are remarkably great things. We just need to kind of follow that through with making sure that the compensation reflects the complexity of the job.
Agree with everything Michael just said, and I'd like to also add that the Wage Commission is so important, because in order to get us from where we're at now to where we actually need to be, in order to really professionalize the position and pay people what, commensurate with what we request them to do 24/7, it's a multi-year plan, because it's going to be quite expensive to raise salaries in the ways that we need to.
Thank you. Thank you for being here. Thank you for your answers.
Thank you, Chair. Sorry. Mr. Culkin, I had some questions. Mr. Culkin, I had some follow-up questions for you. Senator Conazzari Fitzpatrick asked you a question that related to, with violent individuals, you said yourself that you were convicted of a violent crime. What crime was that?
I pled guilty to 3 counts of attempted burglary in the 2nd degree. It's considered a violent crime by statute because of the potential for violence. I entered people's homes while they were there.
Right, and I think, so let me just preface this by saying that one of the things that I really think that we should try to shoot for as a society is to get people who are having trouble with substance use disorder into therapy and treatment as soon as possible. But the distinction that I think some of the DAs have said to me when it relates to this piece of legislation is that it lets violent criminals out on the street where they need to get rehabilitation inside as well, and that rehabilitation come in the form of behavioral rehabilitation as well as substance use disorder. So what would you say to the DAs?
I would say that's great in theory. I could talk for an hour about how ineffective programs in the prison system are. No policy is going to perfectly address every case.
Sure.
We are going to make mistakes. The idea, I think, is to benefit more than we take away. And I think that treatment, it's not going to work the first time for everybody. It's that simple. But
Can I
what,
just
we
ask you a
give up?
question? I'm sorry to interrupt you, but when were you incarcerated? What
I was
years?
incarcerated from 2013 to 2020.
Okay. So in our county, our sheriff is very active, probably, you know, and I know several are, but I just know from personal experience that our sheriff has really been at the forefront of bringing as much treatment for substance use disorder into our jail system, and he actually goes around the country speaking to other systems about how to incorporate that. So was there something like that in prison for you that you could benefit from?
I was sent to prison in 2013 with a drug problem. I was put in an alcohol and substance abuse treatment program in 2019. The program was run by inmates while the counselor stayed in the office. I was lucky that there was inmates who actually cared and would try to be effective. But yeah, we had professional counselors. They weren't doing anything. There's no motivation for them to do anything.
So if I may, just 2 quick questions. So I had asked before, and I only have 18 seconds, so I'm going to run out of time. But I think with bail reform, we miss an opportunity to get people to treatment as quickly as possible. And I think with desk appearance tickets, there's an opportunity there to switch the system and make it available for people to get treatment rather than having to go into the court system. And if they fail, then they go into the court system. So, thank you for being here.
Thank you.
Thank you. Thank you all for being here. And I do want to mention quick with regard to the OPWDD and taking back the rate setting. As we know, the governor is administratively transferring billions of dollars out of DOH into the mental hygiene budget. So it makes even more sense that for consistency's sake, that be the case. And I would say even transparency's sake. I wanted to ask Winnie in particular if you have any thoughts with regard to this. I know, we had done that call back in December, and we were talking about the Wage Commission, and I think it's something we need to do and set ourselves up for, the future, so we can finally make the changes we need to make and get and make sure there's adequate wages to retain and recruit workers. But I think we all know in the legislature, if we do something like this as a standalone bill, it's getting vetoed, right? It happens on so many important issues. Some of them have come up today. But that's just the nature of where we are. So it's imperative that it get done in the budget. So do you have any sense as to what an appropriate appropriation to go along with that would be so that it could be conducted?
Well, that would be the job of the Wage Commission. First, they would have to study a variety of direct care positions, because it's not just DSPs, although obviously...
Actually, I mean for the conducting of the study, actually.
I don't know the cost of that. Do you, Michael?
No, I do not. But I would venture to guess that that's probably not north of $1 million. Like you're talking a pretty sizable group of sectors that you're going to need to look at, bring in. I'm thinking travel, quite frankly, is going to be one of the most expensive things to cover in that. But you could look at this and get some really good trajectory for where the system needs to go. Multiple systems need to go. It seems like wise investment of resources.
I'm just trying to avoid the pitfalls that we see all the
Yeah.
times with these
No,
things.
it would be a group of people who are already engaged in the work, so they, there are no salaries involved. Travel looks like the thing. Yeah.
Right, you look like you have something you want to say.
Yeah, I just, the topic of money came up. I just want to say that it costs a lot less to treat people than it does to incarcerate people. The state's paying $150,000 per person a year. Rikers, it's over $500,000. I mean, it's just, the money makes sense.
Absolutely. I agree completely. Right. Well, thank you all. Thank you all for your patience in being here and your advocacy.
Hi, thank you so much for your work and for your words. In my district, I've seen firsthand how bureaucratic systems inhibit or prevent folks from getting the treatment and care that they need, and I know it from my own community as well. So I know you can't force or cajole somebody into successful recovery. So what are some other barriers that you all are seeing to good recovery that we aren't addressing right now? And what are the right legislative fixes and budgetary fixes that you need from us that we could propose in our one-house budgets?
Well, I think housing, a lot of, people, I think poverty, I think racism, isolation. So I think there are programs like the Clubhouse programs that are going upstate. They provide all of that. They provide food, drop-in services, sort of relapse prevention. We have programs out there. We already know what works.
Right.
We just have to invest in them.
Right.
We should get a COLA, but we also just need more and more different services. That's much cheaper than $1,300 a day in a hospital in New York City.
Right. And I know workforce is really difficult too. I know so many folks who are in recovery who are looking for work, but they don't have recovery-ready workplaces available for them to work at.
Right.
Do you have any thoughts on that program and what we could be putting into that?
I don't know that one, but clubhouses, that's the main function of a clubhouse, besides connecting people sort of socially, is employment. I ran the clubhouse in Albany, and because I didn't do employment all day long, I wasn't really a clubhouse. That's how serious it is.
That's great.
I was just going to add, along with housing and dealing with poverty, let alone racial issues, I think that you're very much onto something, and it's something that we're looking for too, and that's employment skills training, absolutely. And in the program that you mentioned, vocational rehabilitation programs, that's where definitely one of the areas. But I think if you take a look at the list that we have and you want to know what can we do, the programs that we have on that list are tried and true, and that's where the money should go, and that will avoid the consequences that you're concerned of, even though we say those are very limited, violent public safety consequences.
Right.
I just want to add that recovery is holistic. If we get somebody sober but don't help them find a place to live and give them a way to meaningfully pass their time, it's just not going to last. I mean, what is it they say? Idle hands are the devil's work. If I didn't have a reason for living, what's the point? I think the money for the clubhouses is huge.
Great. Thank you so much.
Okay, thank you, and thank you to all of you for being here. I appreciate your well-thought-out strategies to address treatment for mental health issues. And I was just curious, of course, treatment courts seem like a really good way to address a variety of issues. And I wondered, are there statistics that show where there is a adequate amount of treatment courts and where there is none? Do you have those statistics across the state of where this is succeeding? Can we get those numbers anyway?
There are numbers. I'm not really familiar with a ton of them, but I can say that I don't know what year it was, but the most recent year statistics were available. There was something like 20,000 arrests in the state, and 40 people were diverted to mental health court. I mean, that's a statistic for the underuse. There are statistics. I could connect you with the person who would have them. I'm not familiar with all of them.
Okay.
I can say that making the decision to divert somebody to treatment based on the recommendation of a clinician would be a lot more beneficial than the recommendation of a DA.
Yeah, it seems like it could be make a big impact. And then I really like to learn about the programs like the Peer Bridge, Inset, Clubhouses. And the same question goes, like, where are those succeeding and where are they? And where are there like deserts where there's nothing like that available to people? Do we have that? Like, do we know if Long Island's underserved, upstate? What do we know about
Really
this?
everywhere. The INSET program starts in Westchester, now they have one in Long Island. Now they have two in Suffolk. They have one in Buffalo. So there's 5 of them in the state. Bridger programs, we created that out of 5 state hospitals. And now there are more of them, but that's the core. And we help people get out and stay out of hospital. In the budget, we're happy that the governor's going to fund some Bridger programs in community hospitals, not just the state hospitals. So they're growing slowly. These are first generation of these new models. So we have 5 of this kind and 8 of that kind. But so there is some money in the budget, but we'd love more because we really think we need them.
And it seems like it would be, a wise investment because it really does make an impact. But I would love if we could get any statistics so we could see where we need more, where do we need more of them.
Definitely.
And I agree with the review board, the review panels. It's odd to me that it was adopted in 2014 and still hasn't been implemented. That seems odd. And also wage commission study, all of those ideas, are, to me, I'm on board with all of them. And Harvey, you mentioned you were at Mercy Hospital. Do you live in Nassau County?
I grew up in Freeport.
Oh, in Freeport. And do you still live over that way?
No.
Oh, okay. I was going to say you could make an appointment at my office and we could speak about this more if you were local. Okay, thank you very
We'll
much.
have lunch at Ben's.
Thank you so much for all of the work and advocacy from everybody here. I just want to do a special thanks to Ruth and Harvey. Thank you for supporting my district, working closely with my mental health task force that we've created. And we got to shout out Christina for making sure we put all that together as a peer. Not only my constituency, but my family members as well. You have supported them greatly. So I do agree that we need a sustainable person-centered plan with peers at the front of the conversation, like treatment, not jail, not like Daniel's Law, the $1 million that we fought hard to make sure that report was done. Shout out to Bronson and Brook on that. I just want to know, when it comes to, we talked about the increased funding for Peer Bridges program, definitely expanded local culturally responsive respite centers and clubhouses, transform the mental health crisis response like that, housing, invest and expand family support. That's something I really want to talk about. Oftentimes, families are left out of the process or not in the plan at all, and barriers are created for families to really support. And we know that's the way to recovery, is with family support. So I used to think about, like, if you had a brochure, a one-pager, what happens once you enter CPEP, right, for a family, when you leave them at that door, right? What then go to the MHUs, aftercare? What would you think would be like the first thing that we need to focus on for family support so they can be really intentional about the recovery of individuals in crisis?
So we work closely, Harvey and I. Actually, we work in the coalition with criminal reform attorneys and civil rights advocates, providers, disability advocates. And one of the major contributors to that coalition is NAMI New York City. And as you know, they are all about family programs. And we have a whole platform that is in my testimony and that I can share more broadly with more details. But NAMI New York City will be putting in testimony that specifically talks about what kind of money for what kind of specific programs, unless you have something more specific to say,
The family
Harvey.
support program is $500,000. Is what they told us for this year.
Well, that's what we're getting, but I think we have other recommendations. Yes.
We're asking for it.
No, oh, I'm sorry. Okay. Good, we're a team.
Well, thank you. Is there anything else that you want to add to that? You're good? All right. Thank you so much. No, she good. She have something? Go ahead.
Well, I wouldn't mind just saying one more thing. In terms of all of the programs that we're talking about, I want to just take 1 second to talk about the Daniels Law, because that is something that takes into account all the issues we have been talking about here, the prominent role of peers and I thought that the Assembly member.
She still had time.
Oh, I'm sorry.
No, you still
Sorry
had
if I
time.
did the wrong thing.
You used up your time already. You can talk to
8
her
more seconds.
afterwards.
She hadn't. The clock was running. There's still, in fact, 8 seconds.
It's your, it's your, remember, you decide.
Go, talk.
Keep going.
I'm sorry, not to offend, but the Daniels Law, which we're hoping to get everyone here to sign on to, many of you have, is all about the frontline role of peers and to avoid the crises that could potentially lead to untoward events, again, which we say are limited in number.
Okay. All right, everyone now got their time. Well, then we're going to ask you, thank you very much for staying with us and for sharing so much important information. And we're going to let you be excused. And we're going to call the last panel of this hearing.
Assemblymember Griffin, I received a text on my watch. That was 274,000 arrests, 52 diversions. I will get some more statistics and email them to your office.
Okay, great.
Thank you. Okay, so now we have panel F for those of you who are keeping score. Friends of Recovery, In Unity Alliance, and Licensed Creative Arts Therapy Advocacy Coalition. Okay. Well, I guess it's officially good evening. Or all good, all three of you are here. Thank you. So first, just go down the line and introduce yourself so that the tech people know which of you is which. Hi. Press the green. You have to push the button in a special way. There
Push
you
it
go.
hard. I am a co-founder of the LCAT Advocacy Coalition, president emeritus of the New York Art Therapy Association, and clinical director for the Emerald Sketch, an LCAT.
Thank you.
Good evening. My
Good
name is
evening.
Ji-Hoon Kim. I am the president and CEO of In Unity Alliance.
Good evening. I'm Dr. Angelia Smith-Wilson, executive director of Friends of Recovery New York.
And why don't we start with you, Dr. Smith, and then we'll go down that way. Oh, Dr. Smith-Wilson, excuse me.
Excellent, thank you. Good evening, everyone, and thank you for hanging in there, right? Again, thank you for allowing Friends of Recovery New York the opportunity to bring the voice of over 260,000 New Yorkers who report, who self-identify and report as being members of the recovery community. Again, my name is Dr. Angelia Smith-Wilson, and I am the executive director of Friends of Recovery New York. Friends of Recovery New York represents individuals and families living in recovery from addiction, those who have lost loved ones to addiction, and those otherwise impacted by substance use disorder. For New York is also dedicated to building a strong statewide infrastructure as we stand as the New York State's only statewide recovery community organization. I lost my train of thought. And we also support a robust peer workforce that provides vital support for people in recovery and others in need. So the question is not how this proposed budget will impact the over 260,000 New Yorkers who are in recovery. The question is, how bad will it get and how many more lives will be lost to the opioid epidemic? It was literally said earlier today that budgeting is about priorities, and I wanted to jump through the screen as I was live streaming that part from my audience, because budgeting is about priorities. It is the definitive way that we decide as New Yorkers who we will care for and how we will care for them. So while it was also stated by our New York State OASIS commissioner that there has been a 17% increase in opioid overdose, while we applaud that, it is a short-lived victory, as it is not it is not equitable in the Black and brown communities. We are not seeing such a sharp decrease and decline in opioid overdose. So I would be remiss if I did not bring that point up. So the New York State Office of Addictions and Services Supports continues to be funded at a significantly lower level compared to other agencies serving similar populations, such as OPWDD and OMH. On average, the OASIS budget is only 17% of these other budgets. So we are directly advocating for additional investments in OASIS to better support recovery services. What I mean by additional is $1 billion. God, that went so fast. Thank you.
Good evening, committee chairs Kruger and Pretlow and distinguished committee members. My name is Ji-Hoon Kim, and I am the president and CEO of In Unity Alliance, and a social worker by training. It's an honor to be here today representing more than 200 community-based organizations serving New Yorkers at risk of or living with substance use disorder and mental health conditions. Beyond advocacy, our organization provides training and is the exclusive certifying body for peer recovery credentialing in New York State. Thank you, Senator Fernandez, for your continued support and funding of our peer credentialing program. As we all know, addiction and mental health conditions are not unlike other medical conditions, such as diabetes. There are early signs, and without care, the symptoms get worse. Yet, due to persistent stigma and a lack of understanding, when untreated, these conditions jeopardize close relationships, disrupt the ability to earn a living, and even put lives at risk. While hospitals can provide short-term stabilization, for most, true recovery requires ongoing care. Without it, the cycle continues. I know this from personal experience. I was fortunate to receive care early, but not early enough to avoid multiple hospitalizations and long-term rehabilitation. I am a person in long-term recovery from a mental illness and a substance use disorder. I share this because the substance use disorder and mental health care system, despite its many challenges, saved my life. But now it is crumbling. People like me are missing their second chance. New Yorkers who need care wait months or even over a year for their first appointment, many fearing the symptoms will get worse or only being prioritized when they are in crisis. While the governor's historic $1 billion commitment to mental health was a step forward and is appreciated, existing programs are struggling to stay afloat due to years of underinvestment. They are doing everything they can, relying on a patchwork of funding to fill the gaps, and scrambling to navigate severe and persistent workforce shortages. Substance use disorder services are particularly vulnerable, as they have been largely excluded from major transformation efforts and continue to be overlooked. Multiple mental health service providers have approached us saying they would like to apply for new initiatives, but they do not have enough staff or resources. Organizations delivering core services like assertive community treatment, the ACT teams, serving the population intended to be reached by the proposed expansion of involuntary admission criteria, are voicing serious concerns about their financial sustainability. New York must invest in ongoing comprehensive funding strategies to ensure that life-saving substance use disorder and mental health services remain available to all who need them. We are calling for a 7.8% increase to get caught up with inflation, as well as an enhanced Medicaid rate and our fair share of the MCO tax revenue. The proposed 2.1% is woefully inadequate. By investing in these services, you are meeting the growing needs of New Yorkers and fostering opportunities to help tear down health inequities. I appreciate the committee's time and consideration of these requests, and I'm available to provide additional information.
You'll sing a song and I'll sing a song. We'll sing a song together. You'll sing a song and I'll sing a song in warm or wintry weather. I've been a licensed creative arts therapist for 12 years. I focus on training clinicians on the ground mobilizing art therapy after American Terror. I am the woman, the licensed creative arts therapist, who showed up in Newtown, Connecticut as a New Yorker and mobilized art therapy for the young children there. I'm here today because New York has a child and adult mental health crisis, and the state budget can help solve the problem by adding language to improve access to psychotherapy. Creative arts therapy is psychotherapy. For those most vulnerable New Yorkers who rely on Medicaid for health care, the Division of Budget has determined giving our more than 2,000 LCATs the opportunity to apply to become Medicaid providers will cost only $2 million this year, ramping up the number of therapists who can immediately fill workplace vacancies and provide already existing psychotherapeutic services. Creative arts therapy is psychotherapy. In many facilities in which we provide care already. Art therapy for children under the age of 6 with Medicaid coverage in network for LCSWs is requested countless times. Examples are given all day. You all know this, and I appreciate that. While LCSWs have no availability right now, there are countless creative arts therapists who do have openings, but we can never benefit the children in need because we have an LCAT license, and these coordinators are specifically seeking art therapy services for the littlest children in crisis, not to mention of all ages we benefit. In December of 2021, Governor Hochul assigned Law Chapter 819 that passed overwhelmingly by both the Senate and the Assembly. It allowed all mental health practitioners licensed under Article 163. Then, in 2022, Chapter 97 to specifically exclude LCATs and LPs. A chapter amendment was signed. Since 2022, the actions for licensed mental health practitioners in our state to provide desperately needed psychotherapy has only grown, especially for children and teens. If you are unaware, LCATs treat some of the hardest to reach patients, children, elderly, Very importantly, creative arts therapists are uniquely qualified to work with refugees, immigrants, non-English speakers due to the non-verbal processes. Extraordinary thanks to the efforts of Senator Samara Brook, Assemblymember Harry Bronson, and the support of many of you, including Assemblymemberman Joanne Simon. So as well as our collaborators 1199 and Northern Rivers and many, many others, we want you to know creative arts therapy is psychotherapy. And most importantly, listen, the procedure codes for billing psychotherapy is the same. Thank you.
Thank you for that testimony. That made me happy.
Brighten it up a little in here.
Art therapy is a great therapy. Wanted to allow Dr. Davis to finish your funding acts. You said we need more money. You never got to a number. If you could say that.
Yes. Thank you, Senator Fernandez. We are asking for $1 billion investment in OASIS to better support recovery services and address the growing needs of individuals in recovery.
Thank you. Can you detail how recovery is getting funded?
Currently, recovery is funded. There's a small percentage of the state aid to local localities, and then the remaining is from the opioid settlement funds, which are not, earlier today, the commissioner did talk about how those funds are time limited. So even though the funds are due to arrive to New York State over an 18-year period, currently the recovery community organizations right now were given funds last year to be dispersed for a 2-year period, which will be ending in March 2025 of this year. Some of those will be extended to June. But again, sustainability with regards to the recovery community organizations is not there.
Thank you. Senator Canzoneri Fitzpatrick did ask, like, what could be the tool, and forgive me for not word for word, but what could be the tool to get somebody to want to get treatment? My personal opinion is the peer support advocates. I've heard from many, have visited many organizations that have proven that this is a very strong tool to inspire others to take that first step into recovery. And Assemblywoman Gallagher did mention the benefits of having a supportive workplace. Can you speak on that?
Yes, well, first let me say that treatment, while we fully support treatment, all levels and all modalities of treatment. Let me be clear that treatment is episodic and recovery is lifelong. And what I mean by that is that individuals can seek treatment. We often, if individuals are looking to enter treatment, we certainly help individuals. They receive that help by going to local recovery community organizations that also help to, get people into treatment that want treatment. But we support multiple pathways of recovery. So to your point with regards to recovery-friendly workspaces and peer support specialists, we have had the opportunity to provide over 75 scholarships last year through funds from the opioid settlement funds for individuals seeking certification to become certified peer recovery advocates. New York State currently has over 3,000 certified peer recovery advocates that do remarkable work. Most of them are connected to treatment, and some of them are embedded in the recovery organizations, local recovery community organizations.
Thank you so much.
Thank you. First, I want to thank all of the speakers today. Clearly, and I think so important, and you both have said this, is that treatment is relatively short-term. Recovery is a long-term commitment. And I think that one of the things we need to do is find out ways that the state can support that, understanding that it is, in fact, a long-term recovery. Is it Dr. Davis or Ms. Davis with the LCAT? So, one of the things that I see that you pointed out was trauma recovery with children.
Yeah.
And we have more and more children who are in trauma because of violence in their community, gun violence. We are very lucky in New York that we haven't had big school shootings in the way that many other states have, but we have certainly had a lot of violence, gun violence, in many, many communities. And in some cases, in Buffalo, we had a mass shooting,
Yes.
for example. So, it strikes me that this is probably a population that most people aren't thinking about, and that creative arts therapists can actually, are like the magic key there for kids with disabilities who are nonverbal, who can't express themselves. It seems to me that this is the budget season, and if the bill last year was vetoed by the governor, we should be putting it in the budget. Do you have a sense of what the costs are of that operation?
The LCAT Advocacy Coalition was informed from the governor's office that it would cost $2 million to onboard the 2,000+ LCATs that already exist all over New York State. So that sounds fairly inexpensive to the overall budget to onboard us because we're already licensed. And we're here, we're ready to go. We are already deployed and trained.
Seems like a drop in the bucket.
And then we're onboarded. Yeah, and it's not $2 million the next year. Yeah.
Great. Thank you very much. I appreciate it, and thank you
Thank
all
you.
for your testimony.
Is there any kind of peer-recognized review of this as an effective model of therapy with children?
Yes, absolutely.
Okay, so can you get me some materials after tonight?
Yes, I'm happy to get you materials
Thank you very
that
much.
support the work. Thank you.
Thank you.
Yes.
Assembly.
Assemblyman Brown.
Thank you, Chair. Mr. Kim, how are you today?
I'm well. How are you?
Good, good. I'm sorry we haven't connected. I want to ask you, and I don't think 3 minutes is going to satisfy it, but you're uniquely positioned that you worked on the second floor and you were inside the governor's office in terms of dealing with this crisis as it really ramped up, and then as we've seen, because of a large degree because of Narcan, we're down 17%, which is great news. What do you think, being on the other side, sitting at that dais now, that you could tell us that is not in this budget that we really need to do? What's the low-hanging fruit that will help, alleviate this crisis some more?
Thank you for that question, Assemblymember Brown. And I believe we might be, our schedulers are trying to get us to meet on Monday. So hopefully we can find some time to continue this conversation. I appreciate you bringing that up. I was proud of my work on the second floor. I was the deputy secretary overseeing the entire mental hygiene portfolio. And when Governor Hochul took office, it was one of my charges to find a solution to the mental health crisis. And the $1 billion, while it goes a long way, the great majority of that $1 billion is for housing that is going to take years to materialize. So in the years since, the priorities have not been to stabilize the community-based services that actually meet the needs of the individuals that are falling through the cracks. Let me give you one example. We have members, providers. These are providers who have a lot of OMH and OASIS licensed programming and funding. And there are these ACT teams. And these ACT teams that I mentioned earlier are the teams that end up serving the individuals that are ordered through the Kendra's law to get services, right? These are outpatient services, and with Kendra's law, they are ordered by a judge to get these services. Those individuals jump the line to the front of the ACT teams. So what do you think happens when that happens? The individuals that are now on the wait list for these ACT teams, they get bumped down the pecking order because of the expansion of, the proposed expansion of Kendra's law and the existing Kendra law statute. And that actually leads to a greater need for those providers to have better funding to serve these harder to serve high acuity clients. And that's just one example. There are some other examples. I mean, it's not sexy, it's not fun, but it's bureaucratic inefficiency, right? Government takes 1 year to do something that would take a private company, a month to do. And I have a great relationship with Commissioner Sullivan, and I work very closely with her, but these funds really need to prioritize the existing community-based system and not new projects that I know are sexy to announce.
Well, thank you, and I look forward to talking with you and working with you on trying to make it less efficient.
Thank you.
More efficient, I should say. More efficient. Less inefficient. Thank you.
We got you. Yeah, we know.
Sorry.
Thank you, Mr. Chair. Just circling back on the peer support programs, could you just go through where do you think we need additional investment? What programs and what can we do with the budget? Can you just go through some of them with me?
Well, with regards to additioning program, first I would say that we really need to increase and expand the recovery community organizations that are already in the community doing the work. Many of the peers are allocated or kind of designated to work within the recovery community organizations. And so programs like that and opportunities like that allow for people to come in and work with individuals who have similar life experience. A lot of the peers have, well, many of the peers, if not all of the peers, have lived experience, which often comes, is received better than, kind of therapy or therapeutic treatment in some sort. I mean, I myself was a primary therapist for 10 years, and I will say that a lot of the breakthroughs that I had with the individuals that I work with were because of the peers, and their peers having the ability to have individuals see things from their perspective and have that opportunity. So programs like the expansion of recovery community organizations is very much needed. Some 4 years ago, we asked for a recovery community organization to be in every county in New York State. Right now, we have about 31 recovery community organizations. We have 20 youth recovery clubhouses. We have about 4 or 5 collegiate programs. That is it to service, again, the growing individuals and the growing New Yorkers of the recovery community.
So they're not in every county, though, is that what you're saying?
No, they are not. There is not a recovery community organization in every county.
Okay, that's helpful, thank you. Just one question on the creative arts therapy. What is the, what is it, I guess, what's the educational piece of it to become licensed?
I have a master's degree, and then it's a 60-credit master's course. And then we do, I think it's 3,600, I did it so long ago, I think it's 3,600 hours of clinical work, supervised.
Yeah.
So it's very rigorous. It's very rigorous. We're really well trained and we're highly skilled. And then most of us have, like on top of it, I have trauma-focused cognitive behavioral therapy under my belt. So, you know, there's a lot that goes into it, postgraduate degree also, that everyone in the art therapy and music therapy fields continue to study.
And those are all the minimum, like, educational standards you have to meet to get licensed, is that?
Yes.
Okay, all right, great, thank you.
Thank you to all of you for being here today and being patient enough to be the last group. This is for Dr. Smith-Wilson. I just wondered if right now the only way OASIS is being funded is from the opioid settlement fund. How was it funded, or how little was it funded before that was even available?
I'm sorry, correction, you said the only way that
Yeah.
the OASIS
Yeah, you
budget,
said the
overall
only
budget?
state funding available presently comes from opioid settlement fund.
Okay, so recovery services in New York State, there is a small percentage that is, even for New York, is funded by the aid to, state aid to localities.
Right.
And so there's a percentage of that. And then there are the opioid settlement funds, which service a lot of the certified peer recovery advocates, as well as some of the recovery centers. So there are additional funds that OASIS have that they also dole out for youth services that are still trickling out of the SRO funds, which are the state opioid response funds. And so there are still some discretionary funds coming through the federal government, circling through OASIS to support additional funding as well. So I stand corrected with saying that
Okay.
it is only,
Okay,
yes.
I understand. And
Okay.
then I do appreciate you shedding light on the disbursement and allocation of the funds, because that was a question I asked earlier. You know, I don't know about all the counties in the state, but I do know the district I represent is in Nassau County, and unfortunately, as many people that are struggling with addiction, recovery, families, organizations in need of that really critical funding, it's just sitting in the Nassau County executive's in his coffers. And so I really I appreciate the fact that you addressed this, and I would like to learn more about what we can do about that, because that money is so needed and so vital. And it's, to me, I was so glad when I saw that large sum of money come in a couple of years ago, and then I can't believe years have gone by and it's still sitting there. So I appreciate that. And also, this is just quickly, I also agree that I don't think enough emphasis is on recovery. A lot is on treatment, but there's so much to recovery. Quickly, you can't really say much, maybe you can email, but I'd like to know what else you could say about recovery.
Yes, absolutely. Well, first, to your point with regards to what else can be done, and I think that you can do a lot. One of the things that we're asking for, a lot of folks do not know that recovery funding, it is not permanent. It is not permanent in the OASIS budget, nor is it allocated as such. So ensuring that it is permanent and it is allocated as such would help.
Okay, thank you so much.
Hi, thank you. I am a huge fan of Friends of Recovery, and some of my most impactful lobby visits have been from your members. And I have a really strong memory of an interaction I had when I just said to them, the folks visiting me, what is it that you want and that you need? And they said workforce development. And I know from personal experience with people that I've loved and lost to addiction that one of the things that hurt them the most was coming back into the sober world and seeing that their friends had eclipsed all these these opportunities had happened for their friends that they had gotten left out of because they were in another world at that point. So I'm wondering, with these vocational services that you're building, what are some roadblocks that you're finding to having integrative care so that folks can choose a variety of employment opportunities rather than working in the recovery space alone, which is incredible, critical work, but also, limiting?
Yes, yes. Well, while we certainly encourage individuals with lived experience to enter the addiction workforce, we find them to be, it's not so much about the book knowledge. It is really that kind of lived experience that allows for individuals to be seen and heard in a way that a therapeutic environment may not provide. So I think that, to your point with regards to, not kind of pigeonholing and making individuals, go into the addiction workforce. One of the things that we do is kind of allow for individuals to go into any field that they want to. I mean, we had a very small kind of initiative with, we have a Recovery Fine Arts Festival where we encourage individuals to express their recovery in different ways. So we encourage individuals to really seek that meaningful life and their purpose, no matter where it is. But with regards to some of the barriers, obviously it could be gaps in employment. There are other issues as well. People are, they have family reunification issues. So many of the barriers that they face, I think, are not mountains. Certainly they are things that can be overcome, but probably the greatest is stigma. Stigma still exists because individuals that create legislative bodies are not informed as well with regards to how do you provide anti-stigma messages? How do you even, in your own family, encourage individuals to come forward about being in recovery?
Yeah, thank you.
Thank you so much, Chair, and thank you to this final panel for being here tonight and sticking it out with us. I certainly appreciated Ms. Porter Davis's testimony and all of you all's insight on this issue. So I have two quick questions. Wondering, of the three of you all your programs voluntary for individuals who are experiencing substance abuse use disorder? That's number one. And the second question I have is, as it relates to pre-trial diversion programs, I'm wondering if you all offer any pre-trial diversion to allow individuals that might have been caught up in the criminal legal system to be able to receive services from you all as a part of their trial, pre-trial conditions.
Thank you for that question, Assemblyman Anderson. So I represent 200 providers who do serve individuals through their outpatient programming and residential services who may have actually gotten there through an involuntary order, right? But they're not the hospitals themselves, but these are outpatient providers who the example I gave earlier in response to Assemblyman Brown's question about what needs to be fixed, it is that these rates are inadequate, and a lot of the ACT teams that the community-based organizations actually run on behalf of OMH, they provide outpatient services, but some individuals are referred there through AOT, which would be involuntary. Yeah.
Please, Dr. Wilson.
And I work on behalf of the over 30 recovery community organizations. So we, very much like Jahun, we work with them to ensure that they have the services that anyone entering the recovery center can certainly access. So most importantly, we work to make sure that whatever services that individual recovery community organization needs, that we help them to gather those services. And so a lot of the individuals, have justice related, law enforcement related, that enter those centers. A lot of them have specific groups at a lot of the recovery centers. So I would say that although we don't provide those direct services, we certainly advocate for any individual who is in recovery from substance use, mental health, or any other, we even have, eating disorders, whatever the case may be, anyone that is seeking recovery from any condition, that they have access to do that. And one of the ways that we found is that at our recovery community organizations, they address just about any type of issue an individual walks through that door.
Thank you so much.
Checking. Then I would like to thank all of you for staying with us, for agreeing to stay on the last panel. I think I'm going to officially close this hearing, but for those of us who are just hearing junkies, we'll be back here tomorrow morning, 9:30 for the transportation hearing. And if anyone is getting into a car and driving anywhere in the state of New York today or tomorrow, please be very careful. Thank you.